have scheduled the inaugural at 2 p.m. as our Honorable Minister of State, Ministry of Health and Family Welfare, Government of India, Professor S.P. Singh Baghel will join us at that time. So we shall start with the session first, which is the roadmap for making cancer care affordable and accessible in India. Today, along with the inaugural session, we have designed several panel discussions which will take us all on the transformative journey for a healthier and happier tomorrow. As we embark on the path to wellness and embrace positive changes, let's begin the first session of the day, which, as I said, is the roadmap for making cancer care affordable and accessible in India. I would now request the session chair, Ms. Indrani Kaushal, Joint Secretary, Ministry of Health and Family Welfare, Government of India, to kindly step on the dais. And along with her, may we please welcome Dr. Rajendra Toprani, Head and Neck Oncology Specialist, HCG Cancer Hospital, Dr. Monica Puri, Chief Country Access and Policy Officer, Roche Pharma, Ms. Shobha Mishra Ghosh, Director and Head, Government Affairs and Policy, India and South Asia, GE Healthcare, Mr. Vineet Gupta, Co-Lead, Ficci Task Force Cancer Care and Head Government Affairs, Siemens Healthineers, Mr. Vicky Nanda, Chief Operating Officer, Niramay, Mr. Sudhakar Merpadai, Director, Government Affairs, BD India and South Asia, and the moderator, Ms. Srimai Chakraborty, Partner Healthcare, EY Business Consulting, India. We welcome each one of you on the dais, please. Thank you. Okay, sure. Thank you, ma'am. Can we have a big round of applause for all the esteemed dignitaries on the dais, please? Thank you. Now I shall request Dr. Harsh Mahajan, Ficci Health Services Committee and Founder and Chief Radiologist, Mahajan Imaging and Labs, to present a green certificate to Ms. Indrani Kaushal. Thank you so much, sir. Thank you, ma'am. Now, without wasting a moment, I would now request the moderator, Ms. Srimai Chakraborty, Partner Healthcare, EY Business Consulting India, to take over the session, please. Thank you.
Good morning, ladies and gentlemen. Welcome to the session focused on building a roadmap for making cancer care affordable and accessible in India. We are all aware that cancer incidence in our country is growing at a rapid pace, with near 2 million cases getting diagnosed every year. The growth in new cases is also expected to be about 9% in the next few years. While new cancer cases are being diagnosed, the prevalence for this disease is also rapidly mounting. While the disease grows, there continues to be a dual challenge of suboptimal outcomes with high mortality to incidence ratio across most cancer types. Low awareness, late stage detection, skew in access to affordability and quality cancer treatment options have all contributed to this debilitating state. I would like to take this opportunity to reiterate select highlights from the Ficci Heal report on making quality cancer care accessible and affordable in India, which was released in October 2022. Number one, screening coverage in India is less than 2% across organs covered under the population based screening programs. Less than 30% of districts have comprehensive cancer centers in India. Penetration of radiation equipments is 0.4 per million population against the WHO norm of 1 per million. Shortfall exists in the number of medical oncologists to the tune of about almost 2,000 to 3,000 and surgical oncologists to almost 800 to 1,000. A single cancer hospitalization incidence exceeds the average annual expenditure of 80% of the population of the country, and almost 25 to 30% of cancer treatment expenditure is still out of pocket for patients who are insured. Over the last 1 year, Ficci Cancer Task Force, with support of the government, has been conducting regional roundtables to discuss the challenges in cancer care with regional teams comprising government representatives, clinicians, and industry, represented by healthcare providers, pharma companies, medical technology companies, diagnostic companies, and cancer support organizations and NGOs. Several recommendations have come forward, which is under consideration by the government. For example, making reporting of outcomes to evaluate effectiveness of treatment mandatory, re-evaluating customs duties for RT equipments, looking at OPD coverage for diagnostics and oral medication, making treatment guidelines mandatory at some levels to ensure compliance, having an advisory board in place which actually ensures the mandatory implementation of guidelines and monitors outcomes. It has been very exciting for us to hear during the last regional roundtable at Bangalore from representatives advising the NHA that the Health Benefit Packages 3.0 under the PMJY program is being revamped as per the advice of the expert committee to include additional advanced treatment options for cancer care. It will be imperative for state governments to adopt these packages to improve access to the common man for advanced treatment options. We look forward to more such actionable measures being taken by the government to improve access to quality cancer care for the common man. And our purpose here again today through this panel discussion is to delve deeper and come up with more brainstorm and come up with more ideas around how we can bring about recommendations in the areas of screening, diagnosis, and treatment, and make meaningful changes in the cancer care pathway. With that, I would like to welcome Ms. Indrani to give her remarks. Anywhere, wherever you're comfortable.
So good morning to all of you. This is an esteemed venue, and this is the first time I speak from the health sector perspective. In the past, to give a little background, that I worked in the oil and gas sector, so the transition from into a social sector is indeed very challenging, and that's why we look towards the industry. The stakeholder discussions will really help us, contribute to making informed policy. So I'm definitely keen to watch the progress and see how the deliberations take place over this very important topic. Today, my esteemed members on this panel, Shri Raj Gore, co-lead Ficci Task Force Cancer Care and CEO Healthcare Global Enterprises Limited. Mr. Vineet Gupta, co-lead Ficci Task Force Cancer Care. Mrs. Srimoy Chakraborty, who's from Ernst & Young Business Consulting, who authored that report on making cancer care affordable. So good afternoon, all of you. The topic we're discussing here today is making the roadmap, a roadmap for making cancer care affordable and accessible. As part of my mandate of being an economic advisor, I also publish the National Health Accounts Estimates, where we bring out the figures of out-of-pocket expenditure. And we know what cancer, the very name touches the hearts of poor families, and any family who is diagnosed as having cancer, the repercussions and the ripple effects it has on the family, and in some cases pushing the family towards the poverty. Therefore, the inputs of this report, which Ms. Srimoy authored along with Ficci and Ernst & Young, with all your inputs from the industry, are giving us the tenets to work around this issue and make policy. So let us remind ourselves that 70% of the global deaths are attributable to NCDs. India is also experiencing a rapid demographic and epidemiological transitions with steep burden of rise in lifestyle-related chronic NCDs. NCDs are estimated to account for around 63% of all deaths in India, which cardiovascular disease lead with 27% overall mortality, followed by chronic respiratory diseases and cancer, diabetes, and others. The global burden, while it's increased to around 19.3 million cases and 10 million cancer deaths, the situation in India is no different. Our prevalence of old and new cases have touched 36.52 lakhs per year, with incidence of new cases touching around 15 lakhs and mortality being 8 lakhs per year. The peculiar complicated cases of cancers which are in India, they affect from the cancers of lung, mouth, esophagus, stomach, cervical, and breast cancer, and uterus cancer. So this also, I was having a breakout session with my panelists. The extreme use of tobacco use in our Indian country, where you have chewable tobacco leading to different forms of cancer, is also probably prevalent in this part of the country. And the cancers which are there in northeastern parts of the country would vary from that being in the northern part of the country. Therefore, the prescriptions also have to take into bear in factor this wide cultural and demographically different prevalence. There are various causes of cancer. We are very well aware of tobacco use, high body mass index, the alcohol consumption, the low vegetable and fruit intake, and lack of physical activity. But why the government, on the part of government, since I'm representing, we are working on a prevention and early detection screening plan so as to ensure that the tertiary care systems, the load is not increased at the tertiary care systems. And if we are able to detect and have early screenings, that also really makes the out-of-pocket expenditure and the treatment itself at a much affordable cost, vis-a-vis that when much more it's detected at a much more advanced stage. Towards this, the government has taken various steps. We, as you're all aware, the government has been emphasizing that India is one who has 4 levels of healthcare facilities. Not only do we have our primary, secondary, tertiary, but we also have the ASHAs, and we recently, as part of the primary, we have implemented and executed health and wellness centers, which is our first port of call. So there are around 1.6 lakh health and wellness centers which are right at the doorstep of the community, which have been given the facilities for screening and detection of 3 common cancers, that is breast, cervical and uterine cancer. And this is right at the doorstep of the community, and a well-trained community health officer who is also a GNM would be available to impart this early detection to the community at large, so that they don't have to really travel and lose that daily wage in order to travel to the district hospital to get that facility. So CHO is the new cadre, which is so to speak, available for cancer screenings, and that too at population-based screening at large. Our national program, which is there for cancer, for non-communicable diseases, national program NP-NCD, mandates population-based screening for anybody above 30. So towards that, we have also, we used to have this India Hypertension Control Initiative, and we had a separate app which was CPC CHS. Now the two have been integrated and made digitally a much more one-stop application, which is called the NCD application, and which has been integrated into the Health and Wellness Centers app. So any any patient of that category who walks into a health and wellness center, the CHO will update all the records. We'll have line listed data for such patients, and therefore that follow-up after the 5-year mandatory period, all their details will be entered, and whether they are, their screenings and whether they require further follow-up in terms of the continuum of care is digitally available, and we'll be able to use this data for further medical and clinical investigations. The government has not only worked on increasing the prevention, but we also, as part of our tertiary care, we are setting up a tertiary cancer care institute. So we have the state tertiary care centers as well as at the regional cancer care centers. And besides that, we're also looking at day care centers for chemotherapy imparting. Apart from the SCIs and the district cardiac care centers, we also recently launched the National Cancer Care Institute at Jhajjar, which is a 710 patient bed, which is supposed to be the premier institute for research. We also, the government also has set up a second campus of Chittaranjan Cancer Care Institute at Kolkata, which is a 460-bedded hospital, state-of-the-art, which started its IPD since August 2021 and already had their OPD running. These are institutes and which are actually, advancing, giving advanced state-of-the-art cancer care to the patients and the community at the tertiary level. From the primary level, the health and wellness centers and the district cancer care centers will be attacking, whereas these would be more in the range of the tertiary care institutes. So under the NP-NCD, screening, diagnosis, and treatment of cancer are provided at various government healthcare delivery systems, which also includes the subcenter, primary health center, community health center, and district hospital, besides the medical colleges and the tertiary care institutions which I spoke of. Under NP-NCD, we have opened 744 district NCD clinics, 6,220 CHC NCD clinics, 355 daycare centers also. The national NCD portal is being used for implementation of the population-based screening, along with prevention, control, and management of the common NCDs. This will actually aid setting up a longitudinal health record. So I will not only be able to know if the lady who is walked in, who is a pregnant woman and going for delivery, already is suffering from not only maybe she may be already suffering from some form of cancer, but also whether she suffers from any other. She's a BP patient, so one has to be, she's a diabetic patient. So this NCD app will also ensure that it integrates into the ABDM ecosystem and will give you a longitudinal health record. The government, recognizing that cancer is a public good, so in no way the government, cannot really, being public good, we have to involve the entire stakeholders, and we look towards not only the government setting these, making available the public good in the desired quantity. There, the role of the entire stakeholder, that is why a national multi-sectoral action plan for the non-communicable diseases was also set up, where we look towards making health everybody's business. If the ordinary citizen is, informed that health is a decision, avail health, that education, the advocacy and the education has to come through not only our sister line ministries, but also industry plays an equally important role. The FSSI has its equal role to emphasize, low salt and the kind of unadulterated and less of trans fats. This regulation has to be coming from the entire stakeholder community, where we look towards your industry participation also. Under the aegis of our PMSSY, we are setting up 22 new aims. Already super specialties are envisaged under these new 22 aims, and there will be state-of-the-art cancer treatment facility, which is going to come in the future days. These aims will be provided with the state-of-the-art diagnostic, medical, as well as surgical care facilities. And NCD treatment facilities have also been created and planned in 13 state medical colleges, which are being taken up for upgradation under PMSSY. Under PMJ, which is the Pradhan Mantri Jan Arogya Yojana, which provides healthcare insurance cover of 5 lakh per family per year for secondary and tertiary care, hospitalization to over 60 crore beneficiaries. The latest health benefit package, which is that of 2022 vintage, has around 1,121 treatment packages, comprising 1949 procedures across 27 specialties. It's also important to note that 91 surgical oncology, 288 medical oncology, and 53 radiation oncology related procedures have also been added in the latest HPV 2022. We would be welcome for comments when the next, when the consultation rounds open for the next health benefit package, because I understand a number of industry have expressed that they have their wish list to add procedures and also to revisit the rates therein. In order to address the issue of increasing cancer burden in the states, the government on its part has examined different models, and the Assam and Tata Trust, that step-down cancer care model was found to be a very innovative model, where we have 3 levels of cancer care institutions, with level 1 being the State Cancer Institute located in Guwahati, 5 level 2 institutions at Dibrugarh, Barpeta, Silchar, Dipu, and Dhubri, 11 L3 level institutes at Lakhimpur, Tejpur, Jorhat, Mangalday, Kokrajhar, Naya Gaon, Nalbari, Golaghat, Goalpada, Tinsukia, and Shipsagar. Now, this 3 tired Cancer Care Institute have been propagated, and Tata Trust is also working for training the nursing community in order to provide the specialized cancer care. So this is a model which we have urged various other states to explore and see for suitable adoption as per their culturally and their state-specific suitabilities. On the on the aspect of making cancer care affordable, we have opened up many Pradhan Mantri Jan Aushadhi Kendras, which definitely are providing cancer care drugs at a much more reasonable price vis-a-vis the market price. A total of 9,995 Jan Aushadhi Kendras have been set up, and more than 1,800 drugs, including 50 anti-cancer and oncology medicines and 285 surgicals and consumables, are currently included in the product basket of PMBJP, which is the Pradhan Mantri Bharatiya Jan Aushadhi Pariyojana. There are also, in order to supplement this initiative, there is also the Amrit Pharmacy, which is affordable medicines and reliable implants for treatment. This has been launched by the ministry on 15th of November 2015, that aims to provide affordable life-saving medicines and other drugs and medical disposables for treatment of cancer. Presently, there are 285 Amrit pharmacies across 28 states selling more than 5,200 drugs, which include cardiovascular, cancer, diabetes, and stents, implants, surgical disposables at a significant discount, up to 50% on market rates. While we will hear many aspects of these will be raised during the panel discussions which we open up, what we need to recognize is that so my closing remarks would be that cancer care being a public good, pure market mechanisms cannot be merely adequate to deliver such a public good. And how to fund cancer care for the most vulnerable populations is what we expect today's deliberations to give us some headway. With this, I hand it over back to you, Srimay. Thank you for patient listening.
Thank you so much, ma'am, for sharing those insights with us. And with that, we commence the panel session for today. My first point and question is to Dr. Monica Puri, Chief Country Access and Policy Officer, Roche Products India Private Limited. And I think this is a point which we have been debating over the course of the last 1 year. But the point here, Doctor, is that government efforts are in place, but it's a little gradual when it comes to including the modern treatment options in the UHC scheme. What we also see today that 2 out of 3 cancer treatment from a chemo drug perspective is oral and can be prescribed in the OP setting, but is not covered in any form of insurance given that it is from the OP setting. And especially in a country where we talked about medical oncologists being in shortfall, these kind of treatment regimens are very convenient to be administered even in remote areas under remote supervision. So given this as a context, I just wanted to hear from you in terms of specifically what are the deep challenges in inclusion of advanced treatment options in insurance programs, both public and private, and what alternate forms of financing can we look to address some of these barriers?
Thank you, Srimay, for this pertinent question. I think I would like to start from mentioning that when we talk about insurance, when we talk about affordability, what do we really mean by solving for? Because healthcare, even as of today, is seen as a cost and not an investment. And I say this because whenever there's a question of, what is needed, do we really even take into account what does a patient really need? What does a society can bring for the patient? What does the doctor really want for his patient? And what is the government providing for the patient? I think only when we bring all these perspectives together, that's when we know what is the right treatment for that patient. And then comes the question that if that is the right treatment for the patient, how do we make that treatment affordable and accessible for that patient? So most of the time, when we look at solving for affordability, the question is about, are we willing to pay? And then the question is, do we have the ability to pay? Because either we are solving for the ability to pay by saying, okay, we will probably invest this much additional percentage of GDP on healthcare, Or otherwise, we are thinking about, I have this additional budget to pay for healthcare, but do I really want to put it for healthcare or not? So there comes a question then, if I have to. And when I say I or we, I'm not talking about private sector, because maybe I'm sitting here representing Roche as a multinational pharma company, but I do come from the background of being a doctor myself and serving in the most, rural settings of India. So I've seen those access challenges from all corners. And that is why I'm saying, in the end, patient gets what either government decides as a health beneficiary package or what the private sector can provide as an insurance package. So my question goes back in terms of whether we really want to invest in health or we see that as a cost for health. Now, in terms of how do we really set up our reimbursement packages, I think it is very important to understand, as much as we are at the cusp of being the pharmacy of the world, have the best of class treatment. And I really, really appreciate government, because in 2018 we came up with this ambitious Pradhan Mantri Jan Arogya Yojana, which is the Ayushman Bharat. We have made many strides in terms of covering for more than 45% of India's population. It's the biggest national health insurance program in the world. Having said that, we need to move now to the next level of excellence, which means we provide the best of the health beneficiary packages, which should be done in consensus with doctors, with payers, with providers. That means we need to have robust, inclusive, predictable evaluation framework for health technology assessment. Only then we will be really able to assess the value of the treatment we want to bring for the patient. Only then we can have the most affordable and the righteous packages, health beneficiary packages for the patient. And what needs to be done? We need to have public private partnership. We need to come together and solve for this. Government cannot do it alone. Private sector cannot do it alone. Doctors cannot do it alone. Patients cannot do it alone. So we need to have this broader framework of inclusiveness where all the stakeholders can come together, bring their perspective, what is the value for the patient, society, and for the payer, and come to this inclusive framework for reimbursement assessment. Having said that, what I would also like to mention that innovation, and you mentioned specifically about oral chemotherapies. I mean, we're proud to have one in our own kitty as well. I think the challenge is that we have to move the dialogue from just pricing to value. And we can really look at outcome-based agreements. We can look at special managed entry agreements in consensus with government, with the value that a drug brings can be tied up to the outcome that the drug brings for the patient. So we need to move from that model of paying as price as the only barrier to a model where we start to talk about value for the patient and the society and the cost effectiveness that that molecule brings for the patient. Thank you.
Thank you, Doctor. Just a follow-on question in terms of the fact that the environment is also very, I would say, lucrative at this point of time to look at India as moving forward in the clinical trial space. We do a lot of phase 4 trials, but not so much phase 3. If I look at the landscape of all different types of pharma companies which are there. So what barriers are there for India to move forward in the clinical trials journey? Because that also will provide greater access to the patients for more advanced treatment options.
You may be hearing a lot of facts today, but this is just the beginning of the day. But let me throw some figures at you, and which is India hosts 17% of world's population. We also have 20% of global disease burden. But if you look at our participation in global clinical trials, it's less than 4%. Till the time we do not see ourselves participating more in the global clinical trial, where you have at least 17% of the world's population sort of included in terms of looking at genomic profiling, in terms of what does it mean as a new therapy meant for the Asian population, we will not be able to have the right treatment, because the more details that you go into the understanding the genomic profile, the ethnicity, the immunogenicity of a particular population, you will be able to cater to better treatment for that population. So I think one clear ask is that we need to have more participation in the global clinical trial. We need to have India represented better in this global clinical trial, because at the same time, the number of trials is less than 4%, but the number of investigators in India have really moved by 80% in last 5 years. So we have the wherewithal, we have the efficiency to do that, but we need to be better represented. I think the second thing we also need to look at is upgrading our clinical trial research facilities. I say this because we've looked into many states in India. There's enough of expertise available in setting up clinical research observatories as well, CROs as well. But the problem is that the infrastructure needs to be upgraded. We need to make clinical trial or investigations as part of even postgraduate curriculum, that more and more MD students or consultants should be initiating those clinical trials. While they would love to do that, we need to give them that infrastructure as well to do that, which means we need to look at clinical trial excellence project. And I can say proudly that we've very recently collaborated with 10 of the government institutions in India to really upgrade the clinical trial facility in these hospitals. I mean, just last week we did it with Kalyan Singh Center, specialty center in Uttar Pradesh as well, to drive excellence in clinical research and by boosting, existing capabilities for conducting those trials. So better participation, better infrastructure, better representation of Asian population, and that's only when you don't need to do phase 4 as well, and phase 3 will be good enough for Indian population within India as itself. Thank you.
Thank you, Dr. Puri. And I think some of the insights around the mindset shift from cost to investment, a lot more consensus, especially on the design of the packages. I think these are very valuable inputs and will go forward in building out the recommendations. My next question is to Mr. Vineet Gupta, co-lead Ficci Task Force Cancer Care and Director Government Affairs, Variant Medical Systems. So, Mr. Vineet, we've talked about very specific issues around affordability or access, but I think the larger frame, which is the frame for a national policy for cancer care and control. In your view, what should be the how should that journey be embarked upon? And again, if you have learnings from any other disease control programs which we faced in the past, what could be some of those learnings which could be emulated?
Thank you, Srimati. I think cancer as a disease, I think it can be defined as a pandemic in the country. Considering the numbers, the new cases every year, almost about 1.5 million, and considering the number of deaths, it is, I mean, everybody in the room, I'm sure, would have known someone in the family, close circle, friends who have been diagnosed with cancer, or maybe, So the challenges are huge. And I think I want to thank here Ficci that sometime towards the end of December 21, considering the challenges around cancer care in the country and the affordability and access to the facilities for cancer care, this cancer care task force was formed. And EY took a lead in coming up with a white paper, which was unveiled last year here at Ficci Heal itself. However, through this cancer care task force, we wish to urge to the government here, that no doubt the government is doing a lot of things in terms of creating the overall infrastructure, right from, early diagnosis, screening to tertiary care facilities. However, majority of these efforts are being done in silos. There is no consolidated platform where all these efforts can be brought in together and then from there on monitored and implemented accordingly. We from the Ficci Cancer Care Task Force sincerely believe that creation of a nodal agency for cancer care with defined objectives is something government can look at. The objectives could be awareness and prevention with a strong focus on linkage to care. To ensure sustained and equitable access to diagnosis and treatment facilities for cancer patients is something which this nodal agency can be responsible for. We have seen a great success in terms of NACO, which, towards the mid 80s, late 80s, and early 90s, when it was formed for addressing the HIV burden in the country. So, on similar lines, if the government can consider a nodal agency for consolidating whatever efforts the government is doing on a single platform. The nodal agency can be then responsible for strengthening the cancer information system and surveillance to monitor the program and to evaluate the outcome of cancer control actions. It can also be responsible for promoting the professional education of doctors, nurses, technicians, and health workers to augment trained human resources. It can promote research and utilization of its findings for prevention and control of cancers. The programs like NPCDCS, they do exist with a focus on both prevention and screening, as well as upgrading the infrastructure under tertiary cancer care centers or maybe state cancer institutes. However, if we look at all these efforts through a harmonized approach, and the allocation of resources then takes place to address these gaps, I think we can be more effective in addressing the cancer care as a burden. Technology can always play a crucial role with provision of comprehensive cancer care throughout the country by networking and improving the infrastructure and the resources. Models such as hub and spoke may be considered to ensure optimal utilization of resources with the available of services. I think there are multitude of regulations also currently which impact the spaces of drugs and devices for both diagnosis and treatment. A nodal agency can possibly make it easier for a holistic approach on cancer care, formulating regulations with a focus on patients. A detailed mapping to identify region-wise cancer care burden, common types of cancer, and the existing facilities to manage them can be a starting point for the nodal agency. And lastly, I would say the data availability and aggregation at the national level can provide the required picture of the real cancer burden and planning of policy interventions accordingly. I think today the government all needs to do is consolidate the efforts to possibly, the challenge is that the policies are made at the central government level, whereas the implementation, right from screening to diagnosis to procurement of technology, etc., is left with the state governments. Now, the capabilities, if I don't know what is the right word, but then, not every state has the wherewithal to do everything in a sustainable manner. And then they look to certain models in the country, maybe a DMC or maybe an Assam Cancer Care Foundation model. However, the implementation of those things, we need to, somewhere decide that how we can unify the implementation of all those policies which we are making at the central government level, and basis on which we can see a sustainable efforts and the results out of all those efforts. I think. Thank you very much.
Thanks a lot, Vineet, for your inputs around the nodal agency creation. We'll now move on to Dr. Rajendra Toprani, head and neck oncology specialist from HCG Cancer Hospital. So, Doctor, a very important question from to you is that we have looked at, we have talked about affordability, we have talked about access, and we have also seen new models coming up, whether it is hub and spoke model, remote care, day care, etc. But what, in your view, is very, very critical in terms of the right model for ensuring that there is greater access to treatment for patients in the country?
So, thank you, Srivai. At the outset, I would like to thank you all, the whole Ficci team, to have invited me as a clinician. I'm the only odd person out on this panel. All the rest all are the people from the industry. I'm the only clinician on this panel. I'm also the president of Indian Association of Surgical Oncology, which is the premier surgical oncology body in this country. But you all will be surprised to know that there are only 2,000 members for this IASO, Indian Association of Surgical Oncology. So just to begin with, I can give an oration on this topic about the cancer disparities and the action to be taken from the policymakers or the stakeholders, whoever are involved. But as time is limited, I'll just give a very focused answer. First of all, we must understand the grievousness of the situation that we are facing. We must know the enemy that we are going to fight. As far as the Globocan report, 22 million have been reported for this year. Am I correct? Cancer cases?
That's the estimate, doctor.
Correct. So, does everybody think that that's a correct figure that we are facing? No, I don't think so. So, the first problem lies in the reporting. There is a very poor system of reporting in our country. We must get our data correct. We must develop strong population-based registries, and all the stakeholders, including all the state governments, they have to mandatorily have a population-based registry. That is the first step to begin with. The second step, I would say, that's when you get to know the data and the common cancers in particular geographical regions of this country. India is a big country. In Northeast, you see lung and esophageal cancer. In South, you see more of stomach cancer. In the Western part, you see more of oral cancers. Breast and cervical is spread all around. The second part is to understand what kind of cancers that we are going to face in this country. What works in the West doesn't work in India. The guidelines that we are quoting, most of the NCCN guidelines come from the West. This won't work in this country. Oral cancer is the national cancer of this country, which the Western countries hardly see this. And the guidelines are absolutely not going to work in our country. So we need to understand what cancers we are facing. And according to the cancers, we need to have our manpower training. We need to focus on those cancers, and we need to address those cancers on priority. Coming to the manpower, as I told, there are only 2,000 members of IASO, and we are falling short of, you also quoted around 2,000 or 3,000 surgical oncologists. Now, as the population ages, by next 20 years, this number is going to double. And the gap between the requirement of the manpower is going to increase. So how are we tackling that issue? We have only 250 seats for training of surgical oncology in this country. And that's very inadequate. We need to increase the training of surgical oncologists who are the core to treat the solid tumors. For almost 80% of the solid tumors can be treated by a surgical oncologist alone. So we need to focus on those training. Now, why this disparity? You must understand, a radiation oncologist gets his radiation oncology degree in 3 years post his MBBS course, while a surgical oncologist does 3 years of general surgery post his MBBS, and then another 3 years of surgical oncology, and then an organ-specific fellowship, and then he qualifies to become an organ-specific surgical oncologist to practice in a metro city. So it takes 11 and a half years, 12 years. I'm not even addressing the gaps that nowadays students have to, sort of face because of these NEET exams. This whole training program needs to be changed entirely. Whoever is a policymaker, the NMC or whoever, needs to really do a brainstorming on this training program so as to not to discourage the surgical oncologists to undergo this training pathway. Nobody wants to wait for 12 years. The third thing is, there are a lot of shortages for the nurses as well, the technicians. We talk about the technology. We talk about the technology going to the rural areas. But who is going to run the machines? Who is going to run the diagnostic centers? We need nurses, we need technicians. We can train those technicians and the nurses to be the first contact for the diagnosis of these patients. And there can be a pyramid model. The top cannot be heavy. the basic infrastructure for the healthcare has to be strong enough so as to not to overload the tertiary care cancer centers. I mean, that is common sense, but that's not happening. And that is what we need to figure out first. Again, for cancers, we need to understand that there are some preventable cancers. For example, oral cancers. All tobacco related cancers are preventable. And you need to focus strategies to prevent these cancers. This has to be given utmost priority. Cervical cancers, for example. You need to create awareness amongst females to vaccinate their girls, to vaccinate young girls. And this is preventable to an extent. But that awareness has to be brought out through media, through government agencies, through so many other agencies also. Targeted screening, yes, we need to focus on certain cancers for targeted screening. For example, prostate, cervical cancers, and breast cancers. You don't need any fancy technology to detect breast cancer in an early stage. You just need to train the females to do self-breast examination. That's all. They need to undergo mammography at regular intervals after the age of 45 or 50. A simple pap smear is enough to diagnose cervical cancer. That can be done by a trained nurse. For prostate, a simple blood test like a PSA is enough to diagnose prostatic cancer. Now, cancer is a taboo in our country still. This is not openly discussed, even in social circles. You need to create awareness. You need to create awareness for a certain age of people to undergo targeted screening for certain common cancers, which can be diagnosed without undergoing a list of tests. The registry part is the one that I focused on, is very important for us to get this data. Once you get this data correct, the rest of the things will fall into place. The diagnostic centers in the peripheries, it is very important that the patients undergo some basic diagnosis before, basic investigations before they are being referred to a tertiary care center. Everybody doesn't need to come to the AIMS. So many cancers can be treated at district levels. I believe now so many medical colleges are opened up in district places. And these all medical colleges should have a surgical oncology department so that all these cancers can be diagnosed and treated, majority of them who don't require complex or unusual operations to be referred to tertiary care centers. And this will decrease the load on the tertiary care centers and allow them to focus on the most complicated and technically demanding operations. So this is what is the hub and spoke model. This is the pyramid system that we should follow. The corporate sector can certainly help the government and try to develop these surgical divisions in all these medical colleges. We can train the nurses, we can train the general surgeons to tackle the cancer cases. And there is so many things that we can do. Even at the level of our association, we can impart education and training to the general surgeons with a big population. There are a lot of general surgeons in this country and who can take care of these common cancers if they are treated well. So we must identify who is going to treat cancers. So there has to be guideline-based treatment policies in this country. So the guidelines could be an ideal guideline and an optimal guideline. If you cannot treat the patient with these optimal guidelines, you should not be treating these patients. That's the period. You have to refer these patients, and that is to improve their outcomes. The outcomes will only improve if the patients are being treated with optimal guidelines. But who will implement them? That is the question. The NCG, the National Cancer Grid, has made an attempt to develop guidelines, but implementing those guidelines is challenging. So these are the challenges we are going to face, and we have to, rise above everything else. And there has to be a partnership between the government and the corporate sector to join hands and develop this hub and spoke model to decrease the burden on the government alone. That's all what I want to say today. Thank you.
Thank you, Doctor. Thank you for this very comprehensive view, which covered all aspects, starting from awareness to treatment, as well as the creation of data for cancer. My next question is to Mr. Vicky Nanda, Chief Operating Officer, Tinamay. And we have been talking about this topic of screening in quite a lot of detail. In this context, would just want to hear your perspective on how low-cost point-of-care devices are actually changing the paradigm of screening in India, and what more needs to be done to scale this up, at a nationwide level, such that we can take screening penetration much higher.
Yeah, thank you so much, Mr. May, for the question. See, first of all, we need to understand the impact of these numbers. We are talking about screening uptake at 5%. Now, what is the impact? Let me talk about, let me take an example in, let's say, in a breast cancer's statistics perspective. Less than 2% women take annual health checkup when it comes to breast health. Now, the impact is 96% of the women reaches tertiary care at late stages. I think we need to also understand what is happening because of the low uptake. Now, the question is quite relevant, how we can improve this uptake. How can we bring innovative emerging technologies, point of care technologies, which can be provided at population level, which can be deployed at primary health center level, so that we can change this uptake from 5% to a higher number. In Western world, the uptake is very high. We are not even at par. Now, to bring this, what we have done at Niramai is, just let me bring some context. We have developed a new solution, a new test for detecting breast cancer at early stages. It's a simple test which uses thermal scan, and then there is a software medical device which basically interprets these thermal images to detect whether there is breast abnormality. Now, this is a portable solution. Now, using such kind of portable devices, you can either place these devices in community health centers, or you can do population-based screening programs. You can also screen targeted screening, like sir was talking about. We can also deploy a version of these devices maybe at primary health centers. Now, what this will do is, this will definitely create a good amount of nudge among the communities, so that they can take up annual health screenings regularly, which is very important to change the entire impact and overall accessibility. So that's my take on, in terms of how we can change the shift from a lower uptake to a higher uptake and increase the screening pool. If the screening pool is increased, automatically the early detection happens and the care pathways can take care of that. Now, you asked the question with respect to scaling up. I think it is important that when we are talking about scaling up these technologies, we should consider government partnerships, because this is where the scale will come. But more importantly, we need to see how these partnerships can be sustainable, which is very important to ensure that it continues. So that's my take in terms of, and that's the kind of back to you, Shimei.
Yes, and just follow on that, Mr. Nanda. While doing screening itself is critical, but we also need to take care of the referral pathways. How do we have, and you talked about government partnerships, how can it be made much more comprehensive, such that there is complete responsibility, not just to screen, but also to address the referral pathway barriers?
Right. I think this is a very relevant question, because, and the most important question, because we can't just screen people, find suspect, and leave the suspect. We need to have a proper care pathway for that particular suspect. And unfortunately, given our experience, we have done like projects in multiple states using our device. We have been able to solve the initial problem, that is identification of the initial suspect. But what happens thereafter is unfortunately, it is not integrated, if not broken. So we need efforts, both digitally as well as physically, maybe to counsel the suspect, so that the suspect can take up the advanced investigations, and we can track those investigations and track the suspect and bring the suspect for advanced investigations, and then, if required, if it is positive, then go for treatment as well. So this is very important. It has to be, if I can say, a phygital approach where we can combine the efforts, track these suspects, and bring them to care.
Sure. Thank you, Mr. Nanda. We'll now move on to Ms. Shubha Mishra Ghosh, Director and Head, Government Affairs and Policy, India and South Asia, GE Healthcare. So, ma'am, the role of diagnostics in cancer treatment is increasing, and we still see it being underpenetrated in the Indian context. So, here, the first question which we wanted to hear from you in terms of responses: how have you seen PPPs specifically in cancer-related diagnostics work in the Indian context, and what learnings are there from that, and what could be done better?
Thank you, Shrimay, and thank you, Ficci, for inviting me. I wanted to start my comment with a comment which is written out there in the back of the hall, where, ma'am, you said cancer is a public good. But at the fourth AGM, Mahatma Gandhi had said that industry should regard themselves as the trustee and servants of the poor. So with that spirit, let me start my comment. We have heard a lot of deficiencies in infrastructure and skill gap. Dr. Toprani mentioned, ma'am, you did mention about all the interventions that government is taking. But the ground reality, when you look at the diagnostic facilities that are available for 1.4 billion population, and where one data, I think it was either McKinsey or something, where it kind of predicted that 1 in every 9 person is likely to get cancer. If that is the kind of level of disease burden that we are looking at, we have only 2,700 mammograms. And you mentioned about 2% women doing screening, but there are only 2,700 mammograms installed in our country, which is 5% of installations in the US. When we look at cancer care centers with high-end technologies like PET CTs, etc., it's only 30% of our cancer centers that have. And only 15 to 20% of cancer patients undergo any kind of radiation therapy, which is when you compare to the global rate, it is 60 to 65%. And similarly, it's only about 30 to 35% who undergo surgery, which globally is about 40 to 50%. Now, the challenge is not just capital expenses that we have, but also operational challenges as well as expenses of running a center. Now, for example, if you look at the skill deficiencies, we have only 30 medical colleges with 100 seats for nuclear medicine specialty. And when we look at the PET service providers, there are only about 19 centers that have cyclotrons for isotopes, and that is because there is no lack of air connectivity. Those isotopes have to be delivered within 3 to 4 hours. So these are the challenges that we are looking at, and we are kind of up against. So obviously there is a huge requirement for immediate reforms in medical education, in as Vinny said, integration of various schemes that we are running both at the central and the state level. Now, National Health Policy 2017 actually came up with this idea of public-private partnerships, particularly for diagnostics, for dialysis, for blood services, and so on and so forth. And what we have seen is that because about almost 75 to 80% of healthcare providers and clinicians are in the private sector, particularly in the cities. So Health Policy 2017 actually highlighted that we should go for public-private partnerships in the area of diagnostics, and we have seen that increasing. And Wipro GE Healthcare is actually in the forefront, where we have about 350 PPPs running across 25 states. However, there are only 8 working centers for molecular imaging and nuclear medicine. I mean, I'm sure Siemens may be doing some and all, but then those numbers are extremely dismal. And as we were talking, ma'am, that states like Tamil Nadu, Bihar, Assam, Odisha, Rajasthan, they have recognized that the need for public-private partnership. And what a technology company like us does is that we provide the techno-commercial inputs to the government. We bring a help or recommend healthcare providers or diagnostic providers who can set up those facilities. And we obviously supply the equipments and also train the technicians who will be running these centers. In the last couple of years, we have gone to these particular states with, as sir mentioned about hub and spoke centers. And when you look at from the diagnostic perspective, what we have been propagating is that hub should be a comprehensive cancer care facility that includes radiology, medical, surgical, and diagnostic oncology, and therefore they need to have all the high-end diagnostic equipments like the PET CT, the mammogram, gamma camera, Linacs, etc. Whereas spokes can be asset-light daycare centers that can be spread across the districts, and they should be basically for screening, lab tests, biopsy facilities, and referral base should be there in the spokes. Here you need to equip them with equipments like MRI, CT, ultrasound, and so on and so forth. Currently, PPP programs have certain challenges. And I think the biggest one is that probably the mutual trust and respect is missing, which probably, and that as Ficci, we have been telling it, for a number of years, that the public sector, the government, that is high, it should not be a vendor relationship. It should be more of a collaboration or partnership. Secondly, we have also seen that timely reimbursements. Now, most of the states actually, many of them have. So how does it work? There are free diagnostic, treatment, surgical, and palliative care. Some of the state health insurance cover. PMJ covers the inpatient treatment. However, and then there are second level of treatment where private and public health insurance patients are treated. And then, of course, there are some states that who do not have any insurance cover. They are given 10% discounts. And in many states, they have a copay system also where 80% is free treatment and 20% is, So most of the private sector providers that partner with states, they are given reimbursement for these kind of services that are provided. And we have seen that many states actually go back in the pricing of the care packages. And that impacts the financial viability of these providers, particularly when it is in a tier 2, tier 3 setups. And also, what is the need of need is viability gap funding, which is required to for setting up radiology centers in these tier 2, tier 3 cities. So on the PPP front, this is what our recommendation is that the government needs to.
Sure. And what about also the focus on local manufacturing for diagnostics, which can also have an important cost impact?
Yes. So so a lot of, as a company, we have been doing a lot of innovations, where we actually look at the medical imaging, we look at the, clinical data that is available and data analytics, and we come up with a lot of solutions that are integrated with these medical equipments. government has actually come up with a lot of like the production linked incentive scheme, which promotes and tries to attract investments into manufacturing of medical devices. They are setting up medical parks so that again the basic facilities can be given to the domestic manufacturers. In India, the import dependency in medical devices is almost, especially when you look at the high-end imaging technology, which is used for cancer care, is almost to the tune of 86 to 90%. And therefore, PLI, incentives to set up manufacturing for these kind of high-end medical equipment is a very, very welcome initiative. However, the uptake of these PLI schemes is still very, very dismal, because the way the scheme is charted out, there are very few MNCs who have come forward, and there are very few domestic manufacturers who can afford to, meet those kind of guidelines which are there. There are about 21 companies who are setting up under this scheme. What the government needs to do is, medical technology was not within the regulation, a couple of years back, and now suddenly they have put under regulatory, which is a very good thing. So the quality of medical equipment that will be manufactured in the country or being imported from outside will be, of high quality. However, there is a need for predictable policy and regulatory environment. Most of the time, manufacturing doesn't happen in the country because of the inverted regulatory structures or inverted duty structures, where the raw material import is expensive than actually the finished good. So those kind of policies need to be identified and corrected. Regulation is a good thing, but then since it's a nascent industry, a transition time for adoption of regulation is also extremely important. And it also brings in ease of doing business that will attract investments into the country. And of course, incentives, for exports is also important.
Thank you, ma'am, for that. We now come to Mr. Sudhakar Maipare, Director, Regulatory and Government Affairs, South Asia, BD, India and South Asia. So, Mr. Sudhakar, my question to you is, in your view, how should the National Cancer Control Program evolve over the next few years to address the challenges in cancer care? And again, how would the government take a decision with respect to investment priority, prevention versus cure?
Yeah. Thank you, Ficci, and thank you, Shimani. After hearing the significant statistics from the experts, and it's very evident there is a big gap. Even today, the National Cancer Control Program has a 5-stage. I think we all know there is a structured investment is available. Whether it is inadequate or not, it can be debated, like the recognition of new regional centers. The government proposes some 5 crore, strengthening of existing regional centers, 3 crores investment, and development of with the development of the new regional centers, some 90 lakhs, and decentralized NGO scheme 8,000. With the statistics, as it's very clear, 8 lakhs people per annum getting affected in cancer, and it is going as per the statistics, I think 14 lakhs. And it's if the papers published clearly says 5x expansion in the people getting affected. So these investments are focused government. The focused ideas of the government will be completely inadequate. So it cannot come going by the availability of funds at central and state. It cannot suddenly come. So the best way is, one is the PPP program, as my colleagues suggested. Second way is have a centralized ecosystem where people, simple, I'll give an example. In a supply chain, if we cannot get one part from one particular state, we immediately resource from other state and make it happen in an engineering, manufacturing. Same way, if one hospital is inadequate, we cannot go on creating another hospital, regional center, etc. It will take time. Can we have connected care where that person who is affected are the patients who was expertise? He is telling only 2,000 experts are there. It cannot become 4,000 in next 10 years. So the best way is to have a centralized repository where medicines, regional equipments can be, diverted, and where the patients can be referred. That's the only way we can handle. Otherwise, in next 5 years, the amount of government-focused budgeted registry is highly inadequate. Secondly, how it should be in a change, it is not going to change immediately. What we suggest from the industry is scan and treat. As Vicky said, there are people who are getting scanned. Afterward, they never come back. Either economies of scale or they have other taboo. No, anyway, I don't have another. Left with few years of life. Why should I go, etc., etc. So we should have a scan and treat program where government should focus. Anywhere in India, somebody is scanned. That repository should be available. The person can be chased. How can we help him? Support, etc., etc. And last but not the least, this is not going to close because it's going to increase with the population is going to become old age in next 20-25 years. So we need more of centers. So I think my suggestion from the industry is, first of all, new technologies keep coming. Suppose as say Shobha said, the regulatory mechanism to get an approval and get the assessment from the government to implement, it takes time. For example, somebody wants to today get an ICMR clearance for the new therapy in TB or cervical cancer. It takes a host of 1 year, 1.5 years. So can we afford that? So we need to have a fast track approval process, which happened during COVID. The new vaccines came, and so that is the one way of looking. Can we reach the new technology as fastest track, either in the private sector or the government sector? So over to you, back. Thank you.
Thank you, Mr. Sudhakar, for that. And I think that brings us to the close of the panel discussion. And I would like Mr. Vineet to share a few inputs before we go on to the closing remarks.
Yeah, thank you, Srimai. And Madam, before we request for your closing remarks, one last comment which I would like to share here is that we strongly believe that whatever we discuss should be implementable. So I think a centralized nodal agency will surely provide a platform for the continuity of the policy framing as well as their implementation. So we from Cancer Care Task Force of Ficci strongly urge that if government can consider, on our suggestions, on our points, we'll be sincerely thankful to you, and we look forward to your closing remarks now.
Thank you, my co-panelists. It's been a very enriching discussion from each and every stakeholder from the Varian, Siemens. We have the co-lead of the Cancer Care Task Force, and also we have, of course, Dr. Toprani, who's bringing the clinical perspective also into view. If I could quickly, the key takeaways which I got.
Further, the referral stage, that only going to release the capacity in the system and expedite the process of pushing the patient from a first consultation to diagnosis to the care to the treatment without this affecting patient in attending too many OPDs or face the diagnosis delay or the specialist non-availability. So just thought to put that comment across.
I have a question. Thank you. We actually need to move on to the subsequent session, so maybe we can respond to the questions slightly later. Thank you so much.
Thank you.
Thank you very much, moderator ma'am and the panelists, for sharing with us the efforts to streamline healthcare infrastructure, increase early detection and promote cancer awareness so that we can have a better and healthier society. We extend special thanks to Ms. Indrani Kaushal for your presence and your valuable address and remarks. Thank you, everyone, once again. Can we have a big round of applause for all the panelists and moderator? Thank you. We now shall move towards the second session, which is a new age healthcare delivery models. Thank you, Madam. Thank you, sir. This session will deliberate on how integration of technology, data-driven insights, and patient-centric approaches have the transformative potential for new age models, how the healthcare delivery landscape is metamorphosizing, and what is the future of healthcare in India. The panelists will also discuss the changing roles of healthcare providers, the progression of healthcare infrastructure and innovation, and the implications for healthcare workforce and skills. For this particular session on new age healthcare delivery models, the chairperson will be Dr. Harsh Mahajan, Chair, Ficci Health Services Committee and Founder-in-Chief Radiologist, Mahajan Imaging and Labs. We will have the convener, Dr. Mahesh Joshi, Co-Chair, Ficci Health Services Committee and President and CEO, Apollo Home Care. The moderator will be Mr. Lalit Misri, Partner and Co-Head, Healthcare Sector, KPMG, India. The panelists will be Dr. Vishnu Panigrahi, Group Head, Medical Strategy and Operations Group, Fortis Healthcare Limited. Dr. O. Manchanda, Managing Director, Dr. Lal Path Labs. Mr. Mandeep Singh Kumar, VP and Country General Manager, Intuitive India. Dr. Ravi Gaur, Founder, DRG Path Labs, Partner and Director, Uni DRG Specialty Labs. Mr. Gaurav Agarwal, Co-Founder, Tata 1 Milligram. Dr. Gaurav Tukral, COO and EVP Healthcare at Home, and Dr. Vaibhav Kapoor, Co-Founder, Pristine Care. I request everyone to kindly take up your seats, please. Thank you. And shall we extend a very warm welcome to each one of them on the stage? It's indeed a pleasure to have you all over here. Can we extend a big round of applause? Thank you. And I would now request Mr. Lalit Misri, Partner and Co-Head, Healthcare Sector, KPMG India, to take up the session further as a moderator. Thank you.
Very good morning, everyone, and a very warm welcome to our chair, Dr. Harsh Mahajan, and all our esteemed panelists present today here for this session, and all our industry colleagues and leaders who are present here for this session. Session name is the New Age Healthcare Delivery Models, and here we will discuss about how the new age healthcare delivery models are enabling the change of the healthcare delivery systems, the way care is provided, the way the care is delivered, and how the technology innovations are bridging some of the systemic gaps that exist from a long time, enabling across the shortage of human resources, beds, connectivity with the patients, and also the accessibility of the care in urban and rural areas. Before I start the session, let me invite Dr. Mahesh Joshi to start the session with a warm welcome to our chair.
Good morning, all the panelists on the dais, Dr. Mahajan, and all the wonderful audiences who are sitting in here. As you see, the title of this conference is Metamorphosis. I'm sure everybody connected with healthcare somewhere either in 10th or 12th standard drew this entire circle of metamorphosis, right? Larva, pupa, whatever, and that's how you got into somewhere with medicine. But life also at every stage needs a morphosis. It either happens biologically or it happens because of circumstances or the forces, and that's what happens in industry. This is coming out very clearly in healthcare industry. Who is delivering care? Conventionally, it was doctors. It is being challenged and it is changing. It is constantly changing. Where is healthcare being delivered? It is changed from four walls of a hospital and an entire universe is now open. How is somebody accessing healthcare? You had to actually go to a hospital to get care. It is completely being changed now, right? How it is delivered, how it is monitored, how it is tracked, how it is paid for. I mean, did you ever imagine our parents paying insurance premium to avail helps? But this has become the necessity in today's time. And to top it all, I think COVID actually shook this entire industry to start opening up and seeing at these opportunities. So when we were thinking through this entire session, I think these two things just fit in like two pieces of jigsaw puzzle: metamorphosis and the change in the industry, that is the new age healthcare models. There are so many people who are trying to address who should be delivering care, how it needs to be delivered, how it needs to be financed, how it is to be monitored. And KPMG, along with Lalit's leadership, did a wonderful job in coming up with this paper in a short span of time, because there is wealth of work that is happening, but many of us in the industry probably just know only a small segment that we are working with. And the entire endeavor was to bring all of this in a short synopsis or summary to give you an idea about what wonderful work people are doing. Some of these are already successful, some of these are still trying to establish, but nonetheless, it's an opportunity for each one of us to have a look at this and see how each one of these models are contributing to the change or to the metamorphosis in the healthcare industry. So with this opening remarks, I will invite Dr. Harsh Mahajan to say a few words, and then we will hand it over to Lalit to get this session started.
Thank you very much, Mahesh. Good morning, everyone. I think the context has already been set, and we had an excellent opening session, which actually focused on the challenges that we as a country face, the challenge of access, the challenge of affordability, the challenge of being not able to spend enough money, especially from government coffers, to provide healthcare to our population, technological challenges, the dearth of equipment, and also the dearth and shortage of trained manpower. Now, we cannot wish away these challenges, and there is no way that overnight we can overcome them. We can't have double the manpower in even 10 or 20 years. And so that's when something else has to come to the fore to be able to meet the challenge, to be able to provide the universal healthcare which our government has set as an agenda. And that's where probably these new age healthcare delivery models
which, as Mahesh just said, came to the forefront during COVID when we were swamped, the number of sick people much more than what we could handle. And that's where the new home healthcare, telemedicine, which I, as a doctor, used to feel, no, how can I treat a patient without actually having him sit across and putting a hand on his shoulder, and the patient also feeling that it would not be adequate. But during COVID, we saw that those with the oxygen levels of 70, way below what could be handled or what we thought could be handled at home, perforce we were forced to handle them at home, and many of them survived, thrived, and a few of them are amongst us here today. Similar is the case with the burgeoning healthcare problems, NCDs, and a part of that, cancer, which we heard about in the last session. There is no way that a doctor can go and treat each and every patient. That will take probably 50 more years to happen. And that's where these new age models with artificial intelligence, probably improving the productivity of healthcare systems, improving the productivity of doctors, improving their accuracy, improving turnaround times, maybe as has been seen in the pathology and the lab medicine sector, where from a single pathologist reading out 100 or 200 reports, now probably a pathologist reading out 5,000 reports, because everything has become automated, because of technology is possible. And maybe that's where we need to head. And we have stalwarts of the field, some who started as small startups, 2-3 people startups, and have now grown to unicorns, and others, large companies who've taken up this challenge, are going to discuss the way forward, and how these new age models will transform and metamorphose healthcare. And no one better than Lalit Mistry and KPMG, who've done really, as has already been said, in a short span of time, brought out a very comprehensive paper, which I think will become really something which all of us will look at to see where the future of healthcare is headed. So over to you, Lalit. Take it on from here, please. Thank you.
Thank you, Dr. Harsh and Dr. Mahesh, for your insight and setting the context for this session. As you rightly mentioned, we are very fortunate to have the stalwarts and the representation from across the care value chain, right from the team who started our digital front door to delivering a post-hospitalization care, innovative hospital delivery models. And some of the panelists I would like to really mention is Dr. Bishnu Panigrahi, Group Head, Medical Strategy and Operations, Fortis Healthcare. We have Dr. Om Manchanda, Managing Director, Dr. Lal Path Labs. Mr. Mandeep Singh Kumar, Vice President and Country General Manager, Intuitive India. Dr. Vaibhav Kapoor, Co-Founder, Pristine Care. Mr. Gaurav Agarwal, Co-Founder, CTO, Tata 1mg. Dr. Gaurav Pakral, Co-Founder and CEO, Healthcare at Home. Dr. Ravi Gaur, Founder and Director, Dr. Gaur Path Labs Limited. And very interestingly, as mentioned, that during this exercise, the biggest challenge was for us to put the various building blocks of the emerging healthcare landscape together. We all know how it is evolving, what are the different players are doing, which are the main companies who are working this. The biggest challenge was putting that thing in a very logical way together and putting a sense to it, that how the landscape is really getting evolved, how it will change in the coming time, and what are the key enablers that will determine the success of the new age healthcare delivery landscape that is emerging. And to present that, we have captured that in our paper, but a glimpse of that we can see right now in a video, if you have a video ready with us. In true sense, the metamorphosis of healthcare models in India will help in connecting the dots and change the healthcare landscape in India. To start our session, let me invite Mr. Gaurav. Gaurav, you have been working with Tata 1MG and the new concept on the digital front door. The things have evolved in the last decade, but the way things have changed post-COVID and the changing consumer behavior, the way the self-care at home, on-demand care is changing. How do you see this space evolving? What are the future trends that you see, and what are the challenges and how it can enable in helping us in connecting the dots that exist today?
First of all, thank you for having me here, and congratulations on the report. When we started 1MG, we started with this probably foolhardy belief that consumer or the patient needs to move to the center of healthcare. We also felt that a lot of the physical infrastructure that needed to exist to solve healthcare in India as a problem will probably not happen at the pace which we want it to be, especially for a country that's growing at the pace that we were, both population-wise and also economic value-wise. And as a result, we felt that digital technologies are going to be the solution. And as Dr. Mahajan mentioned here, I don't think, it's my belief, personal belief, I don't think we could have come out of the COVID situation as well as we did, despite all the challenges, if we didn't have a robust digital and a physical infrastructure for healthcare. From diagnostics at home to a rapidly, scaling up of a molecular diagnostics infrastructure to medicine deliveries at home. So many of our patients were at home, our markets, our shops were shut down, but they were able to get medicine deliveries at home. Telemedicine was scaled up really well, and people discovered that for a lot of conditions, when you were pushed, you could actually get pretty good quality of care online through our doctors. And we personally saw this transition happening where earlier it used to take us a lot of time. And again, as Dr. Mahajan eloquently put it, how can I see a patient without touching him, feeling him, feeling the nerves, etc. But people started to change their behavior, doctors started to change, and they realized that this is a core model of delivery of healthcare that is going to work. So fundamentally, I feel COVID was a great driver of digital healthcare, digital therapeutics, and new models of care that will emerge. If I sort of take a stab at what's going to happen as we move ahead, I think there's a few trends that are strengthening and accelerating as we see it. The first is we call it self-care. We've also called it the quantified self movement, which started with the advent of smartwatches, etc. But increasingly, point of care diagnostics. There's this really cool strips coming out where you can test some parameters with low fidelity on a daily basis, etc. So the whole self-care, quantified self model is going to strengthen, accelerate as we move forward in healthcare. As a result, is going to get more and more consumerized, move closer and closer to the patient. Technology is going to play a significant role in this whole quantified self model. I think the second big change that I hope will happen and that we are seeing some signs of is to actually change anything fundamentally in, let's say, NCDs, there has to be a payer who's incentivized for populations to live, a healthier life, right? In traditional settings like the West, we've seen insurance play a really good role in that. And in India, we are still far away from seeing insurance play a significant role in day-to-day care and care management. We are seeing outpatient models evolve, but they are nowhere close to where we need them to be for a country like India. And I think that's the second trend that I would hope and imagine that would go through. The third is the role that data and AI are going to play in bringing things together. And there's this really interesting anecdote someone told me the other day, that they were talking to a clinician at Stanford who said that I find it strange that I cannot look at a patient's prescription or medicines and their diagnostic reports together to understand what's working and what's not working. In an ecosystem of today where everything is digital, digitized, etc., it should be possible, right? It should actually become table stakes. What's even more strange is that as we have tried to take all the healthcare data that we collect and generate for patients when they avail services for us, bringing that information together to actually find meaningful insights for patients is actually incredibly hard, because oftentimes there's no research, because data traditionally has been very, very hard to get. And even if there is, making it friendly for a consumer or a patient to actually incorporate is very, very hard. So I feel that next 5 to 10 years, data is going to tremendously change how we interact and how we incorporate healthcare insights in our day-to-day life. Lastly, I feel that a lot of healthcare will move away from episodic to actually becoming condition care plan, because eventually what you need for a consumer who, let's say, has a chronic condition like diabetes, etc., is not just medicines or diagnostics or doctor consultations. You need all of them together with lifestyle management. And it's really heartening to see that we are seeing some of these models actually emerge and starting to do well in India. So I would say these are 4 or 5 things that would be really powerful and that I would see going forward.
So very interesting point, Gaurav, that India, definitely there are mixed models that are emerging, which is digital health, physical, and the phygital models. But also very important is post-COVID, there has been a larger awareness, acceptance, and adoption of the digital technology and data-driven care, both across patients, policymakers, and the providers. Having this new change behavior across the value chain and the stakeholders, it is also determining how the diagnostics and the screening is playing. Let me invite Dr. Om Manchanda. Dr. Om, how are the things in the diagnostic space is playing and how it is evolving post-COVID? Because increasing awareness of the patient, the way the health is seeking, and also moving away from the episodic care to more preventive care and screening, how it is evolving here.
Yeah, thank you for having me here. Good morning, everyone. I think fundamentally, I see the role of diagnostics is changing from purely diagnosing a problem to a lot of other use cases. So it's actually right in the center of healthcare, where diagnostics is not only used to find what the problem is, but it's actually moving towards being predictive, where whole area of genetics and genomics is coming to play. As many of you may have seen that these days, a lot of preventive health checkups being delivered by many companies. So actually that area is fast growing. It's also going in the area of therapeutics, where it's becoming personalized, where we want to know as to which sort of medication would work. Right now, it's very popular in cancer treatment, but I have a feeling that it will grow even further. It's also growing in terms of a real frequency of testing actually is going up. I think, as Gaurav mentioned, it's no more episodic, and to my mind, it's actually going to become real time, where each one of us would track actually on a real time basis as to what's going inside my body. So the role of diagnostics actually has become much more broader than it used to be. I think that's the first big change that I see. The second sort of a thing, I think that what we are talking about is business models, and we have seen this whole area of it's no more people are saying that I want to stand in a queue and wait for the report to come next day morning. So I think this whole service part of diagnostics actually has taken center stage in the last at least one or two decades I've been in the industry. And it's just not stopping because earlier it was like collection centers, then it became home collection, then now it's actually all on the app, and people just don't want to wait even for beyond an hour or so. So I think the service dimension in diagnostics actually has gone to the level next. And there was a time when we were comparing ourselves with other healthcare players, but nowadays when I get up in the morning and my LinkedIn is full of all the challenges, and they compare us with people like food delivery apps and Amazon and things like that. They all actually say in this day and age, how is it possible that you can't do this? So you are not being compared with any other healthcare provider, but you are being compared with virtually every other thing that's happening in the environment. So I think, to my mind, business models do change because at the core is customer or customer needs. I think those needs are very changing very, very rapidly. The third area which I find is which probably I think healthcare would see more of in India. In my mind, it is not where it's about scale of operations. If you look at diagnostic industry, primarily 80% or 70% is fairly unorganized, and you have one single unit being run by a doctor or a technician, and that person actually is doing all the tasks, whether it's starting from booking and starting from home collection to delivering a report, logistics, everything else. But as the scale of operations actually pick up, it's very, very difficult for one player to do all the tasks. I have a sense that the entire value chain of healthcare will break very rapidly, and you will see further businesses appearing. Let's say, for example, that you just may have a logistics company only managing sample movement. They have nothing to do with testing, they have nothing to do with collection, but you just may have a medical logistics company handling logistics. These days, IT actually has gone way ahead, where I don't know how many of you have seen that there are companies which are giving you smart reports. They don't do anything with the sample, they don't do anything with the testing, but they just say, you give us data, we'll analyze it and present a report which is very user friendly. So I think the breaking of this value chain in healthcare is yet to come, and I do believe that not only diagnostics, but I think hospital space will see even more of that. So net, I think at the core of it is customer need, and that is driving each one of us. And there is some disruptor or innovator who's trying to see that how do I differentiate my business model compared to traditional guys, and that's how the innovations are happening in this space.
Yeah. As you rightly mentioned, the digital disruption across the industry is shaping even the healthcare landscape and changing the consumer behavior and changing the way they seek the healthcare. We have also changed the diagnosis space, moving from a diagnosis to a self-screening and screening and testing at home. Dr. Gaurav, from your experience, how the diagnostic industry is evolving, especially around the new technology and new models, and also on the self-care, how it's going to evolve, and what are the changes that you see in this space?
Good afternoon, everyone. It's my pleasure to be here and talking about diagnostics, which is one of my passions, of course. And the first thing, when you look back, sometime couple of about almost 6, 7, 8 years back, IBM drone, if I'm like they patented a kind of a thing, which a drone was delivering coffee to the CEOs when they're meeting at the right point of time. So that was a wonder, but why? Because the basic need was in healthcare. The basic need was probably delivering medicines in the places which is not reaching. So that what I'm trying to say is here, probably the healthcare people, when it comes to these disruption changes, they take time, a lot of time. They resist, to be very frank, many of them. So what has happened, especially the resistance, totally, the COVID has changed that mindset. Look, we have to. Otherwise, it will not work. So I think what you're talking about, the key challenges, what we found, especially in diagnostic, I'll limit myself. When I was part of the National Digital Health Mission, when we devised the unique health policy, they want to standardize the lab thing, but there's no standard nomenclature available. Number one, There was nothing like a common, because CBC, complete blood count for one lab was something, second was something, third was something. Same thing, the thousands of assays, but everybody had different nomenclature and different component. How do you standardize, number one? Then that leads to the problem of the interoperability, because within the labs we have like multiple, within say multiple providers. We have a satellite lab, we have a hospital lab, we are working with insurance companies, and everybody using a different kind of a software. How do you integrate? That is the biggest challenge of interoperability. Then the still I say, leaving aside probably bigger corporate labs, which has now come up, when we budget our labs, we hardly put an ID cost to it. Cost and budgeting is another issue. We just don't, just taken for granted. It's okay, we'll work it out. Then of course, the other challenge is the data security. These are all integral part. Regulatory compliances, which is changing. I think today we have a digital pathology in place. Our digital pathology is something, probably the biopsy images, which can be uploaded across globe, and people have a second opinion and a third opinion. Now, how do you address that? Because the regulations change, you cannot authenticate remotely. Now, when everything can be done remotely, why can't a pathology report be reported or remotely? Because everything is virtual. Labs are totally managed virtually. We can always have all controls, all processes, monitor, real-time monitoring. I think that regulations are, I think, need to be changed, because the technology is changing so fast. Regulations are probably getting static. I think that dynamic has to change. That is another biggest challenge what we all face today in the diagnostics. Of course, the various workflows. I think we have all structure. I'm sure of home is sitting here. You realize there are old kind of instruments, the newer instruments, and the newer technology. How to integrate the workflows? That itself is another change. I think all this ultimately leads to some kind of a resistance. Let delay. Let's do it. But I think the need is today the customer, and we need to work on it. If you don't, you will not actually be surviving. So probably the technology has gone up to DNA, womb to tomb. Probably that's what we talk about. The 5 Ps, what we talk about is like, we talk about the predictive genomics, we talk about preventive screening, we talk about prognostic, we talk about personalized treatment, when we talk about, you can say, the planning, because everything has now to be integrated together. And that's where the diagnostic is piloting it out and becoming a womb to tomb requirement. I think that's something what we feel. And these are the big challenges one need to definitely address. Mindset has to change, but awareness is there. Customer demands. Why can't you do this today? Why? They are well read. I think industry has changed, but I think the mindsets have to change. More awareness is there. The regulations have to change, and the deliverables are there. And I think innovators are always there. But I think the most important, the last important part is the trust in AI development, because in a critical care, when you have a critical delivery of a report, ultimately you're still not able to trust the AI algorithm. You still feel there has to be some human. We don't know whether it's how big and best validation it is. But that is also another area of challenge. But it's happening fast. We already happen in oncology space. It's happening into other lifestyle disorders also. And I think we look forward to that, and it'll be a great to see the future.
Great. Thank you, Dr. Ravi, for sharing the 5 Ps of the diagnostic industry, how it is evolving and how it will change. And as you rightly mentioned, the digital ecosystem will play a very important element to integrate the new age diagnostics and the care value chain. It's also reflecting that the digital ecosystem will change the primary, secondary, and tertiary care. Let me invite Dr. Vishnu Panigrai to share his view about how the hospitals of future are looking like, how it is evolving, how the future primary, secondary, and tertiary care will evolve, and how it will get integrated in the larger care continuum.
Good afternoon, everyone, and thank Ficci for giving us this opportunity to brainstorm here. And as they say, we are looking at the demographic dividend of India. We are looking at a huge workforce which will drive the economic engine of India. I think so. So we should have a healthy body and healthy mind. That is the starting point. And when you look at the healthcare scenario that is evolving now, I think so a lot of the hospitals will be confining themselves to acute care. A lot of care will move out. That is where we need to enhance technology. I think so. We kept on hearing about NCDs, which is the diabetes, hypertension, the CADs. But there's a lot of diagnostic modalities we can use for following up these patients. I think that is not being leveraged properly. I'm just giving a small example. We call ourselves the diabetic capital of the world now, but now everyone can afford a glucometer, And a lot of them have the Bluetooth connectivity. It will connect to the phone. It will go to your diabetologist, endocrinologist, your physician. So they can keep a trend of your blood sugar levels and monitor it, and so that you don't have to come to the whether it's a city or a small town you're staying, coming, traveling. They can predict the way the stroke is going to evolve. The thrombotic stroke, hemorrhagic stroke, you can get the patient earlier. The ECG machines now have the facilities to sort of take the images, the ECG images to your referring doctor to the. So you can make out a ST segment MI much earlier, and so you can, the window period is reduced, so you can, the door to balloon time will be within 90 minutes. So what I'm saying to say is that these type of technologies need to be harnessed, and there's still a lot of time to look at it. And we were talking about public-private partnerships. I think so. Big chains, like say, as we say that in the Ficci, I think so, during the COVID pandemic, the barrier between the public and private sector was demolished. I think so. The major change, they should start looking at having public-private partnerships, and government should help out in that in a way that the model is beneficial to both. I think, and it can be done. I'm speaking from personal experience. The 2 years that I was in Bhubaneswar, the way the government did the public-private partnership during the COVID time, 1,050 beds were put up across the state and in tribal districts for people to benefit, because the private sector has the capability to scale up early. So I think so that model should be looked at, and I think so the major chains, they should start looking at going into the peripheries to sort of enhance technology there. You can do a virtual OPD, get the diagnostics there, and do the treatments there. The other thing I think so, the one thing is that how do we take care of this demographic dividend, the young people? How do we keep them healthy? So I think so we should start looking at the preventive part of it, and this is where the thing came about the insurance. Insurance providers don't look at providing insurance for pre-hospital care, most of it. So how do we encourage that? I think this is where I think so we need to work with the government, with the insurance providers, to say that the insurance providers also start paying up for insurance if a diagnostic is done, a health checkup is done pre-hospital, because it's always in the hospital they pay up. But for outside hospitals, so how do we encourage this? I thought this, once this is done, we'll have a lot of people out in the community to look at doing the health checkups at regular intervals. People are not much more conversant. Everyone has a smartphone, they look at it. So it is not an ignorant India that we're looking at. But this part of it, which is outside the hospital, that is a huge potential that we should look at it, because if we don't take care of them, we will not have a healthy body. Coming to the healthy mind, I think so across India now, this is mental health is a very important issue, which is not being, because there's stigma attached to it. And you can use technology by this virtual consults. A complete workup can be done for mental health patients, and they can come earlier, because a lot of people, the patients who are suffering from various mental health illnesses, they are hesitant to come to hospital to consult a psychiatrist or take a counseling from a psychologist, thinking that what will people say. So that stigma is kept at home. They can consult. I think this is another huge potential that we look at it. Mental health has to be taken care of. It's something that's being ignored, and we are putting it under the carpet. So as I said, that a healthy body, healthy mind, we have to look at it. Great.
Thank you, Dr. Vishnu. And very important point that you made is we need to invest in the digital technology.
One second. The other part which we always forget is other than the doctors, there's another care provider there. It is the nurses, the technicians, all these. How do we keep them, upskilling them? That is something that's again the technology part. All the simulation things are there, available there, so they don't have to come to a college or any institute to do any training. They can do on a simulation, and sort of this will be another thing that we should look at. How do we upskill our allied health force? This is another thing that we need to work on, leveraging technology.
Yes, I think rightly Moya highlighted that there is a need to invest in the digital technologies for all the hospitals, not only moving away from the transactional system to a very integrated hospital information system, MOIT, data integrated care, and also leveraging the skilling and upgradation of the existing workforce in terms of digital literacy and getting equivalent with the new solution, but also the new model where the hospitals are partnering with pre-hospitalization and post-hospitalization care management to provide a complete care to the patients, so that patient is not left alone after once the hospital patient walks out of the hospital. It's a very important part of that, and in this the technology is going to play a very important role. Let me invite Mr. Mandip Singh to share his view that how the technology, innovative technologies and the robotics can play a very important role in the patient centricity and delivering a value for care.
Thank you so much. It's a pleasure and a privilege to be here every year. It's very interesting. We're talking here about healthcare metamorphoses, and I'm glad that we have started to begin to understand how technology would be at the core of it. I refer to a morning discussion that was happening, where I think Dr. Monica brought up a very valid point. For a long time, when we have been talking about cost effectiveness, the focus has been only on cost. And I think we have missed out on the effectiveness part. If we want to become patient-centric, it's important that that effectiveness comes into play. Dr. Om mentioned an important point that today, it's not that a lab is compared only to, similar diagnostic providers. It is kind of compared to a Zomato or a Swiggy. Today, if I have to go to a restaurant to eat or order, I have more data available where to eat and where to order from, rather than where do I really need to get my treatment done. Last year at Ficci, we talked about Heal in India, and we emphasized the focus of recording and publishing clinical outcomes. I think we're really at a very nascent stage of doing so. If you really want to have the patient at the heart and the center of what our hospital network does, or what our technology does, or what our data management does, we need to record and publish clinical outcomes. That's how a patient is going to decide, and that's how businesses are going to get built. Now, if I would just take our own example, in our own humble way at Intuitive, we have been focused on the quadruple aim. How are we looking at making the patient at the center of everything? Every therapy or every technology that we look at developing, it has to improve the patient experience, it has to improve the care team experience, it has to improve outcomes and reduce the cost per episode. Now, how would that happen? I think a point on skilling also got made, right? It can only, what Dr. Vishnu Panigra was saying, it can only be done if seamlessly we are training our physician community to adopt new technologies and helping them. I think Gaurav, you were mentioning about big data. We are doing millions of surgeries every year. We're utilizing that data to help surgeons talk about how do they quantify the impact of a surgery. Long for the last 6 years, I've been an Intuitive. Every time I talk about robotics, the question posed to me is, but robotics is expensive. And my question is, expensive compared to what? If your blood loss is less, if your hospital stay is less, if your chances of getting a recurrence is less, your chances of getting complications is less, where is that value equation going to? Are we really looking at a holistic cost of treatment? And are we able to have a discussion with the patient with that on database? Today, robotics has about 30,000 peer-to-peer clinically reviewed papers on Da Vinci technology, which establish the effectiveness of the technology. The patient is getting much and more informed today. The patient wants and demands answers, right? And they're going to come and ask, hey, and I've heard that from even caregivers and care providers as well. Hey, why are you not considering a robotic surgery for me? That question would come. But at the same time, it also doesn't mean that robotic surgery is for everybody. Right? You got to see and you got to develop your products and technology, training pathways and education models, which make sure that the technology is used for the right reasons, for the right kind of patient, and you deliver right outcomes. If we really don't do that, then I think we risk ourselves in talking a lot about patient centricity, talking a lot about healthcare metamorphoses, but we may not end up achieving the goals to the extent that we can do. Technology as a provider, be it in diagnosis, be it in patient management, or be it in a technology that is actually used to provide the treatment, is a catalyst. But that catalyst has to be utilized effectively. That would be my point, Lalit. Unless and until to utilize that catalyst to deliver the outcomes that a patient is seeking for. What is it there is in the mind of a patient as a risk or an opportunity when it comes to a caregiver? The technology has to answer those questions. The technology has to be driven in terms of its design to answer those questions. And in the hands of the people who are providing the technology and the data needs to provide tools which can answer these questions to a patient. Why does it really make sense for you to undergo this particular recourse of therapy? I think that's where the real change in our healthcare delivery would happen.
Great. Thanks, Mandip. And very valid point that you made is today, even the consumer is looking for a new technology and advanced treatments, and also leveraging the technology. They are well aware about how the robotics can help them to deliver better care, have better surgical outcomes. And that is actually pushing even the providers to adopt those technology and that. And it's worth of investing in these technologies across the hospitals and post-hospitalization care. A very important point that these technologies also have revolutionized the way pre-hospitalization and post-hospitalization care is delivered today, especially at home and out of hospital care that has changed in the last 1 decade with emergence of the post-hospitalization care or post-treatment care moving out of the hospital to at home or at nearer to the home and in a new formats. And that is what has changed in the new age home healthcare delivery, remote healthcare management and all. Let me invite Dr. Mahesh to share his view about this post-hospitalization care management at home and on-demand care that is emerging there.
So, in terms of home healthcare, the first, let's accept the ground realities perception of everybody of home healthcare is it is only post-hospitalization care. So this is the first myth that I want to break. This is just a beginning. It's a very small portion of the entire patient life cycle journey. I think going forward, home healthcare is largely should be playing a role pre-hospitalization and during the episode to avoid the hospitalization. And if need be in a small segment, only doing the post-hospitalization care. This is the first important point. Now, what are the challenge in this? The challenge is today's home healthcare, what the organized players or unorganized players are serving is largely a social need. It's a desperate need of the family that somebody cannot be there to take care. That's why they need somebody. It is not clinical need. There is no doctor who has in his care plans that in my TKR surgery, I will reduce the duration by integrating home healthcare by 2 days. Large part of home healthcare today addressed is social need of the community. So this is the next change that needs to happen. And that is, it has to evolve into clinical home healthcare need. And what is the barrier towards that? The most important barrier is the mindset of the existing hospitals and the clinicians. We have gotten used to providing care in a certain format, and we are not willing to risk anything. पर वहां पे नर्स अच्छी नहीं होगी, पर कैसे कवर होगा? These are the same doubts that have come up years after years whenever there is a new innovation that has happened. So this is another important point. The way I see how these models are evolving in the next 5 to 10 years. Broadly, there will be 3 or 4 buckets that you can put them. One is hospital-based home healthcare player versus standalone home healthcare providers. Hospitals today are driven with a very short-sighted vision of generating maximum amount of money from the patient while he's there in the hospital. Nobody is looking at by reducing the length of the stay truly, and I'm being very candid. To reduce the length of the stay, invest in getting a new patient and earn better revenue, because the vision is very short-sighted, because it takes a lot of effort to get another new customer, right? So I think they have to accept this fact that if they don't do it, insurance will put it down their throat and they will tell them, we will reimburse you only this much. You decide whether you want to put the patient for 5 days or 7 days or 10 days for a TKR surgery or a CABG surgery. So one is the hospital-based versus non-hospital-based. Second will be skilled versus non-skilled home healthcare. As I was telling to you, large part of the need with our entire changing demography of elderly, even our hospital occupancy, more than 50-60% of beds are now elderly people, 60 plus above. So there is a non-skilled segment that is there, which is not constrained by the skilled manpower. So that is scaling up rapidly. It doesn't have so much of risks associated with it. But on the other side is actually the skilled home healthcare, which is struggling because of the dearth of skilled manpower. I think this is where technology will play a significant role to ensure better monitoring and use a lesser skilled person to deliver similar level of care. The third one is going to be the specialty based models, and we are already seeing some specific examples of this. People might not go through the length and breadth of entire home healthcare, but only focus on oncology home healthcare, end of life care, palliative care, maternity care, right? And geriatric care. So many companies have come up. But the issue that these companies are facing with is because of lack of scale, they try to do everything. They put the brand as something, but they end up doing the entire spectrum of home healthcare, and they lose their identity. This is a very difficult business from an economic sustainability point of view. And therefore, this is a business of scale, and those who will be able to scale it up in future will survive. And how does that happen today? Most 95% of this industry plus is unorganized. So what will happen, as Dr. Om was mentioning, that the entire value chain, somebody might just do the sourcing for you. Somebody might actually deliver the care for you. And that's where I see a lot of mergers, acquisitions, and consolidations happening. The important driver for this adaptation on scale in going forward will be both the private and the public health insurance taking this up as a great tool to reduce the cost of care for the patients, to improve the convenience for the patient, to better utilize the existing constrained healthcare infrastructure that exists in the country. And this is where insurance guys will work closely with home healthcare. The way I see home healthcare might not deal directly with the patients. They might partner with health insurance companies, and they'll say, you try and work on this is your target of reducing the percentage claim by intervention at home. This is where the models will go. So I will pause here.
Thank you, Dr. Mahesh, about sharing how the home healthcare is not just a social need, but also a clinical need that need to evolve, and how the hospitals need to partner both across pre-hospitalization, post-hospitalization. Also in the hospitalization, there is an innovative model that is emerging that we have seen in last few years about the surgical care management with a network of hospitals. Let me invite Dr. Vaibhav Kapoor, co-founder of Pristine Care, to share his view that how the surgical care management with the network hospitals are working and how the patient needs are changing.
Good morning, everyone. So I'll spend 30 seconds to just tell you what new age healthcare models in surgery actually do. So it's basically, new age models open up physical clinics, the licensed physical clinics. All the super specialists, instead of sitting in the hospital, they will sit in these clinics. They see the patients in the clinic. And if that patient needs a surgery happens in a partner hospital, which is probably 2-3 kilometers away. So we are utilizing the hospital's infrastructure. Now, how do new age surgical models create impact? So I believe there are three clear stakeholders in healthcare when we talk, right? First is the hospitals itself, right? While we always say that India needs more hospitals, the truth also is that 80% of the hospitals, work at a 20-30% utilization capacity. When you go towards mid-size hospitals, this is the further gap. Every hospital you talk to, they need more patients. So there is already a lot of spare capacity which can be utilized, and new age healthcare models increase in utilizing this capacity. When you go to a mid-size hospital, another problem which happens is these hospitals will not be equipped with the latest treatment protocols, or the patients don't trust, a lot of mid-size hospitals because they will lack these protocols, or since these hospitals are generally owned by a single doctor or a smaller organization, they will not have the most advanced latest equipments, for surgeries to do. So new age models, instead of building own hospitals, they invest in creating these surgical protocols for them, plus investing in all these high-end equipments, whether it is holmium lasers, whether it is, any procedure which can happen in the most advanced technology. So, we equip them with these instruments basically. So that is one part. The second major stakeholder, in the healthcare system is, of course, patient. Everybody like mentioned, and over last 10 years, thanks to the Swiggies and Zomatos and Amazons of the world, the expectations of customers have really changed, and so do in healthcare as well, right? So they're not just looking at quality care, they're also looking at a lot of convenience, not just for themselves, but also for their family. So here is when new age models come in, they bring in not just quality, but also a lot of convenience, right from, where do you do go for an OPD, how do you do your tests, diagnostics, insurance clearances, financial clearances, they aid in quick admissions, quick discharge, follow-up care. So now in surgery space, we don't look at surgery like, it's a 1 day, lab-coli 1 day admission, next day discharge. For a patient, it is a journey, right from the first consult to probably 2 weeks post surgery. So it's an entire month journey where new age models pitch in that, okay, we will solve this journey for you, not just the surgery part. That is the second part. So we directly enhancing the patient experience in that case. Third, the biggest stakeholder is of course the doctors, right? So when I was growing up, I belonged to Ludhiana, a small town. One of the reasons I became a doctor was, doctors were generally considered, almost like gods. I had seen, MLA inaugurating a road on a doctor's name, and I thought probably this is a way you can actually, put your name, that ways. But gone are those days, these things will not happen anymore. Now the situation is, for any, doctor, it is very, very difficult to establish their own practice, right? It is very hard. One, in our medical college, we are always taught about, the medical part only. We don't know about how to take care of the finances. We're not taught about how to do the marketing stuff, how to create awareness amongst patients. So here do new age models pitch in where they give that, platform to the doctor to come aid them in setting up their practice. They don't have to worry about patients. So these three major stakeholders are getting impacted, because of the new age models. Fourth, everybody has spoken about technology. I think any new age thing, the DNA is more on the tech side. Hence, anything which is thought, whether it is on the safety side, whether it is on, how would you manage things or on scale, technology takes the forefront rather than thinking, okay, let us put people there. So the thought process generally is, build a lot of tech, build a lot of systems, build a lot of protocols, standardize them so that, things can also happen in a distributed ecosystem at scale. So I think these, new age models are creating impact in every aspect, where healthcare, is involved or the key stakeholders are involved. Yeah.
Thank you, Vaibhav, about sharing the experience about the way the surgical care management is evolving and the care coordination is playing very important role, but not only in terms of helping a patient to find the right hospitals, compare the cost, guide them through this entire journey, but also leveraging the capacity that is unutilized in some of these facilities, equipping them with new technologies, adding new specialities, and delivering this end-to-end care, which is an interesting thing. As a part of our study, where we were studying various models, one of the very interesting model that Dr. Gaurav Thakral, who is a co-founder and CEO of Healthcare at Home, shared with us, and I will request him to share more insight on how the transition care is evolving and how the post-hospitalization and pre-hospitalization and the medical care is evolving and can be delivered through transition care.
Thank you, Lalit, and thank you, Ficci, for having me here. After spending almost 11 years in out of hospital care industry, largely home health care, I think this is the first forum I would be speaking about transition care. Well, this industry is almost 2 decades old in the West, very, very organized, funded by government, by insurance. What does it encompass? It encompasses institutional residential rehabilitation, skilled nursing facilities, long-term acute care facilities, and also as continuum of assisted living. This industry is now almost 8 years in the country, started in Hyderabad and then in Bangalore. What we do differently here is that we have combined all the components of out of hospital transition care into under one roof. Transition care, it's largely transition from hospital to home or home to hospital, and that's where we bridge the gap of continuum of care. What type of patients are treated here? Largely neurorehabilitation, also with pulmonology, onco, and even transplant. So these are the types of patients. We started with almost 100 beds 2.5 years back. We added 300 beds more. And in the next 3 months, I think another 100 beds. We will be leaders in as HCH transition care centers in the country. What is the need? Well, India shares 70% of the global disease burden in stroke, road traffic accidents, even more. As Dr. Vishnu mentioned, acute care is to save lives. When a patient of stroke, head injury, spinal injury lands up in an emergency, the need is to save a life. But the same patient is discharged with multiple tubes in the nose, urinary catheter, PEG, tracheostomy, and is left to be treated at home to recover by the caregiver who's not even trained. Yes, that's where the role of home healthcare comes in. But recently we did a survey with almost 1,000 stroke survivors. And what we found was that if you are in an institutional transition care center, the recovery is as fast as 20 days to 3 months, whereas the same recovery is 4 months to 1 year if you are being treated at home, because there is a multidisciplinary team which treats you. It's under the guidance of a physical medicine and rehab expert, that physiotherapist, respiratory therapist, occupational therapist, speech therapist, psychologist, with the equipment which cannot be made available at home or in the acute care, they are recovered. And when I say recovered, they become as independent as they would be before landing up in the hospital. This is beneficial because it's very, very affordable. A patient spends not more than 15,000 rupees a day, and it can become as good as affordable as 5,000 rupees a day. We don't have any super specialist in our centers. Still, they are manned by doctors, nurses, and the therapists 24 hours. Affordability, as I said, which is good for the patient, good for the payer. It reduces avoidable disability, which is a big challenge to us. It makes people productive, reduces burden on acute care, also tackles caregiver fatigue. It's very difficult to manage such a patient at home when you're also doing your job, or you have other things to do or attend to. And lastly, I think it adds a value chain in the continuum of care as a transition where you get recovered fast and still can be treated at home and then recover and go back to your normal activities. Thank you.
Thanks, Gaurav, and very interesting point that you made. It was first time that I heard about this concept, and it seems very interesting concept. As all our panelists mentioned, the healthcare landscape is evolving. It is getting more evolved. Number of players that are getting added. It's also equally adding challenges and confusion for the patients as well to navigate and seek the care. There's a larger number of players out there, which will demand patient awareness, self-care, increasingly leveraging the patient care coordinations and helping them to navigate, access the right care, and also help them to deliver this care with the help of the providers. Some of the key enablers that will be really required in the coming time to enable the new age healthcare delivery models include to accept more collaborative approach than the competition. It will be more about how the care providers collaborate and work together and connect the dots instead of being an individual island of excellence at their own and leaving the patient to be more of a transactional service. Health UID, electronic medical record, and interoperable digital ecosystem will be a very important element. We know that Government of India is working towards Ayushman Bharat digital mission, but the fast implementation, larger adoption, and bringing all the stakeholders, both public and private sector, on board will be a very important element. Unless we do that, unless patient has health UID and electronic medical record, there is no way this data is flowing across the value chain, and there is no way that will create a value out of the patient data. Patient will be continue to be treated on episodic basis. The data that is generated will not be able to utilize for the health management, but overall lifestyle management. Regulatory reforms are definitely areas which need to continuously expand and adopt. There are new models are approaching, new challenges, new technology, and also the data security and cybersecurity threats are increasing. This will demand for new regulations and reforms that will be required. Insurance reforms are very important, and which calls for a larger acceptance and recognition of new models. It's very first important thing is the policymakers, the providers, the patient need to recognize and accept the new models and consider them as a part of the core value chain and help them to deliver. An insurance coverage need to expand and ensure that patient is not only covered for the care that is provided in the hospital, but also the care that is rendered at home or at other places. Also very important element is the the consumer will demand a quicker service on demand, and the changing behavior will require a hospital provider to change the way they deliver and engage with the patient is the most important element. The way they access the Zomatos, Netflix, and other services, I know that cannot be compared to healthcare services, but some element of that will be called for the adoption to that sense. And lastly, self-care, both in terms of preventive care and the post-hospitalization care is going to be a very important element. The community is going to play a very important role in a country of 1.4 billion population. You cannot build enough hospitals, you cannot build enough healthcare resources. You will require a self-care and community engagement to take up and preventive and care to come up. Having said that, I'll request Dr. Mahesh to have a closing note from you.
So thank you, Lalit, and thank you all the panelists for bringing out some very good points to think about, well upon, because this is what is going to change or shape the future of healthcare industry in the coming decade. Very interesting insights on self-care model, digital health integration, place of delivery changing, insurance intersection into how they will play a role into this. And a lot of these things, I think it will be worthwhile each one of you to go through the details on the paper that is made available. On the lighter side, before we close the session, for Dr. Weber, who was a little disappointed about that road, you can get a platform named after you, Dr. Weber, instead of a road. So don't worry, that opportunity still exists. And thank you, each one of the panelists, for your insights and sharing your thoughts and opinions, and Lalit for moderating this show, and Dr. Harsh Mahajan for your presence, and all of you for still being alive and kicking.
Yeah, great. Thank you. Thank you very much. And thank you to all our panelists.
I have a question, please, from Dr. Thupral. I have a question. What about the people who have the policies, the insurance policies? Only the hospital will give, the home care will not give. What do you do about that?
Definitely, ma'am. For the last 1 decade, we have been struggling for insurance not making home care as part in the mainstream. There have been various geriatric products with pilot phases. Some worked, some did not work. But fortunately, insurance now recognizes transition cares. And out of our 7 centers, I think 3 are already working with insurance to give cashless facility to the patient.
What about palliative care?
Including palliative
care. Which companies have done it?
There are many TPAs who have done it, but I think what has been led has been by Star, Niva Bupa, and many other private insurances.
Thank you so much.
Thank you very much, moderator, sir, panelists, chairperson, for sharing the innovative healthcare delivery models, offering valuable insights into the future of healthcare. And now we request you to join us for the lunch, and we shall assemble over here before 2 to start the inaugural address and inaugural session. So see you then. Bye-bye. That's a coffee. Thank you. Also, a humble reminder that kindly put your phone on vibrating mode or the silent mode. to reach the venue. So I request everyone to kindly take up your seats, please. And those who have missed out to put your mobile phones on silent mode or vibrating mode, kindly do that. Thank you. I request everyone to kindly rise from their seats and help me welcome our Honorable Minister of State, Ministry of Health and Family Welfare, Government of India, Professor S.P. Singh Baghel. Would request sir to kindly step here. Thank you. Namaskar. It is an absolute honor and a great privilege for us to have Honorable Minister Sir with us to grace this wonderful event. Also, we have on the dais Dr. Ajay K. Singh, Senior Associate Dean for Postgraduate Medical Association and Education, Director, MMSCI, Harvard Medical School. Dr. Harsh Mahajan, Chair, Ficci Health Services Committee and Founder and Chief Radiologist, Mahajan Imaging and Labs. Dr. Sanjeev Singh, Co-Chair, Ficci Health Services Committee, Medical Director, AIM SRC, Faridabad, and Chief Medical Superintendent, AIM SRC, Kochi. We also have Brigadier Dr. Arvind Lal, Chair, Ficci, Swasth Bharat Task Force, Executive Chairman, Dr. Lal Path and Managing Trustee, ALVL Foundation, and Dr. Narottam Puri, Advisor, Ficci Health Services and MVT Committees, Principal Advisor, QCI, Board Member and former Chairman, NAB, Advisor, Medical Operations, Fortis Healthcare Limited. Please extend a very warm welcome to everyone with a big round of applause. We also request Dr. Mahesh Joshi, Co-Chair, Ficci Health Services Committee and President and CEO, Apollo Home Care, to kindly step on the dais, please. Thank you. Ficci Heal is a platform for health, enterprise, and learning that unites CEOs, entrepreneurs, technologists, policymakers, both domestic and international healthcare leaders, and professionals from healthcare and allied fields with the aim to highlight exemplary approaches and revolutionary solutions in the realms of technology, innovation, policies, and programs in order to contribute towards making quality healthcare affordable, accessible, and inclusive. Without further ado, I request Dr. Harsh Mahajan to welcome the Honorable Minister, sir, by gifting a shawl. Thank you. I also request Dr. Harsh to kindly present the green certificate on behalf of Ficci. With this, we pledge to plant a group of trees at the Trees for Tigers, Sundarbans National Park, West Bengal. Thank you. I would now request Dr. Sanjeev Singh to welcome Dr. Ajay Singh with a green certificate. Thank you very much. I now request Dr. Narottam Puri, Advisor, Ficci Health Services and MVT Committees, Principal Advisor, QCI, Board Member and former Chairman, NAB, Advisor, Medical Operations, Fortis Healthcare, to deliver the welcome note.
Good afternoon, everyone. Professor S.P. Singh Baghel, Honorable Minister of State, Ministry of Health, Family Welfare, Government of India. Professor Ajay Singh, Senior Associate Dean for Postgraduate Medical Education and Director of MMCI, Harvard Medical School, Boston. Dr. Harsh Mahajan, Chair, Ficci Health Services Committee and Founder and Chief Radiologist, Mahajan Labs. Honorary Brigadier Dr. Arvind Lal, Chair of Ficci Health Committee of the Swasth Bharat Task Force, Executive Chairman Dr. Lal Pathlab, and Dr. Sanjeev Singh, Co-Chair, Ficci Health Services Committee, Medical Director, Amrita Medical Institution, Faridabad, and Chief Medical Superintendent of AMR SCI RC, Kochi. Distinguished dignitaries, speakers, delegates, students, ladies and gentlemen. It is with immense pleasure I welcome you all to the 17th edition of Ficci's annual healthcare conference, the Ficci Heal, on the theme Healthcare Metamorphosis. India's healthcare system has undergone remarkable metamorphosis, evolving and transforming over the years from a modest healthcare infrastructure to becoming a beacon of medical advancements. India has made significant strides in enhancing access to quality healthcare services and achieving better health outcomes. The transformation is visible in multiple dimensions, both in terms of healthcare infrastructure. India has witnessed an impressive expansion of hospitals, clinics, and specialized healthcare centers, resulting in improved accessibility to quality healthcare services. And the sector has also embraced innovation and research, contributing to global medical advancements. Indian scientists and researchers have made noteworthy breakthroughs, including the development of indigenous vaccines and medical technologies. Who can forget the recent COVID epidemic? Technological advancements and digital technologies have brought about a paradigm shift in healthcare delivery, especially in remote and underserved areas. Medicine has benefited from machine learning algorithms, AI, and predictive analytics, as well as genetics, and these are being utilized to analyze vast amounts of patient data, enabling more accurate diagnoses and personalized treatment plans. Government initiatives have played a pivotal role in transforming India's healthcare landscape. Whether it is Ayushman Bharat or the National Health Mission, along with the numerous elements that go into providing care for a large percentage of population, I'm happy that we are moving closer to universal healthcare. Through the Union Budget of 2023, the government has provided a blueprint to steer the economy over the 25 years of Amrit Kal and initiatives to enhance healthcare infrastructure, particularly by expanding nursing colleges and investing in artificial intelligence and digital education, launching a mission to eliminate sickle cell anemia and increasing focus on research and innovation. While India's healthcare metamorphosis has been impressive, challenges persist. Addressing regional disparities, strengthening healthcare infrastructure, and ensuring equitable access to healthcare services needs to be an ongoing priority. Ficci's Health Services Committee has been working with the government, the Ministry of Health and Family Welfare since the year 2006, and for many of these reforms, and has spearheaded in the fields of quality, standardization, electronic health records, digital health, healthcare innovations, healthcare workforce strengthening, nursing reforms, medical ethics, patient centricity, and cancer care infrastructure. The committee has also held numerous consultations with members to provide feedback and recommendations on various policy measures and has supported all major initiatives of the government, including national health policy, Ayushman Bharat, digital health, medical education, TB Mukt Bharat, and so on. The Ficci Heal conference has come a long way. As I said, it is the 17th edition. It has become a creditable platform for disclosing and discussing numerous challenges, as well as the opportunities created in the sector by both public and private sector. Given the strong role of private healthcare in our country, it is also important that we underscore the challenges that are faced by the industry in order to make our public-private collaborations more effective. Sustainability and viability have been a crucial concern for all healthcare providers, especially under the public health insurance schemes, since quality of care provided should be an imperative. Ficci has been advancing and advocating for a scientific study to be conducted for determining the cost of healthcare. Appropriate reimbursement rates will not only help to increase the private sector participation in the ABPMJ-AY scheme, but will also enable them to cater to the larger population, including the missing middle class. And that is approximately 400 million Indians that need health cover. Further, while substantial work has been done in operationalizing the health and wellness centers, the government can further encourage partnerships with the private sector and leverage their capabilities and strength to efficiently run the HWCs in priority areas such as ensuring availability of all sanctioned manpower, availability of essential drugs and diagnostic services, as well as referrals, which are important in certain degree to some patients. Ficci has already initiated an industry-wide movement for demonstrating smart HWCs, and I'm happy to share that we are working with the state governments of Uttar Pradesh and Chhattisgarh to adopt 30 HWCs in each state under the leadership of Honorable Brigadier Dr. Arvind Lal. I'd also like to highlight another key concern for healthcare providers, GST. Since GST is not payable on healthcare services, healthcare service providers are not eligible to avail credit on the input taxes paid, which ultimately becomes a cost to the service provider. Hence, we request for allowing the hospitals and healthcare facilities to avail the input tax credit through a reasonable 5% GST so that the ultimate cost to the patient is reduced. India, having reasonably navigated the COVID-19 crisis, now stands as a global healthcare exemplar. With substantial investment opportunities, India can emerge as a healthcare hub, attracting foreign patients with high quality, cost-effective services. The government's vision and initiative of Heal in India and Heal by India will not only boost medical value travel in the country, but will also help our medical workforce to travel all over the world and contribute towards a healthy global society. We in the private sector are very happy to contribute to this initiative to help position India as the global healthcare destination in the years to come. This year's Ficci Heal conference will be deliberating on the various avenues and opportunities, as well as effective solutions to tackle the complex challenges. If you don't create the future, and I quote, the present extends itself, unquote. We don't want that for progress. At a time when lifestyle disorders are on a rise, technology-backed public and private affordable healthcare is the only solution to confront the new pool of diseases. The future healthcare, its service design and delivery requires reimagining healthcare, making it more personal, collaborative, and integrated, enabled by digital capabilities. This can only happen through innovations and ideas. And in an area or in an era where healthcare has been a huge focus, and when wars are being fought, we can discuss ideas because ideas, quote, are bulletproof, unquote. I warmly welcome all of you to this multi-stakeholder knowledge sharing platform. We gather today and tomorrow to share each other's stories. As Namita Gokhale said, we are each other's stories. Our success, our failures, and our challenges are what we need to discuss together. I hope that your collective contributions and encouragement and engagement will encourage more and more such dialogues and drive positive change in the future healthcare metamorphosis. Enjoy the 2 days. Thank you very much.
Thank you very much, Dr. Puri, for your warm welcome note with valuable insights on the concerns and recommendations for the sector and for setting the stage for sharing our stories. Ficci, as a thought leader, has been providing policy suggestions and has garnered collaborations on numerous significant healthcare issues, including quality, affordability, access of healthcare services, roadmap for universal health coverage, preventive and primary care, skill gaps in medical education, non-communicable diseases including cancer, technology, innovations in digital health, sustainability of industry, as well as public-private partnerships. To share insights of Ficci's work this year and his expert views on the theme of the conference, I now call upon Dr. Harsh Mahajan, Chair, Ficci Health Services Committee and Founder and Chief Radiologist, Mahajan Imaging Labs.
Professor S.P. Singh Baghel ji, Dr. Narottam Puri, my teacher, Dr. Ajay Singh, who's here from Harvard Medical School, Dr. Arvind Lal, Dr. Sanjeev Singh, Dr. Mahesh Joshi, esteemed speakers, participants, partners, students, ladies and gentlemen. सबसे पहले तो मैं मंत्री जी का बहुत आभारी हूं कि आपने समय निकाला, ये इलेक्शन के दिन है, आप हैदराबाद में थे, हमारे आग्रह पे आप यहाँ आए, अभी आप 1 बजे लैंड किए हैं और 5 बजे आपने फिर वापस जाना है. We are all very, very thankful that you've come, taken this time out. Over the past few years, the Indian healthcare industry has undergone profound transformation. The theme for Ficci Heal 2023, Healthcare Metamorphosis, encapsulates the rapid evolution, adaptability, and resilience that have become intrinsic to our healthcare ecosystem. It appears that healthcare ecosystem in this country always rises to the occasion. It symbolizes the continuous cycle of change, renewal, and growth that defines healthcare in the 21st century. The COVID-19 pandemic, which impacted every aspect of our lives, has been a catalyst, testing the mettle of our healthcare systems. It compelled us to rethink, reimagine, and reinvent our approaches to healthcare delivery, public health infrastructure, and the use of technology. It was a catalyst for metamorphosis in the healthcare sector, pushing us to embrace digital health, telemedicine, and data-driven solutions on a scale never seen before, not only in this country, but probably anywhere in the world. The theme healthcare metamorphosis has broader implications than just dealing with crises. It signifies a shift from a curative, disease-centered approach to a more holistic, patient-centric model of healthcare. It emphasizes preventive healthcare, predictive healthcare, early intervention, and a focus on wellness rather than merely treating illness. Furthermore, the metamorphosis in healthcare is deeply rooted in the adoption of emerging technologies such as artificial intelligence, genomics, and precision medicine, which are revolutionizing diagnosis, treatment, and healthcare management. These technological advancements are driving unprecedented improvements in patient care, drug discovery, and healthcare research. They demand that we consider the ethical, legal, and social implications of these advancements and ensure that healthcare remains accessible, equitable, and compassionate. This Ficci Heal conference intends to bring to the forefront these future models and strategies. The conference sessions over the 2 days will not only provide a forum for sharing of learning and experiences, but an opportunity to actively engage in the discussions and deliberations that will set a path for healthcare is not just responsive to challenges of today, but resilient in the face of those of tomorrow with technology as our guiding light. The various sessions would include deliberations on themes like new age healthcare delivery models, roadmap for making cancer care affordable and accessible in India, fostering resilient economics, and with a focus on demystifying balance sheets, financing and viability in public health, sustainability strategy, sustainable business models, which I think are very, very important because as increasingly governments across the country become both the users as well as payers of healthcare delivery, large healthcare systems are facing problems of viability and sustainability. We will also talk on process efficiency improvement, fireside chats on driving investments in healthcare and leveraging technology for transforming primary healthcare and perspectives on healthcare from those who are outside from other industries than the healthcare industry. There would also be a stakeholders consultation on women and health called Empowering Her Health. During the course of these 2 days, we will also release our knowledge paper that has been developed over the past few months with the support of our members through our task force on new age healthcare delivery models in collaboration with KPMG. The paper brings out how multiple enablers are laying the foundation for new age healthcare delivery models to overcome the challenges and bring more resilience in Indian health systems. It also highlights the mechanisms in which the new age healthcare delivery models can alleviate burden from government, healthcare providers and caregivers by streamlining care delivery, leveraging technological integration, and offering tailored solutions. I would like to thank Mr. Lalit Mistry, partner and co-head, Healthcare Sector KPMG India, and his team for their wholehearted support in developing the papers and multiple consultations, interviews, and surveys that they have administered for the paper. I would also like to share with you all that Ficci, under its multi-stakeholder task force on cancer care, in collaboration with Ernst & Young, has developed a report last year on call for action, making quality cancer care more accessible and affordable in India. This has been recognized as a crucial step in promoting proactive cancer prevention and treatment measures. This year, the task force presented this report and garnered further suggestions from stakeholders across the country through regional roundtables under the aegis of the Ministry of Health and Family Welfare, Government of India. The first regional roundtable was held in Gujarat for the Western region under the chairmanship of Shri Vishal Chauhan, Joint Secretary, Ministry of Health and Family Welfare, Government of India. The Southern Region Roundtable was held in Bengaluru and was graced by the virtual presence of Sri Dinesh Gundu Rao, Honorable Minister, Health and Family Welfare, Government of Karnataka. During the roundtable, comprehensive 9-target strategy as part of the Bengaluru Declaration of Ficci Cancer Care Task Force was unveiled by Mr. U.T. Khadar Farid, Honorable Speaker of the Karnataka Legislative Assembly. Further, you will be happy to know that Ficci is launching an initiative on women and health titled Empowering Her Health in collaboration with Apollo Hospitals, UN Women, and BMGF. It will be launched tomorrow by the Honorable Minister of State for Health and Family Welfare, Dr. Bharti Praveen Panwar, and Honorable Minister of Niti Aayog, Dr. V.K. Paul. I assure the government and the industry that we will keep striving for fruitful collaborations and partnerships amongst all stakeholders with the aim to build a transformed healthcare ecosystem for our country. I'm also delighted to share that the 15th Ficci Healthcare Excellence Awards that will be held tonight have emerged as the definitive recognition for contribution to healthcare in this country over the last few years based on innovation, impact, sustainability, and scalability, which forms the key criteria for evaluation. This year, the jury has been chaired by Shri C.K. Mishra, former Secretary, Ministry of Environment and Forests, and Health and Family Welfare, Government of India. The chief guest for the award ceremony is Ms. Sharmila Tagore, and we look forward to all of you joining for the award ceremony at the Hotel La Meridian in the evening at 7 p.m. I hope that this year's Ficci Heal conference will be a useful platform for you all to discuss partnerships, share best practices, and deliberate on the future roadmap for India's healthcare journey. Thank you very much. Jai Hind.
Thank you, Dr. Mahajan, for sharing the overall conference agenda as well as its various features. I must take this opportunity to thank all the members and associates of Ficci in the healthcare sector for the immense support, cooperation, and guidance in all Ficci health initiatives. Apart from the leadership on the dais, I would like to also acknowledge Mr. C.K. Mishra, mentor, Ficci Swasth Bharat Task Force, Dr. Mahesh Joshi, Dr. Arun Agarwal, Dr. Y.P. Bhatia, Dr. Ravi Gaur, Dr. Nandakumar Jairam, Dr. Vishnu Panigrahi, Dr. Om Manchanda, Dr. Anupam Sibal, Mr. Raj Gaur, and many others for their constant support to the committee initiatives. Moving further, I'm happy to share with you that we have a special guest this afternoon, Dr. Ajay K. Singh, Senior Associate Dean for Postgraduate Medical Education, Director, Medical Sciences and Clinical Investigation Program, Harvard Medical School, who has specially flown in early morning to be with us today. He leads a vibrant group of faculty and staff in developing and overseeing postgraduate medical education at HMS, as well as the master's program in clinical investigation. Amongst his numerous achievements, he has been executive director for the Dubai Harvard Foundation of Medical Research since 2008. Dr. Singh is a fellow of the Royal College of Physicians in London and has an MBA from Boston University. I would like to invite Dr. Ajay K. Singh to give his keynote address on leadership, insights on capacity building and scalability in healthcare.
Thank you very much for that kind introduction. Firstly, I'd like to thank the Minister of State for Health for gracing us with this. Thank you, and Professor S.P. Singh. Also, want to thank Dr. Sanjeev Singh for arranging this invitation. He personally invited me. I really appreciate that. Thank you, and also Dr. Harsh Mahajan for chairing this, and all the members of the Ficci Health initiatives and committees, and of course the organizers of this conference. I'm honored to participate in the 17th version of this important conference. So when Sanjeev asked me to speak on an issue of how to scale healthcare, I reflected about all my many visits to India for many years, but also what trends that are happening in the United States. Because although I'm of Indian origin, I live and work and have for many years in the US, and one of the roles that I've been tasked is how to keep us ahead of everyone else in the game globally and institutionally. So I looked at what are the things we're doing and what are the lessons from those things that might impact or you may want to think about as you embark on this next journey, this metamorphosis of healthcare. I'm going to use a few slides. If you put the slides up. So I can go to the next slide. This is not working. There we go. So the challenges in healthcare right now, I think, would be fair to say, are listed on this slide. And these challenges, I think, are well known to everyone here. These are challenges that are present wherever you live in the world. There's, as you can see, rapid advances in medical research and innovation. The doubling time for medical knowledge has just gone down to a couple of years now. So every 2 years, medical knowledge in many fields doubles in terms of publications and in terms of advances. So it's keeping up and has been difficult, and newer drugs are coming and newer devices that make healthcare quite expensive. The population is getting older, whether it's in India or in the United States. There's growing demand for healthcare, and the costs are rising. Nearly 30% of the US's GDP is expended on healthcare, compared to around 7% of the GDP in the UK. So we spend a large amount of money on healthcare in the United States. And there are workforce constraints like you have here, we have them as well. Go to the next slide. This slide just shows you the healthcare challenges that India faces as you look from outside. There's unequal access, there's issues around affordability. Healthcare spending is continues to be a challenge, and there's shortage of healthcare professionals. On the figure on the right, you see that India has, in terms of doctors per million population, one of the lowest density rates globally. And if you look on the left-hand side, you can see the expenditure that is being spent by the government of India on healthcare, and it continues to rise each year and will continue to rise. It's still not 30% of GDP for the country. So there's a lot of inefficiency in the US, and there's a lot of opportunity in India for getting, as access increases and the population ages, healthcare will become a bigger and bigger part of the central government's budget. When you look at rapid transformation, Mudit Dandavati, who was the CEO and co-founder of Josie, said, we have almost 100 million people in this country, in India. All the high-risk disease populations are increasing. And we look at the population of doctors and nurses, it's not really increasing, and we already have a deficit in India. And AI needs to play a big part. And so, Dr. Mahajan and others, and Dr. Puri have already mentioned that AI is where the opportunity is. And if there's one message I have to share with you, it is that AI is where we also see the solution to scalability. If you look at the top 5 institutions in healthcare, ecosystems, health systems in the United States, on average, we're investing about $1 billion a year on AI and AI solutions. That's a lot of money being spent per institution, per health system currently on AI. And the largest number of growth in terms of new startups and companies and new investment happening in technology currently, not only in healthcare, but more broadly in the United States, is in AI and AI solutions. So AI is going to be the answer. What's interesting is that while India is at one of the largest providers of technology solutions, particularly in the service areas globally, in AI, it unfortunately still lags behind. And that's been recognized, obviously, by the government and others, but that's where the challenges are going to be for the future. If you look at how the world has evolved over the last 1,000 years, perhaps, you can see on this graph that in the early part of the revolution started with the printing press revolution, right? And then we went into the Industrial Revolution. And as you see from this figure, you see that there is now the multiplier from a 4-fold growth in GDP per century to a 20-fold growth in GDP in a century. The solution to that is also AI. So it's going to make a difference not only from the perspective of scalability, but it's also going to be extraordinarily profitable if one takes and harnesses the opportunity of AI. Many people are familiar with what artificial intelligence is. Most people don't actually have a lot of expertise in how one creates these algorithms, how one layers on top of machine learning the AI technology that's currently being used. But every single person now coming out of our master's programs and many of our educational programs at Harvard Medical School is getting basic learning on AI and AI solutions, how you do it, what you do, and that is also one part of the solution. How much of that is happening in India among the healthcare community? How many leaders in healthcare here are familiar with the true impact that AI might have on your practice? So AI consists of machine learning, deep learning, and large language models, and each of these technologies has evolved. It has come about in the last 7 years. And as I said, this past year has been an incredible inflection point in the US where healthcare has started to invest large amounts of money in AI and AI solutions. If you look at what happens even around the world, I was just at Heathrow Airport a day or two ago, and you can see we have AI cleaning people now. So AI is not only going to impact what happens in healthcare, but nowadays they've replaced the cleaners at Heathrow Airport. There's these AI-enabled machines that are going around, and you can see the picture on the right-hand side. This machine came across a person who stood right in front of him. The machine stopped, turned it, and moved in the other direction, because these algorithms have been designed to do this. And this type of technology is being used and being deployed now. So if a patient picks up the phone now and calls our institutions, our hospitals, often they get a chatbot who's going to direct them to the right place for their healthcare. New AI-enabled, there's a US FDA-enabled algorithm that allows hospitals to screen through their health system, their patient data to diagnose people with hypertrophic cardiomyopathy. There's AI solutions now. The latest Medtronic CGM, continuous glucose monitoring, is AI-enabled, so that if it will predict what the insulin dose that should be injected into the patient, given the meal that that person has had. Not wait just for the blood sugar to be detected, but to predict what the blood sugar will be after that meal, given the timing of the meal, and how you should deal with it. These are the sort of things that are currently being deployed as we speak in the United States in healthcare. So where is the future of work, and especially healthcare work with artificial intelligence? It is in every aspect of healthcare. And to us, that's what we're doing. It's in education. We are using AI in screening candidates to come to Harvard Medical School using AI solutions. We are trying to detect whether people are using AI to write their personal statements. It turns out that we have now put policies together and questions so we can detect whether someone writes an AI-generated personal statement for an application to gain admission to Harvard. We are using AI for research, so consent forms are being developed using AI so that they can be very basic consent forms, trying to discover and predict which patients are likely to respond to therapies that they will be tested for in clinical trials is now becoming AI-enabled. We're using AI for various functions in the hospital, so almost all the repetitive tasks are being reviewed to eliminate repetitive tasks in the hospital, from imaging, diagnostics, and other things with AI solutions. And increasingly, we're looking at the role that AI may play for individual decision support for physicians. So that, for example, I have a funded project at my institution where we're trying to predict who among those individuals with a diagnosis of diabetes will need guideline-directed medical therapy, detect them and send them to care before they present with some of the complications of diabetes, predicting who is going to be requiring treatment. These are the sort of implications and impact that's already happening in our institutions. We're also using AI for billing procedures. So rather than figuring out how and what types of patients generate the greatest amount of cost in terms of care, we're using AI to predict, using models to predict who those patients are, so that those patients will, using AI algorithms, be patients who will be billed higher amounts of money for the care they provide. So there's a whole number of things, and you can see the impact in 2025. We think that AI will generate 3 times as much in terms of investment and potential impact in terms of revenue than it did 5 years previously. In terms of impact of AI, so 25% of businesses in the US have integrated AI into operations already. 91% of leading businesses are spending on AI. 64% of companies have implemented AI and seen productivity increase. 77% of people use services or devices that is AI-powered currently in the US in healthcare. So that's the impact that AI has already had. And if it's not happening in this country now, and you're not thinking about doing it in the next 2 years, you will be lagging behind. And then if you survey, 86% of company leaders say that AI is or will be mainstream in their organizations. 64% of executives embrace AI and happy with it. And 75% of executives are afraid that they do not go out, that are afraid they will go out of business in the next 5 years if they don't implement AI in their organizations. And by 2030, AI will contribute $15.7 trillion to the US, to the world economy. I'm just going to leave for you one slide, which I will just share with you, and then I will close my talk. Let me just go to this next slide. And this is the slide that I want to just close with. It's the cover of Time magazine earlier this year, and it shows AI by the people and for the people. And there is a quote from Sri Narendra Modi, our Prime Minister here, who says, quote, "We want India to become a global hub for AI." And I think the opportunity is that India could become a global hub for AI in healthcare as well, because we have the people to in this country to do it. It requires investment, it requires commitment, but it's certainly possible. And if it doesn't happen, India will lag behind countries like the United States that are spending huge amounts, both at the national level, but also at the institutional level, as I shared with you. Thank you very much.
Thank you very much, sir, for your exceptional insights and the enlightening keynote address. Let's now move on to the next key feature of the conference, the release of knowledge paper. This year, a task force was formed under the Ficci Health Services Committee on New Age Healthcare Delivery Models. We are thankful to the members and the knowledge partner, KPMG, for developing the paper, which is being released today. I request Honorable Minister Sir, Professor S.P. Singh Baghel ji, to kindly join us to release the knowledge paper. I would like to call the Chair of the Task Force on New Age Healthcare Delivery Models, Dr. Mahesh Joshi, Co-Chair, Ficci Health Services Committee and President of CEO, Apollo Home Care, and call upon stage Mr. Lalit Mistry from KPMG and Mr. Naveen Agarwal, Office Managing Partner, Delhi NCR KPMG in India for the release. Gentlemen, join them. Yeah. We can have the louder round of applause for the work because it was immense. Thank you, gentlemen. This Ficci KPMG report highlights emerging healthcare delivery landscape in India and aims to understand the influence of changing healthcare determinants and related challenges which have paved the way for a blended healthcare industry. The report brings out how multiple enablers are laying the foundation for new age healthcare delivery models to overcome the challenges and bring more resilience in the Indian health system. It has been led by Mr. Lalit Mistry, Partner and Co-Head, Healthcare Sector, KPMG Advisory Services. We are thankful to the entire team for their support and efforts over the past few months. Thank you. And now we come to the much awaited part, the address from the Guest of Honor of Ficci Heal 2023. Professor Satyapal Singh Baghel, Honorable Minister, Sir of State, Ministry of Health and Family Welfare, Government of India. Prior to this, he was a Minister of State with Union Ministry of Law and Justice and was member of Lok Sabha from Agra. In 2017, he became a member of the Legislative Assembly of Uttar Pradesh representing BJP. In 2015, he became the president of BJP OBC Morcha. He has a Bachelor of Law degree, a Master's degree in Science, and a doctoral degree. He attended Maharaja Jivaji Rao University in Gwalior, Madhya Pradesh, and the Meerut University in Meerut, Uttar Pradesh. I now invite Honorable Minister Sir to give his address.
Seventeenth Annual Healthcare Summit फिक्की द्वारा आयोजित हेल्थ केयर मेटामॉर्फोसिस की सेमिनार में मंच पर विराजे ब्रिगेडियर डॉक्टर अरविंद लाल साहब, डॉक्टर संजीव सिंह जी, डॉक्टर अजय कुमार सिंह, डॉक्टर हर्ष महाजन जी, डॉक्टर नरोत्तम पुरी जी, डॉक्टर महेश जोशी साहब, हेल्थ केयर सेक्टर के विभिन्न क्षेत्रों में काम करने वाले सभी देवियों एवं सज्जनों, मेरा सौभाग्य है कि हेल्थ केयर के विषय में फिक्की द्वारा 2 दिन की ये जो सेमिनार आयोजित की गई है, हेल्थ केयर के विशेषज्ञ लोग इसमें शामिल हुए हैं। आपकी 2 दिन की वैचारिक मंथन से जरूर कोई ना कोई अमृत निकलेगा जो मानवता के काम आएगा, मरीजों के काम आएगा, गरीबों के काम आएगा और हेल्थ सेक्टर में लाभदायक होगा। फिक्की अपने तमाम क्षेत्रों में काम करने के लिए जानी जाती है। मेरे लिए खुशी की बात है कि पॉलिसी सजेशन में उनका बड़ा रोल रहता है। भारत सरकार जो हेल्थ केयर की नीतियां बनाती हैं, आपके महत्वपूर्ण सुझाव हम लोगों को मिलते रहते हैं और सब विषय विशेषज्ञ लोग जब फिक्की की इस हेल्थ केयर जो देख रहे हैं, मंत्रालय लाभान्वित होता है और हमारी पॉलिसी बनाने में आपका सहयोग है, इसके लिए मैं आभार प्रकट करना चाहूंगा। हेल्थ का कई चीजों से बड़ा गहरा संबंध है। इसका गरीबी से भी संबंध है, इसका स्वच्छता से भी संबंध है, कुपोषण से भी संबंध है, धुएं से भी संबंध है, पर्यावरण से भी संबंध है और कई चीजों का सीधा रिश्ता है। प्रधानमंत्री जी ने इसका महत्व समझते हुए 2014 में शपथ लेने के बाद 15 अगस्त को जो लाल किले से वो शब्द बोला जिसको बोलने से लोग कतराते थे, वो शौचालय के लिए उन्होंने अपनी बात कही। क्या उसका हेल्थ से संबंध नहीं था? अगर आप का जरा भी रिश्ता किसी गांव से रहा होगा कभी, तो हमने सड़क पर शौच करते हुए, नहीं तो ट्रेनों के किनारे देखा होगा आपने, सड़क पर शौच करती, खेतों में शौच करती हुई महिलाओं को देखा था। ये गंदगी भी बीमारी का एक बड़ा कारण थी। शुरू के प्रधानमंत्रियों ने ज्यादा देखा होगा, तब हम ज्यादा गरीब थे, लेकिन ये विचार क्यों नहीं आया था? मैं इसको अपना सौभाग्य मानता हूं कि मैं एक 35 घरों के छोटे से गांव में पैदा होकर के यहां तक आया हूं, इसलिए बड़े अच्छे अनुभव हैं। सड़क पर शौच करती हुई महिलाओं को क्या, अपने घर में दादी नानी को और माओ को देखा। उससे ज्यादा दुर्भाग्यपूर्ण होता था अचानक गांव के किसी बुजुर्ग आदमी के उस रास्ते से गुजरने पर उनको खड़े होते हुए देखा। ये भी देखा कि जब वो बैठी होती थी तो कोई मोटरसाइकिल रोशनी वाली अगर निकलती थी या कार, तो अचानक खड़े होते हुए देखा। भारत में कहा जाता है कि भोजन करते हुए कोई भी आ जाए, हमें खड़ा नहीं होना है। भोजन करते हुए खड़े होने पर ना तो कपड़े खराब होंगे और ना पेट खराब होगा, लेकिन शौच करती हुई महिला अचानक, ये कोई स्विच ऑन स्विच ऑफ नहीं है। इसको मैं वहां से जोड़ रहा हूं कि ये 3.5 करोड़ शौचालय बने हैं और अब हम खुले में शौच मुक्त भारत हो गया है। इसका भी बीमारी से गहरा संबंध था जिसमें कमी आई होगी। पुलिस की नौकरी के दौरान अगर बलात्कार की एफआईआर के मैटर को मैं पढ़ता था तो उसमें 90% ये लिखा होता था कि हमारी पत्नी, माँ, बहन जो भी है शौच करने गई थी तो बदमाशों ने बुरा काम किया, क्योंकि वो सूर्योदय से पहले जाती थी अंधेरे में और सूर्यास्त के बाद जाती थी। इस अंधेरे का फायदा बदमाशों ने भी उठाया। उसको सही शब्द दिया गया है, वो अब इज्जत घर है। तो ये 3.5 करोड़
लोग अभी तक उनके घर में ये नहीं था, तो बाहर जब जाते होंगे तो तमाम गंदगी होती होगी, उसका बीमारी से संबंध रहा होगा। मैं केवल इन विशेषज्ञों से एक बात कहना चाहूंगा कि इस सभागार में, मैं डॉक्टर नहीं हूं इसलिए जरा भी टेक्निकल सेशन में घुसने की कोशिश नहीं करूंगा और ना मुझे उसका ज्ञान है, लेकिन मुझे लगता है कि पूर्व जन्म में कुछ अच्छे काम किए होंगे, मंत्री बने, लेकिन ज्यादा अच्छे काम किए होंगे कि स्वास्थ्य विभाग देखने को मिल रहा है। ये आपका भी ये पूर्व जन्म का प्रारब्ध है और मेरा भी, कि आप हेल्थ सेक्टर में काम कर रहे हैं। यहाँ सड़क के ठेकेदार बैठे होते तो ठीक है, आप या बिजली के इंजीनियर लोग बैठे होते, अंधेरे से बिजली में ला रहे होते, कच्चे से पक्के में लाने वाले निर्माता होते, लेकिन आप हेल्थ केयर से जुड़े हुए हैं जिसका बहुत बड़ा संबंध है। मैं उत्तर प्रदेश में वेटनरी मिनिस्टर था, तो एक हेल्थ मिनिस्टर के साथ मंच शेयर कर रहा था, तो मैंने कहा 84 करोड़ योनियां हैं, 83 करोड़ 99,999 का मिनिस्टर मैं हूं, क्योंकि मैं रेप्टाइल्स का भी मिनिस्टर हूं, मैं पक्षियों का भी मंत्री हूं, मैं एनिमल्स का भी तो हूं ही, केवल इंसान के आप हो। ईश्वर ने मेरी सुनी, अब इंसानों का भी मैं हूं, तो 84 करोड़ सारे को कवर करने वाले मंत्रालय मेरे पास रहे हैं। बहुत भाग्य होता है जब इंसान का शरीर मिले, और उससे ज्यादा भाग्य होता है उसको मरने से बचाया जाए। ये मेरे जीवन की पहली प्रायोरिटी है कि किसी बीमार का समुचित इलाज करा सके। इसलिए एम्स के डायरेक्टर ने, जब मैं मिनिस्टर नहीं था, तो एक दिन फोन करके ये कहा कि मैं जानना चाहता हूं कि देश के 500 एमपी जितनी रिकमेंडेशन करते हैं उतनी आप अकेले करते हैं, और सारी चिट्ठियां आपकी हाथ की लिखी हुई हैं, तो कितने पीए रखे हैं? मैंने कहा नहीं, ये सब चिट्ठियां, और कहा जितनी चिट्ठियां हैं उनकी राइटिंग एक है, तो इतने सारे पीए लोग एक राइटिंग में कैसे लिख सकते हैं? तो मैंने उनसे कहा सब चिट्ठियां मेरे हाथ की लिखी हुई हैं। इतवार का दिन मैंने रखा है कि एक पेड़ के नीचे बैठता हूं, जिससे कोई सिक्योरिटी वोटी का भी बहाना ना चले। 14 लोकसभाएं आती हैं, जीता एक लोकसभा से हूं, जिसमें बड़ी संख्या होती है कि लोग, बीमार लोग अपने इलाज के लिए या तो प्रधानमंत्री कोष से पैसे के लिए, या मुख्यमंत्री विवेकाधीन कोष से, अथवा अस्पतालों में एडमिशन के लिए ज्यादातर आते हैं। सड़क, स्कूल, बिजली, पानी, नाली, खरंजा, ये फाइनल रिपोर्ट, चार्जशीट, बंदूक का लाइसेंस, विधवा विकलांग पेंशन तो आएगी, लेकिन बीमार लोग जरूर आते हैं। तो थोड़ी सी हमें ये जिम्मेदारी महसूस करनी है कि इस देश में 80 करोड़ लोग, बहुत बड़ा आंकड़ा है, 5 किलो गेहूं चावल मुफ्त का लेने के लिए लाइन में लगते हैं। हमेशा जेहन में ये लोग रहने चाहिए। 3.5 करोड़ लोग केवल 20,000 का शौचालय के लिए प्रधान के घर लाइन लगाए। अगर प्रधान भी माने तो उसमें से 1,000 रुपये भी मार देता है, उसमें से 20,000 का, जितने ठीक से वॉश बेसिन नहीं आता है। केवल 2.5 लाख रुपए का प्रधानमंत्री ग्रामीण आवास बनता है, उसको भी 7 करोड़ लोगों ने आवेदन किया है, केवल 2.5 करोड़ का। शहर में 3.5 करोड़ का। मोदी युग से पहले 9 करोड़ लोगों के घर में गैस ही नहीं थी, तो लकड़ी पर, ढेंचा पर, खांडू पर, तोई पर, कंडों पर खाना बनता था। क्या उस धुएं का टीबी से कोई संबंध नहीं रहा होगा? क्या उस धुएं का मोतियाबिंद से या आंखों की बीमारी से कोई संबंध नहीं रहा होगा? 9 करोड़ उज्ज्वला योजना में हम लोगों ने उनको दिया। ये सबको मैं हेल्थ से जोड़ रहा हूं। अगर एक कोई पत्रकार मुझसे ये पूछे कि मेरे 6 कार्यकाल के पार्लियामेंट के दौरान विभिन्न तीसरे प्रधानमंत्री जी के साथ में काम कर रहा हूं, कोई एक योजना बताएं जो आपको सबसे अच्छी लगी, तो मैं अपने कार्यकाल की बात नहीं करूंगा। मैं आजादी के बाद तमाम अच्छे काम हुए हैं, लेकिन नंबर 1 पर मैं देना चाहूंगा आयुष्मान भारत प्रधानमंत्री जन आरोग्य योजना का आयुष्मान कार्ड, इसको मैं नंबर 1 पर देना। 5 लाख रुपए प्रति व्यक्ति प्रति साल, पूरे खानदान का इलाज। मैंने आपसे अर्ज किया है कि मैं गांव से आया हूं, इसलिए थोड़े अनुभव मेरे बड़े सही वाले अनुभव हैं। हम देहाती लोग बीमार होने पर एक दिन तो बीमारी को नोटिस में नहीं लेते, दूसरे दिन चाय में तुलसी डाल करके अपने जुकाम को ठीक करने की कोशिश करते हैं, तीसरे दिन काढ़ा से काम चलाते हैं, चौथे दिन जेब में डले हुए रुपयों के अनुसार डॉक्टर का चयन करते हैं। पैसे वाले लोग बीमारी के अनुसार विशेषज्ञ डॉक्टर का चयन करते हैं। ये जो 80 करोड़ लोग हैं, ये अपनी जेब के अनुसार डॉक्टर का चयन करते हैं। कई बार डॉक्टर कहता है, एक मेरे निजी विचार हैं, कई बार कहा जाता है कि आप बोल रहे हो तो सरकार बोल रही है, तो मुझे कहना पड़ता है कि ये मेरे निजी विचार हैं कि शिक्षा और चिकित्सा समान होनी चाहिए। काश ऐसा हुआ होता तो आज भारत विकसित राष्ट्र बन चुका होता। 47 में देश आजाद हुआ, थोड़ा विषय से हट रहा हूं। अगर समान शिक्षा हो जाती, प्रथम राष्ट्रपति जब हमने मौलिक अधिकार समान दिए हैं, मौलिक कर्तव्य दिए हैं, राज्य के नीति निर्देशक तत्व दिए हैं, विचार और व्यक्ति की स्वतंत्रता समान दी है, संपत्ति को खरीदने का अधिकार समान दिया है, आदि आदि आदि, पूजा पाठ का अपना अधिकार दिया है, तो समान शिक्षा हो जाती, केवल कॉमन एजुकेशन। प्रथम राष्ट्रपति राजेंद्र प्रसाद जी का नाती और राष्ट्रपति भवन के चपरासी का बच्चा, दिल्ली के मंत्री का और संतरी का और कमिश्नर का और सिपाही का और नगर सेठ का और भिखारी का बच्चा एक ही हॉल के नीचे एक ही सिलेबस, एक ही पढ़ाई कर रहे होते, तो आज देश का दूसरा रूप होता। क्या ऐसा होना चाहिए था? आप जिस हार्वर्ड की बात कर रहे हैं, से आए हैं, कैम्ब्रिज, हार्वर्ड और ऑक्सफोर्ड, मानना पड़ेगा पहले प्रकार के विश्वविद्यालय हैं। अभी हमारे शिक्षा मंत्री ने सदन को सूचित करते हुए प्रसन्नता व्यक्त की, हमारा एक आईआईटी 37वें नंबर पे आ गया है। पूरे सदन ने ताली बजाई। मैं चुपचाप बैठा था तो मेरे पड़ोसी मंत्री ने कहा, आपको खुशी नहीं हुई? मैंने कहा, दुख हुआ है। ये नालंदा का देश है, ये तक्षशिला का देश है, ये विक्रमशिला का देश है। बख्तियार खिलजी जिस साल नालंदा विश्वविद्यालय को जला रहा था, संयोग है कि उसी साल गोरे लोग फावड़ा लेकर के ऑक्सफोर्ड विश्वविद्यालय की नींव खोद रहे थे। इतने साल पीछे ये लोग। हमारी 3 मंजिल की लाइब्रेरी 3 साल तक जलती रही, इतनी किताबें थी, बल्कि मैं कह सकता हूं कि सब कुछ जल गया, क्योंकि पेन ड्राइव नहीं थी। लगभग सब जल चुका है। जो याद था थोड़ा बहुत बचा हुआ, वही बचा है, और उसी से आज हम लोग बहुत अच्छी पोजीशन में। जब से वैश्वीकरण, उदारीकरण और निजीकरण हुआ है, हार्वर्ड और ऑक्सफोर्ड में भी मोबाइल से एडमिशन लिया जा सकता है, फीस जमा की जा सकती है और क्लास भी ली जा सकती है। भारत के संदर्भ में ये सामाजिक जिम्मेदारी के लिए भाषण दे रहा हूं आपको कि सोशल रिस्पॉन्सिबिलिटी हम लोग महसूस करें। भारत में देहरादून का दून स्कूल, अजमेर का मेयो कॉलेज, ग्वालियर का सिंधिया और नैनीताल का शेरवुड टाइप के पहले प्रकार के हैं। फिर पीटर्स पैट्रिक, चार्ल्स जॉर्जी, जीटी गोयनका टाइप के दूसरा स्तर है। फिर कुछ अंग्रेजी नाम रख करके नीली पीली टाई लगा करके कुछ पढ़ाते हैं, वो तीसरे हैं। और लास्ट वाले वो हैं जिसमें मैं पढ़ के आया हूं, अपनी टाट पट्टी ले जाकर जिला पंचायत के स्कूल में। काश समान शिक्षा होती। दूसरी गलती दिल्ली वालों ने बहुत की है देश के साथ। हम उत्तर भारत के लोगों को क्लास 6 में 11 साल की उम्र में अंग्रेजी दिखाई गई थी। अल्फाबेट हमने सीखे हैं जब हम 11 साल के हो गए थे, क्लास 6 में। वहीं पर 3.5 साल के बच्चे दिल्ली में, मुंबई, कलकत्ता, मद्रास में क्रिश्चियन स्कूल में अंग्रेजी सीख रहे होंगे। दिल्ली जाती करती भी रही है और अच्छा भी करती है। जनरल नॉलेज हमें कभी नहीं पढ़ाई गई। पहला बैच आईएएस का निकला तो जीके अनिवार्य थी और अंग्रेजी अनिवार्य थी, बाकी ऑप्शनल पेपर थे, और दोनों का हमसे कोई वास्ता नहीं था। पता नहीं क्यों, जबकि देश को आजाद करने वाले शुरू के 10 नेता विदेश पढ़ के आए। महात्मा गांधी स्वयं, जवाहरलाल नेहरू, मोतीलाल नेहरू, सरदार पटेल, बाबा साहब भीमराव अंबेडकर, कैलाशनाथ काटजू, नेताजी सुभाष चंद्र बोस, इवन डॉक्टर लोहिया ने जर्मनी से पीएचडी की। जब देश आजाद हुआ था तो ये समान शिक्षा कर देनी चाहिए थी। ये मैं थोड़ा सा वैसे ही बोल रहा हूँ। चिकित्सा समान इसलिए होनी चाहिए कि मनरेगा के 3.5 करोड़ मजदूर या ये 9 करोड़ 80 करोड़ जो गेहूं चावल 5 किलो फ्री का ले रहे हैं, अगर वो बीमार होते हैं, मैं बीमार होता हूँ, रिक्शा चलाने वाला बीमार होता, 2 बीघे वाला किसान बीमार होता और बीमारी एक है, तो क्या इलाज एक सा होगा? मैंने कहा ना कि हम अपनी जेब के अनुसार डॉक्टर का चयन करते हैं। कई बार डॉक्टर के पास जाते हैं, डॉक्टर साहब बुखार आ रहा है, डॉक्टर साहब कहते हैं कि ये 5 दिन वो वायरल है, एंटीबायोटिक कोर्स चलेगा। मैंने खुद सुना है, भाड़ में जाए आपका कोर्स, 75 रुपए में जितनी दवाई आती हूँ उतनी दे दो। तो वो फिर नीली पीली गोली बिना रैपर वाली डब्बे में से कागज की पुड़िया बना के देता है। ये 80 करोड़ हमेशा याद रखिएगा, 9 करोड़ 80 करोड़ 3.5 करोड़ अलग अलग योजनाओं की ये मैं संख्या बता रहा हूँ। 12 करोड़ किसान जो 2000 की किस्त पाते हैं साल में 3 बार, 3 करोड़ 1,000 विधवा पेंशन, केवल मात्र 1,000 रुपए। दिल्ली में कई बार मैंने देखा है, आजकल तो वो नोट बंद हो गया लाल वाला, वरना कार का दरवाजा खोलने पर या बंद करने पर वो लाल वाला रुपया दे दिया जाता था टिप के तौर पे। तो मात्र 1,000 विधवा विकलांग वृद्धावस्था पेंशन मिलती है और उसका महत्व है। एक बूढ़ी महिला ने मेरे से कहा मोदी जी को राम राम कहना, तो मैंने कहा क्या कर दिया उन्होंने आखिर? तो कहा मुझे जब 1,000 रुपए के विधवा पेंशन आने के 3 दिन पहले मेरी बहू मेरे पैर दबाने शुरू कर देती है। बड़ा महत्व है उस 1,000 का, ऐसी बात नहीं। कुएं पे नहाते हुए मैंने एक मोती संदल साबुन अपने गांव की एक गरीब महिला को दिया, तो साल भर तक उसने उसको इस्तेमाल किया। कह रही सूंघ लेती हूँ, समझ लगता है नहा लिया है, केवल मुंह पे लगाती हूँ। ये 80 करोड़ लोग हैं। तो यहाँ कुछ ना कुछ मंथन जरूर होना चाहिए, सस्ते इलाज के बारे में, सस्ती दवाओं के बारे में, जेनरिक दवाओं के बारे में, जन औषधि केंद्र के बारे में, अमृत फार्मेसी के मामले में जरूर चर्चा होनी चाहिए। क्योंकि पिछले 60-62 साल से भारत के लोग सरकार को चुनते थे और इंडिया के लोग सरकार को चलाते थे। पिछले 9 साल से भारत के लोग सरकार को चुन रहे हैं और भारत के लोग ही सरकार को चला रहे हैं। इसलिए ये लंबी गरीब कल्याणकारी योजनाएं हैं। मुंशी प्रेमचंद की एक पूछ की रात है। आज मैं बड़ा हृदय से बोल रहा हूं, मेरे को काफी कुछ लिख के दिया गया, तो मैं कोशिश कर रहा हूं कि वो आंकड़ेबाजी के जाल में मैं ना फंसूं। मुंशी प्रेमचंद की पूछ की रात एक कहानी है जिसको मैं अमीरों के खिलाफ नहीं हूं, लेकिन डल्लप पिलो पर सोने वाले, एसी में रहने वाले लोग उसको याद करके 90% नंबर ला सकते हैं, लेकिन उसके दर्द और मर्म को वही समझ सकता है जिसने पूछ की एक ठंडी रात एक चादर में काटी हो। नरेंद्र मोदी जी ऐसे ही परिवार से आते हैं। 10 बाई 15 के कमरे में 6-7 भाई बहन रहे। माँ ने दूसरे के घरों में चौका बर्तन किया, खुद ने चाय बेची। तो मैं तो हमेशा कहता हूं कि इस देश का प्रधानमंत्री कोई महागरीब आदमी बनना चाहिए, लेकिन लुटियन जोन में आकर के उसे गरीबी याद रहे तो बनना चाहिए, अगर भूल जाए तो नहीं बनना चाहिए। इसलिए लंबी फहरिस्त है, क्योंकि आज हम केवल हेल्थ केयर के बारे में यहाँ पर बैठे हैं, तो मैं बहुत लंबा भाषण हो जाएगा अगर सब योजनाओं के बारे में मैं बताना शुरू करूंगा। लेकिन आयुष्मान कार्ड, इसको मैं नंबर 1 पर दूंगा। आजकल मैं जब अपनी कॉन्स्टिट्यूंसी में राशन कार्ड बनवाता हूं तो लोग कहते हैं राशन कार्ड छोड़ो, आयुष्मान कार्ड बनवा दो। अब सबका नहीं बन सकता। इसमें केवल 4-5 चीजें हैं कि 2011 में एक शैक्षिक, सामाजिक और आर्थिक जनगणना हुई थी, क्योंकि आपके घर में मेड्स होंगी, ड्राइवर होंगे और काम करने वाले लोग होंगे, लेबर होगी। अभी लोग वंचित हैं जानकारी के अभाव में। 2011 की सेंसस दिखवा लीजिएगा, अगर उसमें उसका नाम है तो आयुष्मान कार्ड घर में ही आपके मोबाइल पे बन जाएगा, अथवा अंत्योदय कार्ड उनके पास है, अथवा उज्ज्वला। उसको ऐसे बोलिएगा, उज्ज्वला याद नहीं रहेगा कि क्या तुम्हारे घर में गैस का सिलेंडर आया है, अगर आया है तो आप आयुष्मान कार्ड के पात्र हैं। अथवा लेबर कार्ड, यूपी 7वां देश है। यूपी में अभी 15 दिन पहले हम लोगों ने नियम बनाया कि सामान्य राशन कार्ड में अगर 6 लोगों का नाम है तो उनका भी, और ये अब सेल्फ जनरेट है, मोबाइल पर स्मार्टफोन पे बन जाएगा। उसकी एक लिंक है, वो बता मेरे से पूछा जा सकता है। मैंने अपने गांव में खेत बेचकर इलाज करते हुए देखा है। मैंने अपने गांव में बीमार होने पर महिला के पास जेवर थे, पति बीमार हुआ पर धीरे धीरे एक एक जेवर कम होते हुए देखा है। 3 रुपए सैकड़े या 5 रुपए सैकड़े पर ब्याज से भी इलाज करते हुए देखा है। इसलिए मैं आयुष्मान कार्ड योजना को नंबर 1 पर देता हूं। कई बार बड़े अस्पतालों में बाप बीमार है, खुद ही बच्चे से कहता है कि मैं ठीक हूं या ना हूं, मुझे घर ले चल, क्योंकि जितने बार मरीज का नाम लिया जाता है उतने बार पैसा जमा कराने के लिए लिया जाता है। ये एक पहलू है, हालांकि सरकार के काम है, सरकार अपना कर ही रही है, बहुत अच्छा कर रही है। भावनाओं से देश नहीं चलेगा, देश बजट से चलेगा। एक छोटा सा आंकड़ा वैसे ही आपको बता दूं कि 2013-14 में 33,228 करोड़ का बजट था, और इस साल 88,956 करोड़ हेल्थ का बजट है, माने 2.5 गुना। क्या 13 से 23 आते हुए आबादी 2.5 गुनी हुई है? क्या आबादी 2.5 गुनी नहीं हुई है, लेकिन बजट हमारा 2.5 गुना हुआ। तो भावनाओं से नहीं काम होता है, सड़क भावना से नहीं बनती, उसके लिए गिट्टी मिट्टी सड़क सी की जरूरत होती है। ऐसे ही स्वास्थ्य भावनाओं से काम नहीं चलेगा, उसके लिए मेडिकल कॉलेज खोलने पड़ेंगे, पीजीआई खोलनी पड़ेगी। 7 एम्स विरासत में मिले थे, 22 हो गए। हर डिस्ट्रिक्ट में एक मेडिकल कॉलेज की परिकल्पना प्रधानमंत्री जी कर रहे हैं और हो रहा है। 1.5 लाख से ऊपर हमारे पास हेल्थ एंड वेलनेस सेंटर हैं। और आयुष्मान कार्ड कोई ऐसी नहीं है कि ये एक केवल आंकड़ा है। यहां आया हूं तब तक 70,000 करोड़ रुपए हम लोग रिलीज कर चुके हैं। 5.5 करोड़ लोग अस्पताल में भर्ती होकर के इलाज करा चुके हैं, और 27,000 के आसपास अस्पताल इनपैनल्ड है। तो जो आप देख लीजिएगा अपने घर में, जो मेड्स हैं, ड्राइवर्स हैं, अधीनस्थ हैं, लेबर है, काम करने वाले हैं, सफाई कर्मचारी हैं। दुख ये है कि 9 साल में 5 साल हुए हैं इसको। अगर वो पात्र हैं तो उनका बन जाना चाहिए, जो आप अपने मोबाइल से उसको बना सकते हैं। देख लीजिएगा जरा कि उसकी वेबसाइट क्या है। इसलिए ये राज्य का कर्तव्य था कि वो लोगों के स्वास्थ्य का ख्याल रखें। और फिर हम तो उस देश के लोग हैं कि सर्वे भवन्तु सुखना सर्वे रोग निरामया। पप्पू भवन्तु सुखना वाला देश नहीं है। पप्पी भवन्तु सुखना, परिवार भवन्तु सुखना, यूपी भवन्तु सुखना, भारत भवन्तु सुखना भी नहीं है। सर्वे भवन्तु सुखना वाला देश है। इसलिए हमें सबके इलाज की व्यवस्था हमें करनी चाहिए, और कर रहे हैं प्रधानमंत्री जी इस दिशा में अच्छा काम। एबीडीएम से भी लोगों को जोड़ने का प्रयास किया जाए, क्योंकि डिजिटल का ही जमाना है। कई बार ये लगा कि आभा से जुड़ने पर निजी अस्पतालों को लगा कि उनकी प्राइवेसी में हम लोग घुस रहे हैं। वो उसका प्राइवेसी से कोई संबंध नहीं है, और ना वो पब्लिक डोमेन में डाली जाएगी। लेकिन जो भी मरीज, तो मुझे खुशी है कि यहाँ विभिन्न अच्छे अस्पतालों के सीईओज, ओनर्स भी बैठे हुए हैं। तो आयुष्मान भारत हेल्थ अकाउंट से जुड़ेंगे तो थोड़ा काम आसान हो जाएगा, वो पर्चों का और भीड़ का, और वो थोड़ी बचेगी। रेशियो भी ठीक कर रहे हैं। 854 पर अब हमारे पास एक डॉक्टर है। WHO 1,000 के लिए कह रहा है, उसके नजदीक हम लोग पहुंच रहे हैं। आबादी बढ़ रही है तो चिकित्सकों की भी संख्या बढ़नी चाहिए। 387 मेडिकल कॉलेज थे, मुझे बताते हुए खुशी हो रही है, क्योंकि मैं अपने विभाग की बात जरूर करूंगा। 705 मेडिकल कॉलेज। ये 9 साल ऐसे ही नहीं हम लोग बेमिसाल कहते हैं। इसी प्रकार से 37,000 पीजी की सीट्स बढ़ाई हैं। 2014 में पीजी की 31,185 थी, जिन्हें अब 78,000 कर दी गई। मेडिकल टूरिज्म पर भी
थोड़ी चर्चा हो जाए, लेकिन एक बात कहना चाहूंगा कि CGHS कार्ड मेरे पास है। कई बार मैं दिल्ली नहीं आ पाता हूं तो दवा खरीदनी पड़ती है। एक दवाई मैंने 119 रुपए की मार्केट में ली और जन औषधि केंद्र पर वो 25 रुपए की थी। कोशिश करें कि हम थोड़ा जन औषधि केंद्र पर होने वाली जेनरिक दवाइयों पर अपने पर्चों पर अगर लिखा जाए तो ये काफी इन 80 करोड़ लोगों को सहूलियत होगी। 9,995 जन औषधि केंद्र खुले हैं, 705 करोड़ रुपए की बचत हुई है। किनकी बचत हुई है? जो गरीब लोग हैं। ऐसे तमाम योजनाओं की तमाम आंकड़ेबाजी है, लेकिन मेडिकल साइंस भी बड़ी गजब की है, बहुत लिमिटेड और बहुत ब्रॉड। जिम्मेदारी मेरी ही है ऐसे चिकित्सकों को समाप्त करने की, लेकिन मैं सरकार का एक अंग हूं। फेडरल सिस्टम्स की बहुत खूबियां हैं और बहुत कमियां भी हैं। हमारे गांव का एक हमारा ट्यूबवेल चलाता था, 8वीं फेल था वो लड़का। मैं नाम भी, हालांकि उसके पिताजी कहते हैं आप बहुत बदनामी करते हो भाषणों में। तो राम नारायण धीमर था। एक दिन मेरी जेब से 25 साल पहले 2,000 रुपए चुरा के चला गया। हमारे गांव से 30 किलोमीटर दूर एक छोटा सा कस्बा है, वहां पर किसी निजी चिकित्सक के यहाँ पुड़ियां बांधनी उसने शुरू की। ठीक 3 महीने बाद वो लौटा तो राम नारायण धीमर से डॉक्टर RN कश्यप हो गए। वो अंग्रेजी नाम होना बहुत जरूरी है डॉक्टर का। वो और कहीं प्रैक्टिस करता तो कोई बात नहीं थी, हमारे ही कस्बे में 3 किलोमीटर दूर वो प्रैक्टिस करने लगे। शायद कोई IMA के कार्यक्रम में रहा होगा, तो ये मैं हमेशा बोलता हूँ। तो मैं छुट्टी से आ रहा था तो उसके क्लिनिक पे रुक गया। क्लिनिक नाम पर एक कुर्सी, एक मेज, 10-12 बोतलें, तमाम सारी गंदगी, एक प्लास्टिक का कवर, एक कुर्सी, एक बेंच, एक स्टूल। तो मैंने कहा गांव के क्या हाल चाल है? तो एक मरीज स्टूल पे बैठा था। तो डॉक्टर साहब ने थोड़ा इशारा किया कि वो मरीज देख रहे हैं। तो उन्होंने उसके सिर पर स्टेथोस्कोप लगाया। मैं थोड़ा कंफ्यूज हुआ, विज्ञान का छात्र हूं इसके बाद भी। फिर पीठ पे देखा तो मैंने कहा चलो पीठ तो देखा जाता है। फिर घुटने देखे, फिर जीभ खुलवाई और जीभ पर रखा। जीभ हमारा भी डॉक्टर खुलवाता था, लेकिन उसने जीभ पर स्टेथोस्कोप रखा। फिर घुटने, फिर पैर। अब मुझे लग गया कि मैं अपनी जगह सही हूं, डॉक्टर गलत है। मरीज ने कहा कि डॉक्टर सुभाष त्रिपाठी MBBS थे, 50 रुपए लेते हैं, केवल सीना देखते हैं। इन्होंने 5 रुपए में पूरी बॉडी हमारी चेकअप कर ली। क्या ये भारत में नहीं होता है? अक्सर अखबारों में सुनने को मिलता है, तो कंपाउंडर ने डिलीवरी करा दी, बच्चे की डेथ हो गई। तो मैं हर प्रकार की सिफारिश करता हूं, लेकिन ये वाली सिफारिश मैंने कभी नहीं की इस विभाग में आने से पहले। एक तरफ बच्चे 15-16 घंटे पढ़ते हैं, तब नीट क्वालिफाई करते हैं, फिर पढ़ते हैं, तब UG करते हैं, फिर बहुत पढ़ते हैं, तब PG में होता है, फिर बहुत पढ़ते हैं, फिर पास आउट, फिर पता नहीं क्या SR-शिप, JR-शिप। मेरे भी बाई द वे मेरे बच्चे दोनों डॉक्टर हैं। तो मैं कहता हूं कि पढ़ते हुए शादी कर लो, वरना 35 साल में बाहर निकलोगे। तब जा करके फिर स्पेशलाइजेशन क्या क्या। एक तरफ ये चिकित्सक है हमारे पास, और एक तरफ जिसका मैंने वर्णन किया है। फिर वो हमारा हेडेक है कि उनको हम जेल भेजें, लेकिन विभिन्न सूबों में विभिन्न सरकारें हैं, दिल्ली से हम लोग कंट्रोल नहीं कर पा रहे हैं। लेकिन भारत विश्व गुरु था, नहीं है, बनेगा जरूर, और वो हम आप लोगों की दम पर कह रहे हैं। राइट ब्रदर्स ने हवाई जहाज 1900 कुछ में बनाया, हमारे पास त्रेता में था उस वक्त, हकीकत में था। भारद्वाज मुनि ने बनाया था, रावण हाईजैक करके ले गया था। जेल वेयर ने टेलीविजन भी 1900 कुछ में बनाया होगा,
लेकिन हमारे द्वापर में कुरुक्षेत्र के युद्ध को हस्तिनापुर में संजय टीवी पे देख के धृतराष्ट्र को सुना रहे थे। कितनी मजाक उड़ी होगी महाभारत की 17वीं शताब्दी और 18वीं शताब्दी में, कितनी मजाक उड़ाई होगी। इन घोरों ने खासतौर से मजाक उड़ाई होगी। अरे भाई, कुरुक्षेत्र में युद्ध हो रहा है, तुम्हारे गजब के लोग दूरदृष्टि हैं। वो दूरदृष्टि नहीं थी, वो दूरदर्शन था। और हस्तिनापुर में देख रहे हैं, आपके राम जी लंका से हवाई जहाज से आए थे, पुष्पक से। आपके पास बुलेट प्रूफ जैकेट हमारे पास थी, कर्ण के पास थी, और कवच अवच कुछ नहीं था सब। प्रहलाद की बुआ के पास फायर प्रूफ जैकेट थी, वो उसे ओढ़ के बैठ गई थी, सोचा प्रहलाद जल जाएगा। वो हवा आई, जैकेट प्रहलाद पे चली गई, बुआ मर गई, होलिका। ये सब उदाहरण बिल्कुल सही है। वायरलेस मार्कोनी ने बहुत बाद में बनाया है। मेरी ही लोकसभा से जब कंस अपनी प्यारी बहन को लेके जा रहा था, तो आगरा के पास आकाशवाणी हुई थी कि जिसको लेके जा रहा है उसका बेटा तुझे मारेगा। तो हमारे पास एफएम भी था। और गणेश जी आपके क्षेत्र का सर्वोत्तम उदाहरण है। इस पर ब्रेकिंग न्यूज बने तो बनती रहे, मैं तो अपनी बात कहता हूं। क्योंकि गणेश जी गुलशन नंदा, प्रेम वाजपेयी, रानू, इब्ने सफी बीए या जेम्स शेडली चेज या आर्थर कॉनन डाइल के पात्र नहीं है। वो थे, वो हैं, वो रहेंगे, प्रथम देवता हैं। ये सर्जरी का अनुपम उदाहरण है। हमें अभी वहां तक पहुंचना है, बाकी सब चीजों की नकल लोगों ने हमसे की। मैं इस अवसर पर एक बात कह के अपनी बात समाप्त कर रहा हूं। मैं जब मिनिस्टर बना तो एक दिन ऑर्गन डोनेशन डे था, तो मुझसे कहा गया आपको शपथ दिलानी है। मैंने कहा भाई, शपथ दिलाते रहते हैं हम लोग, चलते वलते तो है नहीं उस पर। कौन ऑर्गन डोनेट कर सकता है, किस उम्र के कर सकते हैं, क्या मेरे जैसा इस उम्र में कर सकता है या डायबिटिक आदमी कर सकता है? पहले बताओ, प्रोग्राम को रोको। अगर मैं स्वास्थ्य मंत्री नहीं बनता तो जिंदगी में मैं नोटो ही नहीं समझ पाता कि नेशनल ऑर्गन एंड टिश्यू ट्रांसप्लांट ऑर्गेनाइजेशन भी कोई संस्था काम कर रही है जिसके पास करोड़ों का बजट है। मैं लॉ में नहीं आता तो टैली ला नहीं समझ पाता, जबकि जमीनी आदमी हूं। अगर मैं नहीं नोटो समझ रहा हूं तो कोई भी नहीं समझ रहा है। पढ़ने लिखने का भी शौक है और बहुत जनता से जुड़ा हुआ हूं। मैं आत्म प्रशंसा के लिए सब भाषण क्यों हो रहा है, मैं 4 बार एमपी पहले रहा हूं। इस दिल्ली में 23 रात रुका हूं केवल, बाकी एमपी महीने में 23 दिन यहाँ रुकते हैं। मैं पूरी लाइफ में 23 रात दिल्ली में रुका हूं। अभी भी अपनी कॉन्स्टिट्यूंसी ही जा रहा हूं। 3 बजे के बाद दिल्ली में कुछ है नहीं। पार्लियामेंट चलते हुए, पार्लियामेंट नहीं चल रही है तो मंत्री नहीं थे हम, तो एमपी थे हम। आता ही नहीं था, आता था तो रोज वापस जाता था। तो रोज गांव में कोशिश करते हैं कि रोज जाएं, एवरी डे जाऊं। मैं जिस गांव में सबसे कम बार गया हूं उसमें 28 बार गया हूं। तो नोटो मुझे नहीं पता था, तो कहा गया कि नहीं आप ऑर्गन डोनेट कर सकते हैं। तो मैंने पहले अपना हार्ट, लिवर, किडनी, लंग्स, पेंक्रियाज, स्मॉल इंटेस्टाइन, बोन्स, कॉर्निया, टिश्यू देश को दे दिए हैं। इसके बाद आपसे बात कर रहा हूँ। फेसबुक पे डालने पर ये जो पीछे से ताली बजी है, ये थोड़ा सा नाम आपका भूलता हूँ, आपका नाम बड़ा टेढ़ा है। इन्होंने अभी तक 173 बार, हाँ 175 बार अपना ब्लड डोनेट किया है। खड़े हो जाइएगा जरा, एक बार नाम बता दीजिए, दोबारा कभी नहीं पूछूंगा, मुझे याद हो जाता है। हाँ तो नाम ही टेढ़ा है ना, वो हमारे जैसा दिनेश महेश सोलापुरकर, ठीक है। 175 बार इन्होंने ब्लड डोनेट किया है। ब्लड डोनेशन डे पर शायद आरएमएल में हम लोग मिले थे, आपसे परिचय कराया गया तो मैंने कहा कि मेरे ऑफिस आए आप, हम दोपहर का खाना साथ में खाएंगे और मैं अपने लेटर पैड पर आपको एक प्रशंसा पत्र लिखूंगा। वैसे तो हर बार आपको बुलाया जाता होगा, मेरा काम करने का तरीका दूसरा। 175 बार। रक्तदान के बारे में मैं ये कहना चाहूंगा कि उंगली जब कट जाती है, ये मेरे अपने गांव के अनुभव है, ये राहुल गांधी को थोड़े पता है। जब कभी गांव में किसी मजदूर की या किसी की या हम जैसे किसानों की उंगली कट जाती है और एक बूंद खून आता है,
उसको मुंह में डाल लेते हैं। शायद ऐसा आपने देखा होगा, नहीं तो सुना होगा, जबकि वो इन्फेक्शन करेगा। लोग सोचते हैं कि इतना महत्वपूर्ण खून, इसको बाहर नहीं बहाना है, दोबारा मुंह में डाल लेते हैं। जो लोग रक्त देने को तैयार नहीं है, उनसे मैंने किडनी, लिवर, फेफड़े, लंग्स, इंटेस्टाइन, हार्ट मांग रहा हूं। उस दिन मैंने फेसबुक पे डाला तो मेरे बेटे और बेटी ने अपने ऑर्गन डोनेट किए। कोई मुझे अचंभा ही नहीं हुआ, क्योंकि अगर कोई डॉक्टर अपने ऑर्गन डोनेट नहीं किया है या जीवन में कभी ब्लड डोनेशन नहीं किया है तो उसकी डिग्री पर मुझे शक होगा, क्योंकि उससे ज्यादा देहदान का महत्व, अंगदान का महत्व या रक्तदान का महत्व कौन जानता होगा। लेकिन सपोर्टर्स ने फोन किया, ये क्या है, हम भी करना चाहते हैं। तो मैंने फिर एक कैंप लगाया प्रधानमंत्री जी के जन्मदिन के एक दिन पहले। पार्टी का कोई झंडा नहीं लगाया, कोई ट्रैक्टर नहीं बुलाया। आप तो गए थे मौके पर, कोई मेटाडोर नहीं, कोई बस नहीं, कोई ट्रक नहीं, कोई भीड़ नहीं। 8,003 लोगों ने ऑर्गन डोनेट किए, एक ही आगरा में, एक ही छत के नीचे, एक व्यक्ति के बुलाने पर 8,003 लोग। मैं ऑर्गन मांग रहा था, 326 लोगों ने अपनी देह दान कर दी। 8 घंटे सर्वर फेल हो गया इनका, नोटो वालों का, क्योंकि इन्होंने जिंदगी में देखा ही नहीं था कभी कि 8,000 लोग आ जाएंगे तो अचानक क्या करेंगे ये लोग। और मैं पर्चे वो बनवाना भूल गया। मैंने इनसे एक बात कहा था बस, इसका जो ये वाला सिस्टम है कंप्यूटर वाला आप रखना, हमारे पास लोगों की कमी नहीं है। मुझे 200 लोगों ने कहा कुछ दिन खाना खा के आए या खाली पेट आए। ऐसे मेरे सपोर्टर, उनको ऐसा लग रहा था कि वहीं पे किडनी विडनी देनी होगी तो दे देंगे बघेल साहब के कहने से। जैसे आप लोग महाजन जी बुलाते होंगे ना, वो नहीं लाल वाले बुलाते होंगे, खाली पेट आना, लिपिड प्रोफाइल करना। वो 200 से ज्यादा लोगों ने फोन किए कि खाली पेट कैसे। मैंने नहीं, खा पी के आना, वो वहां कुछ नहीं लेना है, केवल प्लेस करनी है। उसको बढ़ाएं जरा, ये मैं आपसे अनुरोध करना चाहूंगा। जिस देश में 2.5 लाख लोग मर जाते हों एक्सीडेंट में, और दुख बात है, मुझे मेट्रो से दुख है, दिल्ली, मुंबई, कलकत्ता, मद्रास से, कि एक रूम में आदमी मर रहा होता है, एक में मरणासन होता है। अगर वो वहीं दे दें, क्योंकि डॉक्टर काउंसलिंग नहीं करते हैं। मैं अहमदाबाद का कौन सा कॉलेज है अस्पताल, सिविल हॉस्पिटल मेहता, सिविल यूएन में कोई है यहाँ पर? भाई मैं तो आपको यहाँ देखने गया था, प्रोटोकॉल ना होता तो आपके पैर छू लेता मैं। मन बहुत हो रहा था कि उस टीम के पैर छू लूं। 173 लोगों का आप लोग अंग ले चुके हैं, मृत लोगों से 173। आपने फोटो वहां पर लगाई है, गजब गजब। फिर मैं वहां से एक डॉक्टर साहब को बुलाया था, आगरा में उनका भाषण कराया था। तो मैं ऐसी भाषण नहीं देता हूँ, मुझे 40 मिनट एक्स्ट्रा मिले थे, तो मैं आपके कॉलेज में गया और देख के आया आखिर ये कौन लोग हैं, देने वाले कौन हैं और निकालने वाले कौन हैं और लगाने वाले कौन। मेरी एयरफोर्स से बात हुई है कि ये हेलीकॉप्टर जो फाइटर्स हैं ये केवल पाकिस्तान के लिए ही खड़े रखे हैं क्या? अगर नहीं हुआ 30-40 साल युद्ध तो उनका नहीं, हमारे स्तर का काम तो बताएं ना। अब बारात में फूल की वर्षा तो करेंगे नहीं। तो मैंने कहा अगर एसएन मेडिकल कॉलेज से हार्ट निकाल सकें, किडनी, लिवर, और हमें दिल्ली लाना हो, तो उन्होंने कहा साहब एयरफोर्स के लिए गौरव की बात होगी, हम 30 मिनट के अंदर एम्स के हेलीपैड पर हार्ट, लिवर, किडनी, पैंक्रियास जो भी है उसको पहुंचा देंगे। तो इस मामले में अब हमारे यहाँ 8,004, अगर किसी 50 साल के व्यक्ति ने आगरा में शपथ ली है, ईश्वर उसे लंबी उम्र दे, लेकिन अगर वो 70 साल में अगर मरा 20 साल बाद, तो मुझे लगता है कि हर मेडिकल कॉलेज में अंगों को निकालना और लगाना संभव हो जाएगा। क्या कभी हमने सोचा था कि कासगंज में मेडिकल कॉलेज वो बनेगा, एटा में मेडिकल कॉलेज बनेगा, मैनपुरी में मेडिकल कॉलेज बनेगा? कभी नहीं सोचा था हमने। फिरोजाबाद में मेडिकल कॉलेज, मैं अपने आसपास बता रहा हूँ, मैं 5 जिले का एमपी था, मेडिकल कॉलेज केवल एसएन था। आज मेरे हर जिले में मेडिकल कॉलेज है। तो आने वाले 20 साल में मुझे लगता है कि अंगों को निकालना और लगाना भी संभव हो जाएगा। माफ करना, मैंने कुछ ज्यादा बात कर ली, लेकिन एक बहुत महत्वपूर्ण संस्थाओं के लोग यहाँ पर बैठे हुए हैं। अक्सर आप देखते होंगे, अगर यशोदा अस्पताल में, हम गांव के लोगों की एक रिवाज है, बीमार को देखने हम ट्रैक्टर से जाते हैं पूरे 30-40 लोग। लेकिन जब आपको भीड़ कम करनी हो तो बाहर जाके कह देना कि 1 यूनिट ब्लड की जरूरत है, धीरे धीरे सब सरक जाएंगे। मैं अभी एक मरीज को, एक एक्सीडेंट सामने देखा तो मैं उसको उठाया, जाना था एक शादी में, मैंने उठाया और कहा माँ बाप भाई जो भी हो जल्दी से मेरी गाड़ी में बैठो, बच्चे की जान बचानी है। आगरा से 70 किलोमीटर दूर, अपने अनुभव बता रहा हूँ। उसने कहा कि जिस शादी में आए वो सामने आया, अरे शादी इतनी इंपॉर्टेंट थोड़े है ना, जान बचानी है। बहुत बुरी तरह क्रश हुआ था उसका पैर। तो मैं लेके आया, आगरा में फोन किया, भैया सब व्यवस्था करना। मैं तो जानता नहीं इसकी रेडियो टूटी है या अल्ना या एटलस या टिबिया फिबुला, ऐसी कोई हड्डियों को नाम कुछ याद आ गए मुझे, लेकिन बचाना है, जान बचानी है। मेरा पूरा कुर्ता, कपड़े ब्लड खून से बह गए हैं, लेकिन जान बचानी है, सब व्यवस्था रखना। जैसे ही पहुंचे तो उन्होंने कहा सब सब इंतजाम है, बस इसको ब्लड की जरूरत होगी। तो मैंने उसके फादर से कहा कि चले जाओ, एक समर्पण ब्लड बैंक है, आप अपना दे आओ, वहां से ले आओ। माँ है, पिता है और भाई है। पिता कह रहा है 3 साल पहले मुझे टाइफाइड हुआ था, मेरे तो खून ही नहीं है। माँ ने कहा कि मैं भी बहुत वायरल हुआ मुझे 2 महीने पहले। और भाई ने कहा मैं छत से गिर गया था, मेरा तो सारा खून बह गया। तो पहले तो मैंने कहा कि पहले तो एम्स से तुम्हारा आईसीएमआर को दिखाता हूँ कि सालों तुम बिना खून के जिंदा कैसे हो। अब सोचिएगा, ये हमारे सामने की बात है। मैंने कहा मैं पैसे का इंतजाम कर सकता हूँ, लेकिन नहीं, इतना अंधविश्वास है, खून आप ही दे के आओगे। मेरे पे वाई कैटेगरी है, तमाम पुलिस थी। मैंने कहा नहीं, तुम्हारा अंधविश्वास आज खत्म करना है। मैं कोई एचएम पर पॉलिटिक्स नहीं करता हूँ, लेकिन धर्म विशेष के लोगों को बहुत दिक्कत है। एक बकरा खाने पे एक बूंद बनती है, वो चली जाएगी, जबकि ये रोज बन। तो मैं ये कहता हूँ गिव मी अ फिश एंड आई ईट फॉर ए डे, टीच मी टू फिश एंड आई ईट फॉर ए लाइफ। आपसे अनुरोध है, आप हमें कुछ स्लाइड बना के दें, कुछ वीडियो फिल्म बना के दें। मैं रोज गाँव जाता हूँ, जाके दिखाऊंगा। जब महाजन वाले बोलेंगे, लाल वाले बोलेंगे, यशोदा वाले बोलेंगे, एम्स के डायरेक्टर बोलेंगे, मेदांता के तरहान बोलेंगे, आद्याती अपोलो वाले बोलेंगे, आपका नाम बहुत है, तो लोग आपकी बात मानेंगे। हमारी बात को पॉलिटिकल मानी जाती है, आपकी बात को विज्ञान पे आधारित मानी जाती है। तो लोग ये, वो है ना कि मछली दे देंगे तो एक दिन खा लेंगे, मछली मानना सिखाओ। तो हम रक्तदान से अंगदान पे आ गए हैं और देह दान पर आ गए हैं, ऐसी बात नहीं है। ये दधीच का देश है, ये राजा हरिश्चंद्र का देश है, ये कर्ण का देश है। तो थोड़ा सा ऐसे इसके प्रचार प्रसार के लिए, रक्तदान नुकसानदायक नहीं है, कैसे होता है, कितने लोगों की जान बचती है, तो ऐसी कुछ डॉक्यूमेंट्री आप बनाएं। तो मैं कोशिश करूंगा कि सिनेमा हॉल में उनको दिखाएं, और बड़ी बड़ी मीटिंगों में उनको दिखाएं। धर्म गुरुओं के बड़े बड़े सम्मेलन होते हैं, राधा स्वामी वगैरह के 5-5 लाख के होते हैं, निरंकारियों के। तो कुछ ऐसा मटेरियल हो, हालांकि ये हमारा ही काम है, हमारे विभाग का काम है, फिर भी मैं आपसे निवेदन करना चाहूंगा कि छोटी कुछ 1-2 मिनट की बना के ऐसे हम दें। तो मैं बाकी लोगों से निवेदन करना चाहूंगा कि सिनेमा हॉल में दिखाएं, या हम अपनी जनसभाओं में भाषणबाजी से पहले चीज को दिखाएं। बहुत खुशी हुई आपने मुझे बुलाया, बहुत लोगों के नाम बहुत सुने थे, दर्शन आज हुए। कई बार चिट्ठी उट्ठी लिखते हैं कि कुछ कंसेशन कर दें गरीबों को, लाल पैथोलॉजी पर हैं, अब तो कर दिया करेंगे ना। अच्छा, आप हम मेरा भी नहीं समझ सकते कि मैं ये क्या करने आया हूँ। मैं 8 बजे उठा, 9 बजे मैंने एक मंदिर के शिलान्यास, इसके बाद 10 बजे एक हलवाई की बड़े आउटलेट का उद्घाटन, फिरोजाबाद में कैंसर परमार्थ एक चैरिटेबल 10 करोड़ की तो एक मशीन आई है उनकी, उसका उद्घाटन, फिर एक आउटलेट का, फिर जलेसर में 3 लोगों की मौत, 2 स्कूलों में लैपटॉप, इसके बाद 5 रामलीलाएं, 6 देवी जागरण करते हुए मैं 3 बजे रात में आया। 5 बजे की ट्रेन पकड़ के दिल्ली, हैदराबाद गया, हैदराबाद से मल्लिकार्जुन, मल्लिकार्जुन से सुबह 1:45 आया, फ्लाइट पकड़ के सीधे आपके बीच में आया हूँ। अब ट्रेन पकड़ के सीधे आगरा जा रहा हूँ। तो हमने कुछ नहीं दिया, समय बहुत महत्वपूर्ण है। तो थोड़ा वो 80 करोड़ में से किसी को भेजूं, तो क्योंकि आयुष्मान में वो पैथोलॉजिकल टेस्ट वो है नहीं है शामिल, तो थोड़ी सी आप करते हैं, बहुत अच्छा करते हैं, सोशल रिस्पॉन्सिबिलिटी हम सब लोग करते हैं, लेकिन ये आंकड़े आपको नहीं पता रहे होंगे कि 80 करोड़ लोग, तो जितने में मैं एलबी का पर्स देख रहा हूँ, इतने में प्रधानमंत्री आवास बनता है, सच में। और 10वें 5वें दिन कोई ना कोई महिला मुझे गांव में रोकती है, रुको वो छपाए नहीं, वो भी महंगा वाला है मैडम जो आपने पीछे किया है। बहुत महंगा है वो, वरना वो राडो वाली घड़ी भी बहुत महंगी है। 2.5 लाख का मकान देते हैं, और उसकी खुशी बताऊं मैं,
अक्सर मुझे 10वें दिन कोई महिला मिल जाती है, क्योंकि महिला को मकान दे रहे हैं। भैया रुकना जरा, मेरे रिश्ते ऐसे ही हैं अपनी कॉन्स्टिट्यूंसी में। क्या हुआ? रुको रुको और सरसों के तेल की आरती, जबकि आरती यूपी में नहीं है। यहाँ वोट मिल जाए बहुत बड़ी बात है। यहाँ ना कोई श्रीफल देता है, ना सॉल पहनाता है, ना आरती। आरती क्या हुआ? और बतासे ठूस दिए मेरे मुंह में 2-3। क्या हुआ? मोदी जी ने मेरे को मकान दिया है। मैं बाहर छप्पर में सोती थी, कपड़े रात में ऊपर नीचे हो जाते हैं, हमेशा चिंता रहती थी। शराबी लोग निकलते हैं, डर रहता था। जिंदगी में कभी, उसने साउंड स्लीप तो नहीं कहा, उसने कहा कभी जिंदगी में घोर नींद नहीं आई। अब भले 2.5 लाख का है, कुंडी बंद करके सोती हूँ, और अब मुझे चिंता नहीं रहती, मुझे डर नहीं लगता है। नहीं तो आधी छप्पर में भैंस बनती है, आधे में चारपाई होती है। भैंस पेशाब करके पूंछ हिलाती है, हम सबके मुंह पे बहुत गिर रही है। लेकिन अब उनका अलग मकान है, आदमी का अलग मकान है, जानवरों का अलग मकान है। लेकिन अभी भी बहुत काम करने की आवश्यकता है। ये मैं थोड़ा अनुरोध करना चाहूंगा। ये मेरे निजी अनुभव हैं, वो पॉलिसी बनाने में बड़े काम आ सकते हैं। और आपका टेक्निकल, आपकी बातें हम लोगों के बहुत काम आ सकती है। तो जो भी डेमोक्रेसी, यही होना चाहिए, कोई प्रोटोकॉल नहीं होना चाहिए, खुल के बातें आपको करनी चाहिए। मैं अपना फोन डायरेक्ट उठाता हूँ, सीधे फोन करें, मेल करें, मिलने आए, सेशन के समय कभी भी आए, किसी भी प्रकार की कोई। दूसरा एक और कहना चाहूंगा कि आयुष्मान कार्ड के अलावा कई लोग हैं जो आयुष्मान कार्ड धारक नहीं है, लेकिन पैसे वाले नहीं है। जैसे 33% थर्ड वो होती है फेलियर, 33, तो 33 वाला कौन सा बहुत होशियार है? 32 9 पे फेल हो गया, माने आयुष्मान कार्ड। 33 आ गए तो वो बहुत होशियार थोड़े है। ऐसे ही आयुष्मान नहीं है लेकिन गरीब है। तो प्रधानमंत्री राष्ट्रीय राहत कोष से कोई भी एमपी चिट्ठी लिख दे, प्रधानमंत्री जी को चिट्ठी वो लिखे, प्रार्थी फलाना फलाना बीमार है, ये है, इस अस्पताल में इलाज चल रहा है, मैं पैसे नहीं दे सकता, कृपया ये शब्द आना चाहिए, प्रधानमंत्री राष्ट्रीय राहत कोष से आर्थिक सहायता देने का कष्ट करें। 2 फोटो, डॉक्टर का एस्टीमेट, आधार कार्ड और इनकम सर्टिफिकेट। और एक ये पता नहीं क्यों नियम बना रखा है, एक डिक्लेरेशन करना है कि मैं फलाने सन ऑफ सो एंड सो, रेजिडेंस ऑफ सो एंड सो, प्रमाणित करता हूं कि मुझे अभी तक कोई सरकारी सहायता प्राप्त नहीं हुई। तो ये मेरा इंडिया का रिकॉर्ड 26 साल से कोई नहीं तोड़ पा रहा है। तो ये मैं लिख के बताता हूँ, प्रधानमंत्री के नाम चिट्ठी, 2 फोटो, अपना आधार कार्ड, इनकम सर्टिफिकेट, डॉक्टर का एस्टीमेट, एमपी की चिट्ठी, और ये डिक्लेरेशन कि मुझे अभी तक कोई प्राप्त नहीं हुआ, भवदी एबीसीडी। तो मैंने भवदी एबीसीडी लिख दिया, तो उसने प्रधानमंत्री को भवदी एबीसीडी भेज दिया। मुझे प्रधानमंत्री जी के यहाँ से आया, बड़े अच्छे नाम रखते हैं आपकी कॉन्स्टिट्यूंसी में। तो अब ऐसे भी लोग हैं, उदाहरण के लिए मैंने एबीसीडी लिख दिया तो उसने एबीसीडी लिख के भेजा। ऐसा मैं सबको लिख के देता हूँ। तो मैं 26 साल से अपना रिकॉर्ड बना रहा हूँ। आपके यहाँ भी कोई ऐसा मरीज आए तो कृपया मेरे पास भेज दें, या लोकल एमपी के पास भेज दें। प्रधानमंत्री इंपैनल्ड हॉस्पिटल होना चाहिए। दूसरा, मुख्यमंत्री विवेकाधीन कोष, यूपी के सिलसिले में आपका हॉस्पिटल है विवेकाधीन कोष में, गाजियाबाद में, यशोदा। हाँ, तो उसमें प्रधानमंत्री 40% टोटल एस्टीमेट का अस्पताल को देंगे, और मुख्यमंत्री टोटल एस्टीमेट का 50%। ये जितने कागज बताए हैं ये सभी ओरिजिनल जाने चाहिए। श्री नरेंद्र मोदी, प्रधानमंत्री कार्यालय नई दिल्ली, योगी आदित्यनाथ, मुख्यमंत्री कार्यालय लखनऊ, किसी एक के पास भेज दीजिएगा। ये अस्पताल में हेड के पास पैसा पहुंच जाता है। ये आपको पता था तो ठीक है, और नहीं पता हो तो अपने लोकल सांसद, जब कोई देश में ना लिखे तो मैं लिखने को तैयार हूं। धन्यवाद।
हाँ जी। माननीय मंत्री जी, आपके प्रेरणादायक उद्बोधन, सचोट मार्गदर्शक एवं आपकी मानक उपस्थिति के लिए बहुत बहुत धन्यवाद। आपका शेड्यूल बहुत व्यस्त है और रहेगा भी, उसके बावजूद आप यहाँ पधारे, उसके लिए हम आपके आभारी हैं। And with this, we are at the end of the inaugural session, where I would like to invite Dr. Sanjeev Singh, Co-Chair, Ficci Health Services Committee, Medical Director, Amrita Institute, Faridabad, and Chief Medical Superintendent, Kochi, to give the vote of thanks.
A very good afternoon to all of you. आप माननीय मंत्री जी, आपका लेक्चर जो था वो इतना आप इतना दिल से बोल रहे थे कि उसको सुनने का और भी मन कर रहा था. But we would like to just offer a vote of thanks on the behalf of organizers and the entire Ficci team. We extend our heartfelt gratitude to our distinguished guest speakers and all the attendees at the 17th edition for Ficci Heal. I would like to express our heartfelt gratitude to our esteemed chief guest, Professor S.P. Singh Baghel. Sir hails from Agra, and he was mentioning that he comes from a modest hamlet of 34 houses, and he has 84 लाख योनियों के मंत्री हैं. वो एक क्लेम जो उनका था वो बहुत ही भारी क्लेम था. But he did mention about hygiene, sanitation, preventive and nutritional health. He did also, but he was a very clever and a brilliant minister, where we from the private side wanted to speak about Ayushman payments and CGHS payments on time. But he was clever to get his word across to Lal Path Labs and to Yashoda Hospital. And that is how a politician remains a good politician. But he is very passionate, very popular.
पार्लियामेंट सेशन में दिल्ली में एक मीटिंग रखेंगे जिसमें आयुष्मान इन पैनल्ड हॉस्पिटल के साथ बैठेंगे कि उनको क्या दिक्कत होती है पेमेंट को लेके, लेट पेमेंट को लेके, या जो भी है. उसमें सरकारी, गैर सरकारी, बड़े वाले 7 स्टार, 5 स्टार और छोटे वाले अस्पताल सभी. तो बहुत जल्दी सदन चलते, इसलिए कह रहा हूँ कि 4 राज्यों में चुनाव है, तो हम लोग बैठेंगे उस दिन आयुष्मान पर 2-3 घंटे में केवल आपकी बातें सुनूंगा कि कहाँ दिक्कत होती है, और अपनी पूरी टीम को लेके आऊंगा मौके पे, उसका समस्या का समाधान भी करेंगे, क्योंकि एक साइड बात नहीं होनी चाहिए. दिल्ली में रख लेंगे, बल्कि फिक्की को ही कह देंगे, आप ऑर्गेनाइज कर देना. इन पैनल्ड हॉस्पिटल जितने भी हैं दिल्ली एनसीआर में, उनको सबको बुला लें, हम अपनी पूरी टीम लेकर आएंगे. आपके सजेशन जो भी होंगे वो अगली बार में शामिल कर लेंगे.
थैंक यू सो मच.
पेमेंट और पैकेज, खासतौर से 2 ही बातें होती हैं, लेट पेमेंट और पैकेज.
Thank you so much for that. And it was so good to passionate politician highlighting 175 blood donation person and identifying him, and also for the civil society, 100 and civil hospital and 173 organ donation. So that was very, very good. Thank you so much for gracing the occasion, sir. I was speaking to Professor Ajay Singh, and I was asking him why Harvard is Harvard, and he said that 150 Nobel laureates had come out from that and 10 from the medical school. So thank you so much, Professor Ajay Singh, for your enriching talk and your mention about AI solution and scalability, and to eliminate repetitive tasks and improve efficiency. It's extremely important. So he was on his way to Hong Kong, and he agreed to sort of break his journey and be with us. There are 3 Bhishma Pitamas, young Bhishma Pitamas of Ficci, an ace cricket commentator, par excellence, ENT surgeon, and an insurmountable work which he has done in policy and advocacy, Dr. Narottam Puri. I thank you, sir, for being in this for the inaugural program. Brigadier Arvind Lal, Padam Shri, a very decorated defense personnel. He had taken a Swasth Bharat initiative and has done some fantastic work, and he's a very vocal and a supportive advisor to Ficci. Thank you so much for the inaugural program and attending it. And Dr. Harsh Mahadan, he has been our mentor. He chairs this program, the Ficci Healthcare Services. Plus, there are a lot of work which has happened for the last 1 year, roundtable meetings, roadmap to cancer, new age model and upskilling. And that's the credit goes to him. And my colleague, co-chair Mahesh Joshi, who heads the Apollo Healthcare and has done some fantastic work. I would also like to thank all the eminent speakers for their valuable insights and expertise and knowledge sharing. Organizing committee, Praveen ji, Shilpa ji, Sarita ji, Ishan, and the whole group, and all the sponsors and the media partners and all the attendees. In conclusion, once again, thank you everyone for making for being part of this important meeting. Your support and participation exceeded our expectations, and we are truly grateful. And thank you again, Professor S.P. Singh Baghel साहब, आपके दिल से जो आपने सारे anecdote share किए, वो बहुत important थे, and we are extremely grateful for gracing the occasion.
Thank you very much, sir, for your warm thank you note. And one more time, we give a big round of applause to Minister Sir for his presence and his words. Thank you so much, sir. जी सर, धन्यवाद, धन्यवाद. I must say he has a very sharp memory. Thank you, sir. I now request all the participants to kindly take up their seats, please, because we shall commence with the next session, which is on fostering resilient economics. A humble request to each one of you to kindly be seated. For this particular session, would like to welcome the convener, Dr. Sanjeev Singh, co-chair, Ficci Health Services Committee, Medical Director, Amrita Institute, Faridabad, and Chief Medical Superintendent, AIM SRC, Cochin. We will have with us Mr. Gautam Khanna, immediate past chair of Ficci Health Services Committee and CEO, PD Hinduja Hospital in MRC, Mumbai. Dr. Vishal Gandhi, founder and CEO of BioRx Venture Advisor. Dr. K. Madan Gopal, advisor, Public Health Administration, National Health Systems Resource Center, Government of India, Ministry of Health and Family Welfare. And we will be virtually joined by Dr. Carsten Angel, CEO, International Society of Quality in Healthcare. I request the esteemed dignitaries to kindly step on the dais. We welcome on stage Dr. Sanjeev Singh, Dr. Gautam Khanna, Dr. Vishal Gandhi, Dr. K. Madan Gopal. And virtually we will have with us Dr. Carsten Angel. Please, sir. Thank you. everyone will turn up in a while.
Yeah.
Those who are standing in the hall, I request you to kindly take up your seats, please. Dr. Carson Angel, CEO, International Society for Quality in Healthcare. We welcome you, sir. Can you hear us, sir?
Yes, I hear you well. Thank you.
Most welcome, sir. Our pleasure.
So we'll get started. This is session 3 for looking at economics and international health and healthcare benchmarking. We had named this particular session as resilient economics, and we know that in healthcare, the ability to withstand and adapt to an economic challenge in delivering efficient and effective healthcare is becoming very, very difficult. So it would involve lots of strategies, lots of operational plan, lots of redefining of business model to be able to sustain and also adapt to the fluctuations in the market. There are a lot of diversification in the revenue stream which happens to mitigate financial risk. There are lots of cost control and efficiency analysis, which is again very important and a critical factor to for any healthcare organizations to bring in financial resilience. There are huge collaborations and integrations which has to happen across industry. So those who are running hospitals with medtech and pharmaceutical companies and lots of, like we heard today, from the government and non-government organizations. There are lots of innovative payment plan, and we have been meeting very young, dynamic engineers and financial analysts who are working in healthcare, and they bring in some fantastic models who are able to take that risk, also to innovate, accelerate, and improve efficiencies within the healthcare organizations. And definitely, technology and digital health is making a sea change in the way we deliver healthcare, and also bringing in cost effectiveness and benefit to us. So I will get started with Dr. Carlston Angel. He has been our mentor. He is a CEO of International Society for Healthcare and Quality. All accreditation body across the world reports to ISQA, and they need to be member, both from the standards point of view and an organization point of view. And he is at Lisbon, and fortunately, he agreed to speak to us. So, Carlston, is that okay? We can get started with you?
Yes.
Yeah,
Thank you so much.
Dr. Carlston will be speaking on learning healthcare system as an international benchmark and best practices. So over to you.
Thank you, and thank you for the opportunity to speak to you today. And I bring to you greetings from the entire worldwide ISQA community. We share your vision of providing accessible, affordable, high-quality healthcare for all, and we congratulate Ficci on having arranged this 17th annual healthcare conference. May it be successful and inspire all of you in your daily endeavors to realize the noble mission you're in charge of. I will perhaps not speak so much about financial sustainability, but that's not our not our line of action. But I'll talk about something that's closely related, because you can't talk of sustainability without looking at both financial and quality sustainability. Next slide, please. As you all know, there are many challenges for healthcare systems today, but there are also many opportunities. One of the ways in which you can prepare and support your system to meet the challenges and leverage the opportunities is to nurture it to become a learning health system. And indeed, being a learning health system is an international benchmark and an international recognized best practice today. I'll give you some reasons for that. One is the obvious, that the amount of knowledge in the healthcare field is growing exponentially. The healthcare you deliver must always reflect the current state of knowledge. Thus, the system cannot be static, but must change. It must change the care it delivers in accordance with the changing knowledge. Another is that a learning health system is not just a system that allows or even expects or demands the individual healthcare professionals working within the system to learn continuously. The healthcare system is a highly complex system. It must adapt the way in which it works as a system, not only to changes in our understanding of diagnosis and treatment of disease or promotion of health, but also to the changing conditions, including as well short-term variations from day to day or even hour to hour as long-term trends. And it must be able to adapt to changing expectations, such as patients expecting to be met in a more person-centered manner. A complex system will adapt spontaneously. You can't, as a leader, force your will upon it, but you can nudge and influence the way in which it adapts. This is an essential part of your mission as a leader. Next slide, please. I talked to you about the need to accommodate an exponentially growing amount of knowledge. Surely a challenge. The bad news is that we are not even on top of today's knowledge. Various studies show that something like 60% of care is delivered within guidelines based on evidence or expert consensus. Much of it, by the way, on consensus rather than solid evidence. 30% is low value or wasteful, and 10% results in direct harm to patients. Imagine that 40% of what we are doing does not provide much value to patients. It even generates harm that must be taken care of. Imagine that we could mobilize perhaps 50% of the resources we spend to create real value. This will need to change. As we know, any system is perfectly designed to perform in the way it does. So we must change the system. And it's not just done by adding to the knowledge of the individual actors within the system. We must create a learning health system. Next slide, please. A learning health system can be defined as a system where science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the care process. Patients and families active participants in all elements, and new knowledge captured as an integral byproduct of the care experience. Next slide, please. Healthcare is a highly complex system, possibly the most complex system ever created by humans. Next. The reason for complexity to emerge is that relations between causes and effects are not linear, but include positive and negative feedback loops and crosslinks between different processes. This means that the effect of a given action can't always be predicted precisely, and an action at one place may have unforeseen consequences at another place. Embedded in the system are a lot of processes that are simpler, sometimes even linear and easy to understand, but the result of combining a large number of interconnected processes is the emergence of a complex system. Next slide, please. As a response to this unpredictability, it is not always efficient or even possible to work as per the rules in a manual. There may even arise situations where two applicable rules prescribe actions that are conflicting. Therefore, people in the system will react by adapting their actions to the actual situation. They will do so based on the knowledge of how the system works locally where they are. They can't have an overview of the entire system. They may not necessarily be able to take the more distant effects of the actions into account, which may lead to the need for new adaptations elsewhere in the system. Some of the adaptations may lead to changes in the written or unwritten rules on how to act. In other words, the system develops and learns. This may lead to an improved system, but can sometimes also lead to a drift into failure. A complex system adapts itself. Doesn't this mean that it is inherently learning? Well, it does in some sense, but we can't be sure that it changes in the direction we want it to. To be true, the performance of healthcare systems does improve over time. We see a secular trend for improvement that, by the way, can confound some scientific studies, before-after studies, or time series studies if you don't take the appropriate methodological precautions, but the change is too slow. Some people have found that it takes an average of 17 years for only 14% of new discoveries to enter practice. Consider the rate with which knowledge is growing. Even if we do improve, the target full use of all present relevant knowledge is moving and moving fast, and we need to speed up the learning. As I mentioned, there's always the risk of drifting into failure. Staffordshire was a complex system that adapted and changed itself. No one deliberately wanted it to change into the failed system it became, but nevertheless, that was what happened. Reasons for this drift into failure would include conflicting goals and messages, reluctance to listen to staff and patients, a comfort-seeking as opposed to a problem-sensing approach to data, and a blame culture. But laissez-faire, hoping that things will take care of themselves, is not an option. And now we're on this slide. But the opposite of laissez-faire is also not an option. Rules and procedures can reduce complexity and are well used for this purpose, but they can't eliminate it. A complex system can't be managed by a master manual. Next, please. So what you can do and what you should do as leader is, in a sense, to ride the wave. You should leverage implementation science. There is a difference between understanding what we want to change and understanding how we can make that happen. In a complex system, what a healthcare professional leader brings to the table is not so much knowledge about the thing, but an insight in how the system works that can help him or her to understand, take the system's perspective, ask the right questions. Next slide. The learning health system framework can be defined as you see here. It consists of 4 dimensions: science and informatics, patient-clinician partnerships, incentives, and a continuous learning culture. One thing to notice is that nurturing a learning health system is not about doing a lot of things you haven't dreamt of doing until now. On the contrary, digital transformation, engaging patients in a patient-centered approach to care, focusing on value rather than volume, and being mindful of waste are things you're dealing with already. So it's more a question of being aware of using them in synergy and with the creation of a learning health system in mind. One thing to note is, however, that for your staff, learning is not just about honing traditional professional skills. It is also about system thinking and understanding complexity. Next, please. The learning health system is aligned with the quintuple aim. That is one way of summarizing on a very high level what a health system should aim for. Patients should experience good care as viewed from the perspective of the patient. Did this help me solve the problems I came with? It should result in better outcomes for the population as a whole at a sustainable cost. We have come to realize that clinician well-being is essential if good quality is to be delivered, and also that good quality includes equity, good health for all. And mind you, that to achieve equity, we must improve the whole system, not just a single hospital. The quality of a health system is measured by how it treats the most vulnerable, not by its peak performance. Next. And this is to finally repeat my core message to you today. Leadership is about nurturing a learning health system. Thank you for your attention.
Thank you so much, Katstran. And I think you brought in so many valid points about the learning health systems, and science, informatics, incentives, and cultures needs to be aligned. And those are fantastic programs, triple aim, quadruple, and quintuple in 2021, which got released, and a lot of institutions have adopted it and they have benefited. So thank you so much. And if you guys could stay with us, we will finish a few of the sessions and come back for a question and answer session. Is that okay, Carsten?
I can stay for a while, but unfortunately I have to leave for another session shortly.
No problem. No problem. Thank you so much for your very insightful talk. And we will move on to Dr. Vishal Gandhi. Dr. Vishal Gandhi is a founder and CEO of Biorex Venture Advisor. And he would be sharing his thoughts on nuances of smart hospital, basically covering financing and viability in private healthcare. Over to you, Dr. Vishal.
Thank you, Ficci and Dr. Sanjeev, for having me here. So I'm going to share my humble experience working with the healthcare ecosystem. So I started my career with the Dabur Research Foundation, where I was responsible for floating a company called OnQuest along with my key founders. And I see Dr. Ravi here, who actually managed the company and scaled that faster. And then, of course, with the Ranbaxy, worked on genomics platform. So sort of biotech and pharma experience. And I was extremely fortunate to actually be a part of Dr. Trehan's, project that was first financing of a most complex, project, which is 1,500 bed in a single location, was a history to me. And I was actually part of Yes Bank at that time, and we had kind of given 250 CR line. And because we gave that, and I think that really gave us a lot of insights as to how to fund private hospitals. And that's where we saw a lot of corporatization of hospital happening between 2005 to 2012. And my experience, what I'm going to share with you is more practical. And so since, we have seen that the efficiency of a private hospital just cannot come the way it is done today, right? We got to reimagine the way healthcare is delivered. And healthcare to me is not about only hospital. It's about, medical device. It's about medical consumables. It's about, pharmaceutical, and then hospitals, So I think most of the time we only think about hospital is the only way to bring efficiency. But I think we got to have a healthcare continuum. And what is going to allow us to do is to digital health. And I think the concept of smart healthcare and digital health goes hand in hand. So we have seen that digital health as a sector has certainly grown, and which means that it is not an option anymore. It is actually compulsory that we adopt digital health in every aspect of the way we manage, drug discovery to the patient, right? From the bedside, from a bench to bedside. And so what I like to do is to share with you some of the experiences that we have had. We're working with startups. Can I have my slides, please? Yeah. How do I get to the next slide? Okay. So I'm sure all of you are aware about smart hospital, right? When we talk about smart healthcare, the hospital is integral part of that. So I'm not going to talk about that, but I think this is one way to actually make the project viable. And we have seen most of the time, the hospital projects, like I would have seen the balance sheet of at least 150 hospitals in last 150, at least last 15 years. And it is very unfortunate. Most of us do not know this, but it's unfortunate that some of these single specialty hospital or a multi-specialty hospital at even good locations, they turned NPA. And the credit rating, I am not sure how many of you are aware, but the way bankers look at any project, they look at the credit rating. And most of the hospitals which came in between 2005 to 2015, the credit rating of those hospitals was not something called investable grade, right? It was actually in the range of, triple B, which is called just investable grade. Now, Can we continue to deliver healthcare the way actually it's been delivered? No. And as I said, that the healthcare, the solution is digital health. And within digital health, I think the way we need to look at that, what are the challenges the current hospital setting is needs to prepare, which they have not really prepared. And these are some of my cursory thoughts I'm sharing with you. One is that we have no idea about the health impact of the climate change that we're going to witness, right? So I think hospitals are not really prepared towards that. Second is that a lot of diseases still we do not have the solution to, right? And one of the things that I can talk about from my own experience of working as a cancer specialist, cancer scientist, that 20 years back also when we were looking at molecular biology of a cancer, I think today also, even if genomics, proteomics, metabolomics, we still do not have the right answer to diagnose the cancer and thereby decide the precision oncology. I think still we are, a long way to go to actually be able to create a precision medicine for oncology. Coming to the next potential challenge, which I'm sure all of you are aware, is AMR. I think this is going to be the one big disruption that needs to be there, and we need to solve this. And I think hospitals will have a big role to play here. Then coming to the shortage of healthcare workers, I think we definitely are going to look at how to solve this problem by way of digital health, by way of simulation, by way of various other techniques which have not been adopted so far. But we are going to at least foresee this, as in like shortage of healthcare workers. And this needs to be solved. Otherwise, making buildings and those buildings will become unsustainable. So then, of course, we all know that today the healthcare is so accessible only to people who are living in tier 1, tier 2. But whereas tier 3, tier 4, where 80% of the people live, they do not have access to the healthcare. And that is 20% of the healthcare is belonging to only 80% people who live there. So I think there's huge inequality. Telemedicine, there are digital healthcare interventions which are trying to solve this problem, but I think we're still a long way to solve this problem for the rural healthcare, which is tier 3, tier 4. Now, let's look at, why some projects turn NPA. I don't know how many of you know that, some of these projects actually, which got kicked in between 2007 to 2015, a lot of these hospitals turned NPA and then went and settled as an OTS, one-time settlement, which do not come onto the, I would say public platform, but that is the reality. Because if you look at debt to equity ratio for all the existing hospitals today, it is not one-on-one, it is highly leveraged. It is actually 3 to 1, which means 3 times more debt than actually what they can absorb. So that is making the hospital unviable. Now, what can we do to make this kind of efficiency? I think digital health again has to play an important role. How do we continue to manage the patient, and how do we continue to provide that continuum of care? Whether in the hospital or outside hospital. I think there is some learning from e-commerce model. They call it lifetime value. In the same way, we need to also think about patient lifetime value. How do we manage the relationship of patient so that there is a good patient value? I think there are no models in healthcare yet, but I think one has to think, and that will really increase the efficiency of a hospital, thereby returns on hospital. So I did a small analysis yesterday that what is the level of profitability, EBITDA, PAT, the profitability of any good hospital which has been there in the system for long is not more than 20 to 25% as an EBITDA. The PAT is not more than 10%. And yet people are saying that, doctors are doing this kind of practices or hospitals are fleecing money, so I think there is again sort of a deficiency of trust between a doctor and the hospital providers and the patients, so even if they are not making money, and still, how do we solve this problem? Again, I'll say digital healthcare probably will bring transparency, which is very, very crucial. And so coming to, I think Ayushman Bharat is a great scheme to me. I think what we witnessed in fintech as an opportunity, like Paytms of the world, did not exist 10, 20 years back. But today we do see that the intervention of, National Digital Health Mission, possibly the next decade belongs to health tech. But again, not many health tech players have been able to scale the way they should have. And we have seen even companies which are into digital health, their scalability affordability factor is very much impacted because I think somewhere the adoption is very low. Now, what do we do to make adoption higher? I think those incentives which are given by the ABDM are not enough to entice the adoption. And I think unless and until we don't adopt the digital health in a very truly comprehensive manner in a private healthcare and of course public healthcare, I do not really want to comment on public healthcare because I don't understand that space well. But looking at the balance sheet balance sheet of most of the hospitals, I think they're highly leveraged. Now, how do we ensure that the returns are also there? How do we ensure the quality of care is also there? So I think we need to reimagine, right? And reimagining of healthcare is very, very important. And as I said, that digital health is the solution. And I can keep talking about it for next 20 minutes. And, but only thing is that maybe, I would like to put pause here, and I have a flight to catch to Lucknow. And I would like Sanjeev ji, if there's any question from anybody, I can entertain right now. Otherwise, I'm available offline, online on LinkedIn, and please feel free to reach to me. Thank you very much for the opportunity. I've prepared a lot of slides, but I don't think I will be able to really share a lot because time is limited. I have to pause now. Thank you, Sanjeev ji, for the opportunity.
Thank you so much, Dr. Vishal. There are many, many, many questions for what you said. Healthcare is not investable. 3:1 debt equity ratio, so many one-time settlements. So there are many, many questions. So, but I'll ask if the audience if they have anything to ask Dr. Vishal before he leave to catch up his flight.
I just have a comment for you, Vishal.
Sure.
I think the balance sheets where you saw the 20-25% EBITDA they don't exist anymore. I think those are, they are not in this universe. I can tell you that.
Sure. Absolutely. So I think this is a number that I can tell you from the listed companies that we did some research yesterday only. And this is what we saw, and maybe PAT is even less than 10%, right? So how do you kind of create a sustainable financing for a hospital which can continue to scale and provide that quality of care? I think there is a lot of rejigging required, Yeah.
So a quick question, why would still people invest in healthcare?
Okay, so I think to me, people who want to invest in healthcare, they first think about social. And social aspect is a very, very important aspect to start with. So you see a lot of philanthropic foundations. Initially, whether it's a trust or a philanthropic foundations, they actually give funding. But then, after that, you see that commercial capital comes, and the commercial capital drives efficiency, and that drives the scale. And then that's how people start. So you don't see many VCs per se who had funded only single specialty or perhaps, a single location hospital. I think they would look at funding only organizations which are scaling high, and they will come at a right time when the organization at least has 2-3 good setups. All of them have turned EBITDA positive. Now it's about scale up capital. So there's hardly venture capital available for growth in hospitals, whereas there is a private equity, which is available, definitely, because private equity is more of a growth capital and not many risks are involved in that.
Perfect. Thank you so much. And that was extremely valuable and very insightful. And you can leave whenever the time permits. We'll get to Mr. Gautam Khanna. Gautam Khanna is the CEO of PD Hinduja Hospital. And understanding balance sheet is one of the most difficult aspect. But he's going to demystify balance sheet with all of us. And how do we balance the balance sheet in a corporate hospital? So over to you, Mr. Gautam.
Thank you. So after hearing Vishal, so I couldn't stop myself. So people who are hospital owners and CEOs, they know 25% is a dream, I'm telling you. 20%. So I'm going to take a few minutes so mine is not a very serious presentation with facts and all that. I'd just like to explain so it's like you can consider it as finance 101 for people. Some of you are very experienced, you understand that. But I just want to tell you, when we talk about a strong balance sheet, how does a strong balance sheet happen? So let me start with this. What is this? This is what we do every day, right? We do exercise, what we eat, and this shows our health, right? This is what it is. This is what is life. What we do every day and what we eat determines our health. So what this means, where do I point it? Clear करना? Oops. So somewhere I'm pointing and it's changing, it's fine. So essentially, this is the difference between a P&L and a balance sheet. So what you do on a daily basis is your P&L. And what effect of that is your balance sheet. So if you want a strong balance sheet, understanding balance sheet, forget the balance sheet. Focus on the P&L. Focus on your day-to-day activities in your organization, in your hospital, and see the way you will do exercise and eat properly and maintain your health, what you would do to maintain a good balance sheet, a good financial health. Okay. So, there is a almost 2/3 of the CEOs have concern about financial health of the hospitals. And as you can see, the costs are growing. Human capital more than 50%, plus and minus 5-10%, including doctors, staff, so on. Costs are increasing. And we heard about, the minister said about 80 crore people have no access or limited access to healthcare. But if you want a certain level of quality, then you have to import medical devices. 80% are imported, 70% are imported. So it's very expensive. So these are things you have to figure out that the cost is increasing. And our friend just went from here talking about digital, but digital is also going to cost money. Infrastructure, everything is going to cost money. So this is what you have to be careful about. And on the other hand, what else is happening? Revenues are reducing because why? Of course, competition. And we had a session of new age models, Lalit. So what it is doing is healthcare system is doing very well, but the hospital, if it doesn't have those new age models, is going to lose revenue to home care companies, etc., etc. So there is impact on revenue. Then, of course, if you are for some reason you don't have good occupancy. So this is an example. So this I'm going to take a minute. So if you see previous year, so this is just comparison of 1 year versus the second year. So in the bottom, in the left, extreme left is previous year profits. So with the budget projection of next year's growth, you will get additional profits of the big blue bar. Okay. Then you start putting your expenses which you are budgeting, which will be, increase in costs of people, increase in infrastructure costs, increase in digital cost. You will have to spend more on medical supplies, etc., etc. And you keep reducing, and then you come to the bottom right blue. That's the profit. Okay. Now, what it means, this is the only slide which you need to know. Understanding the balance sheet is you control the orange bars. You control the orange bars, increase the blue. You are home. Okay. So it is up to you which orange bar you want to reduce, which orange bar you want to increase. Okay. And there is an impact on the right, top right, is occupancy with the revenue. So if you want to get more revenue, focus on the occupancy, you will get it. Okay. And some other things. So if you just take a minute to absorb this and understand this is what it is on your day-to-day basis, even if you are not in the hospital in a position where you are influencing these decisions, but at least you are able to understand why the profitability of the hospital is getting affected. Okay. And so now we come to fixing it. Okay. So this is how it is done, fixing the revenues. We heard about new age models, digital models, resolving your efficiencies and so on. So that will help you get your revenues back. And what about the cost elements? Cost elements. So firstly, you need to budget. Budget means fix what will be the orange element, what will be the blue element. You plan for that. Okay. And then you monitor. And then, of course, you need the efficiency. We talked about the efficiency. So the more efficient you are, the better you have a turnaround of your beds and hospital resources, etc. And the thing which I think Dr. Carlson, I think if he's still there, in one of the slides, he mentioned about the behavior you will get for quality. He mentioned the more you look at it and monitor is what behavior you will get. It's like what you will observe is what you will get. So if you want to manage it, please look at it. Very simple. It's looking very simple. And, we keep hearing, and Dr. Puri is not here. He has a joke about EBITDA. So we keep hearing about EBITDA. Don't worry. EBITDA is what you earn. That's all. Vishal also said EBITDA. EBITDA is your earnings before all the deductions. Okay. So how to get that? The trick is efficiency and patient care. If you get better patient care, you'll get better patient scores. You'll get patients to come back to you. You will have higher revenues. Think about that. And the other thing, and he mentioned about investments. The problem is, why did the hospitals go NPA? And he's talking about most of the hospitals having NPA. NPA, for people who didn't understand, is sick hospitals who are not making money. Is because when you are investing more than what you are capable of handling, then it is a problem. And so you have to decide whether you have to spend on capital item, revenue item, what is more important for you from your organization. And if there are some strategic initiatives which you want to do and you are ready to take the risk for investing your capital, or you want to do it as part of your OPEX. So that is your decision to do. And then, of course, you do all your analysis of payback, IRR, etc. So this is all there is. So if somebody thinks that your CEO is sitting in the office and doing something, he's not doing anything. He's just doing these 2-3 slides. But there is a lot more work to be done. And the trick is in controlling each and every element of the metric which drives these boxes, the orange or the blue. Okay. So with that, let me just try and sum up for you. If you have a healthy heart and if you monitor it regularly, you will have a good health and you will have a good P&L. If you monitor, have a healthy P&L, you will have a healthy balance sheet. So that's all. I hope I've made it very simple. Thank you so much.
Fantastic, Mr. Gautam. He is an IIT and IIM graduate running a very, very precious and very sustainable healthcare in one of the most difficult towns. And he rightly said that CEO is not doing anything, but it doesn't look like you have done so fantastic work. Just one quick question. Are there any industry averages or are there any trigger in balance sheet which other than ALOS and EBITDA, is there anything which a non-finance person or a finance person should be looking at?
The trick in any balance sheet is to look at the growth of what your assets are, what you call as current assets. So whether, don't go into the terms. All you do is how much money, how easy or how fast are you getting your receivables? How much time are you taking to pay? So when is your money coming in and when is your money going out? So that is your working capital, and your current assets. If you can control that, but for some reason, for example, you have an excellent customer and you get revenues of, let's say, 100 crores a year, but they are going to pay you after 1 year. So you have to look whether you can manage the 100 crores of loan, because then you will need to take a loan of 100 crores. And that 100 crores loan will come at a cost of 10, 12, 14, 8, whatever is the percentage. So if it is 10%, that is 10 crores a year. So that's almost 80 lakhs a month is your cost of that 100 crore revenue business which you have got. So you have to think about those. So that is one. And suppose for some reason your suppliers, means your vendors, they have started asking you advance because of I mean, it's in a market, they can ask that. And if you are paying 50% or 80% of your people as advance, so you think about it that you are paying advance, you are getting it money late. It's a question of time that you will not have money to run your day-to-day operations. Day-to-day operations means you'll have to pay salaries of people, you'll have to pay the electricity bill, you'll have to pay all kinds of things and taxes and so on and on. So you have to look at your receivables, and that is one. And then inventory. How much money are you blocking in your inventory? Inventory means stores, your pharmacy. And so are you buying for 1 month stock, 2 month stock, 6 month stock, because somebody who is your friend in another pharma company or device company and said that, we have a great deal going, please buy for 6 months. I'll give you 10% discount. And you buy it, you've blocked your money for 6 months. So, these are the things you have to look at. And then, of course, you look at your fixed assets. How many are you increasing? So if you are increasing your assets, and Vishal mentioned about ROI, that what is the ROI on the money capital which you are deploying? You are investing some money to make a building, and then how much revenue are you going to earn out of it? If you are conscious about it, that you're not going to earn any money, no problem. But if you think that you're going to earn a lot of money and then you don't, you will have a problem. So the trick, Sanjeev, short answer to this is, all you have to do is be very observant and take whatever decisions you have with information and knowledge. There is no decision which is right or wrong. Whatever you do is right for you. But what it impacts your organization or your hospital is your choice. You want to take higher loans, your choice. You want to make more money, do something, your choice. So that's where I feel.
Very good. Thank you so much. You mentioned about a very healthy heart, and I was missing a beat every time whatever you were saying. But with that, we'll shift gears, and
Can we ask a question, please? So can we ask a question?
Yeah,
Excuse me.
Sure.
Yeah, I was just thinking, Vishal, Gautamji, when you were mentioning that, you have to cut down on the reds and look at what is going to be in blues, right? See, for us to have an idea of what exactly, as, it was asked before, how exactly do we have some standards? Like I know HR cost is maybe between 40 and 50%. So it is going to be different for tier 1 cities, tier 2, tier 3 places where we operate hospitals, right? So do we have those standards along which we could compare and maybe think of improving or whatever can be done from our end? Thank you.
I mean, you're saying benchmarks. Standard means benchmarks.
Yes, benchmarks for different parameters, not just the HR, maybe overhead benchmark, everywhere, like relatively where we could make a comparison and see where we could improve on.
I don't know whether there's a benchmark, but see what I'm going to stick to 25% what Vishal said. Nobody makes it, but suppose we say he wants to make 25%. That means 100 is your revenue. Let's say 25% is cost of your material, devices, etc., etc. So 75 left. Out of that, you will have at least 10% of your other expenses for non-people expenses, at least 10% of that, or maybe if you're very efficient, maybe 7%. So let's say 10 for argument's sake. You are left with how much it is? 75 minus 50, 25 minus 10. So you're left with 15. It didn't reach 25. So then now you start juggling. If you want that to be 25, you have to either reduce the 50 to 40, 10 to 7, and increase the 100 to 125. So that is the jugglery you have to do. So there are no fixed benchmarks. It's all as per what you want to do. Some people will be happy with 15, with 10, with 20, whatever. So,
yeah, EBITDAs of 25%, I'm sure is not very easy, especially when you operate in tier 2, 3.
Yeah, not easy at all.
Yeah, exactly. Thank you.
All right. Thank you for that question. We'll shift gears, and we'll have Dr. K. Madan Gopal. Sir is an advisor, Public Health Administration, National Health System Resource Center at Ministry of Health and Family Welfare, and he'll be speaking on financing and viability in public health. Over to you, sir.
Okay, thank you, Sanjeevji and Ficci for inviting me and sharing my thoughts. We have heard the private sector, the EBITDA, balance sheets, profit and loss, return on investments. But in public sector, our return of investment is usually we have a return of investments in the form of economic evaluation. What is the cost benefit? What is the cost effectiveness? What is the utility? What has been the budget impact? That kind of analysis we do, and we call it as economic evaluation. And we usually do that thing. Can I have my slides, please? So the government has been spending. We all talk about that the per capita talk about GDP expenditure on health, and the government has been spending in the range of, if you include the social determinants also, in the range of 1.25 lakhs to 1.5 lakhs crores. Every year we are spending it. But after spending so much money, because as has been pointed out by the private hospitals as well as the other speakers as well, that the revenue is one of the constraints, one of the important factors, which is limiting to our activities. Be it return of investment, be it in a government sector, you have to see that whatever revenue, whatever budget is being allocated, you have to see how we prioritize the resources and how we utilize the resources so that it becomes effective for the general mass in general masses. We are dealing with 1.4 billion population. We are dealing with triple burden of disease, that is RCH, non-communicable, communicable disease. And now if you add to the other aspects, now we have to deal with the emergencies as well. So how to prioritize all this thing? For that, all the programs, we are having many national programs. You name a particular communicable disease, you are having a program for that. Now we are having a national non-communicable disease program. We have agreed for, we have traveled a long journey from disease to health, from health to wellness, wellness to well-being, with a strategy of primary healthcare approach, which has now been upgraded as a comprehensive primary healthcare approach, so that we can meet the commitments of SDG and the universal health coverage. So every year we are budgeting it, and we are trying to see that how we use that thing. I would be just quickly going. It's not a yes. At least it has moved. So what we are doing, why we want to do it, how we can understand whether our programs are working or not. So we have to do an economic evaluation, and every year we have been doing it. Before the budget, you have the economic survey report. Apart from that, we do have an institutionalized mechanism of carrying out program evaluation. So WHO has estimated that around $237 billion annually we are losing because of health inefficiencies. The system, private or government, as somebody from the audience, they have asked about do we have a benchmark? So that kind of thing, because of inefficiencies, and Gautamji has rightly pointed out, okay, how much margins you want. Because when I was working in my previous organization, where we were trying to focus on mobilizing investment into tier 2 and tier 3 cities, we were surprised that the foreign investors, they were working on a margin of 2 to 5%, but our here investors, they usually want to have a margin of 20 to 25%. That's a different kind of thing. I'm not a financial expert, but when I was working in that field, that this type of thing came to us. Then why we do it? Because we want to improve the health outcomes. We are having a limited resource. With this limited resource, we have to see that 1.4 billion population, how we can make them healthy. And we are having an approach which has been agreed is a primary healthcare approach. And the vehicles for implementing this primary healthcare approach is the National Health Mission and the 4 pillars of the Ayushman Bharat. Then what we are doing, so we do have monitoring thing. The CAG report points out that 38% of the government program, they don't have an effective monitoring and evaluation function. So what we are doing, we are collecting, we do have a mechanism for regular collection of data, analysis, we are using technology. Any program, they are having a digital dashboard, that kind of information is coming. We are engaging with the different donors and other persons. That kind of mechanisms are there, but still the CAG reports points out that the points about the inefficiencies in the system. So we are in the process of strengthening we have a HMI system. We carry out evaluation surveys, which I would be dwelling in the subsequent slide. But we are more or less seeing that how better utilize the resources and the budget which has been allocated so that a proper outcome is measured in the term of improved health outcomes. These are these are many types of the economic evaluation we are doing, because we can only measure the impact on the people, that is cost effective analysis. So if a particular regime, because you see previously when the TB regime started, you see how lot of interventions have happened and we have devised a cost effective method, that how a domiciliary treatment can be better than a institutional treatment. Then we are able to manage the things properly. The COVID times also, we have seen that how the use of technology has resulted in the avoidance of the catastrophe due to the telemedicine, the command center, and the management of the patients at the home. That kind of evaluation do happen. We do have a cost to utility analysis. How many, if you are having a mobile medical unit, if how much this particular unit has been able to cater to the services. Cost effective analysis, cost benefit analysis also we try to do it, and we have to try to see the budget impact analysis also we do it, because if you are using a e-Sanjeevani or a e-health program, whether it is able to impact on the public health delivery services or not, that kind of analysis we do. And apart from that, there are many programs which have shown that how this finance and the economic evaluation has impacted this program. You have seen the success of the National AIDS Control Program, the immunization program, and the National Rural Health Mission. These are the glaring examples of how this economic evaluation has resulted in the yield which we were thinking in terms of health outcomes. Now, we do have a system in place. The system has evolved from previously the Ministry of Finance, they were having the Program Evaluation Office, then the Independent Evaluation Office were there before 2015. In 2015, all these two units, the Program Evaluation Office and the Independent Evaluation Office, they were merged, and the DEMIO office, which is it is an attached office to Niti Aayog, that was formed. This Department of Monitoring Evaluation Office, Development Monitoring Evaluation Office, is a organization responsible for doing all the evaluations of all the central sector schemes evaluation, centrally sponsored schemes evaluation. They do the evaluation part. And in consultation with the Department of Expenditure, they usually feed in. The Department of Expenditure is responsible for managing the expenditure, how the expenditure happens in the different public health programs. So these are the central evaluation bodies. As I mentioned, the DEMIO office at Niti Aayog, then the Department of Expenditure, they usually have a say in how the expenditure and other things will happen. All the bodies are vital. Apart from that, Economic Advisory Council is there. They give inputs from time to time, and the economic surveys which you see before the budget, that's all part of the things, the economic evaluation which have been carried out for influencing the programs and the allocation of funds and budgets. Besides this, we do have at the ministry level, we do have a combined review mission in which all the stakeholders and the partners, they usually go visit and see the effect of the program, whether the program is giving us the desired health outcomes or not. Then we do have a National Health and Family Welfare Survey. Everybody quotes about the NFHS surveys. 5th round is complete, 6th round is underway. And that gives that key where the program funds are put in and which are the areas which need fix and which are the activities which needs to be prioritized so that the impact is more. Then we are having implementation research also. And you see the example, because the NHM is a vehicle for making a health sector reform and change. In this, project implementation plans are there. And the states have been mentioned about the resource envelope. In this resource envelope, they have to prioritize their activities and see that key with a small tweaking into the nature of the activities, whether they can have a desired health outcome or not. That kind of exercise is there, mechanism is there. These are all institutional mechanisms which are available. Then these are case studies which I mentioned. The immunization program, that's only one case study. Immunization program, you see that it's a cost-effective investment into the children's health. One of the largest public health programs in the world provide free vaccine to the children, and economic evaluation found to be highly cost effective with a cost benefit ratio of 16:1. And it has prevented millions of deaths and illness and saved billions of dollars in health. Another example is the this emergency medical response initiative 108 ambulances which you have seen. You see the response time. Response time is also there. The more at many of the places the response time is between 15 to 20 minutes, and that has saved millions of lives since its inception. You see that what kind of benefit it is having every year. That has become around an institutional activity, and the government is supporting such kind of activities. The other is the challenge and opportunities. The challenge lies in the data collection. So one of the thing is how to collect data, because sharing of the data, it has to be an institutional process, because most of the evaluations, what happens, it is focused on program performance rather than generating evidence so that policy can be influenced. So we are only bothered about whether my program is successful or not. So we are moving. But what has happened recently is the DEMIO office, they have started with the output outcome monitoring framework. They have made the outcome monitoring framework for 67 ministries, and they are monitoring it, whether the budget which has been earmarked for a particular area, whether it is yielding the desired outcome as per the given inputs and activities. Then these are the challenges. The one is data collection, other is standardization. We have to still focus on standards. One standards may not be fit for one program. We have to see that all the programs are there. We only talk about the numbers, as Honorable Minister Sir was also mentioning about numbers. We should not be bogged down with numbers. We have to talk about the objective of the program. The PMJ objective is reduction in out-of-pocket expenses. You see the wider interest on resulting in the objectives. The objective is very genuine, very commendable. We see that how we work towards achieving that objective. And evaluation should focus on not the achievement, but whether we have been able to reach to that objective. At the start, when the 13-14, when that National Health Accounts has pointed out the out-of-pocket expenses was around 73%. With the efforts, it has come down to 48%, and the threshold is less than 25%. We are working towards that. I think the next National Health Accounts will further result in saying that. That means all the programs which are being aimed at reducing all this out-of-pocket expenses, they are yielding results. The economic evaluation usually brings out this picture and say that in this direction we are moving. So we are having opportunities in the form of technologies and other things, but we have to see that how these economic evaluations are conducted rigorously so that an informed decision can be made. Then these are the future direction. We see that how we embrace the newer technologies, AI tools. For that, if we are able to standardize and have a good data collection mechanism, then only we can use this kind of tool. We have to see that how the government, the academia, and the private sector, they collaborate each other. We say that 70% of the expenses happen in the private sector, but that is all the data collected during the compilation of the national health accounts. Do we have a regular mechanism? Instead of calling estimates, do we have a dynamic mechanism so that we can know it on a dynamic basis? Right now, we are having a lag of 2 years, 3 years for getting this health accounts data. But can we reduce this lag with the participation of all these people? We have to see that how the best practices knowledges and the best practices can be shared, and so that we can improve the quality and effectiveness of this economic event. This is all from my side. Thank you once again for this opportunity.
Thank you so much, Dr. Madan. I think you mentioned about all the important initiatives which have been taken. 237 billion people, there's a loss, but then you did mention that there are monitoring mechanisms which are available and which is figured out in the NFS survey. And you quoted 2 good examples, which is National Immunization Program and ambulances, where the cost-benefit ratio is extremely high. One very quick question: when most of the, since it's a federal in nature, most of the program implementation plan which gets built, and many of the states still don't use that kind of a budget. So is there any evaluation which happens, because you mentioned the objective is very clear? So is that also figured out with various states?
Yes, if you talk about because if you talk about the central sector support scheme, that means 100% central grant is there. The sponsored scheme is there, is a partnership between the state and the center. In the 60-40 and 90-10 for the union territories and the northeastern states. If that kind of mechanism is there, if a partnership is there, that means 40% the state has to put their money. And we both agree that we would be doing this kind of activities. And you have seen that for the last many years, we have been collectively with the cooperation, collaboration of the state governments, the things are moving. And it's not that they don't do it, things are moving. But there are many checks and balances in the government expenditure and other things. Sometimes what happens because of some laxity, so they are not able to utilize the budget. But we are trying to see that how this kind of lacuna or the capacities for expenditure, that is also built, or round of trainings and other things do happen so that we build the capacities. Side by side, what happens on a monthly basis or a quarterly basis, review meetings happen. We usually say that your spending is less, you have to take the second tranche, third tranche. That kind of mechanism is there. So that the spending and the expenditure which is envisaged for a particular activity so that the outcome can happen, that happens.
Is there any question for Dr. Gopal?
Yeah, good evening, audience, and thank you, Dr. Sanjeev, for the opportunity. My question to Dr. Madan is that you said about the unutilization of the allocated budgets. So is there any mechanism actually, because all of these grants are made based on budgetary demands by the concerned departments, or at the end of the period, if it is lying unutilized, and most of the time it is happening, and we see that there are those programs which feel deficit of budgets, and there are others who don't use it at all. So is there a mechanism to evaluate and maybe take a corrective action? Thank you.
Mechanism do exist, because if we talk about right now, we are in the planning for 2024 to 26. That means we are planning 6 months ahead of the requirements for the financial year, which would be starting from 24 and 26. For 2 years, that budget planning happens. Apart from that, for all the activities, budgeted activities, there are key performance indicators, which both the states and the central union, they agree for this key performance indicator. There's a review mechanism. PFMS software is there. That means it tracks the delivery of the funds right up to the beneficiary level. So we can track it unless and until that thing is noted in the PFMS software. The funds and other balance sheets are not reflected. You can't that key. If you say that I spent 100, but if it is not reflected in that portal, then that is not agreed. That's one thing. Based on the PFMS software, we encourage the states to monitor the performance of this. And on a regular basis, meetings do happen with the state secretaries and the mission directors there. And they have been pushed for this. The utilization of the central funds have been always more than 60%. In some of the states, they ask more than 90%. It goes up to that. But it's based on the utilization. I give you money. If you are not able to utilize that money and provide utilization certificate, then how I can give you the next installment? As if I can't be blocking the money there, as mentioned by Gautamji. That means if somebody is giving me discount for 6 months, I would be buying and blocking my money for 6 months. So that is not going to happen. If the state spends more money, they can ask more money. And that's the only allocation. That this is the thing which has been allocated. And the budget allocations are usually more than 100%. That means if you are proposed for 100, if you are having an envelope of 100 rupees, we will give you an envelope of 114 or 120 rupees. So that in case you want to reappropriate or you want to use the budget in other heads, you can always do that. That kind of flexibility is always given to the states.
Right. Thank you so much, sir. I will quickly go to my topic, which was cost of poor quality. Can I have the slides? So generally, we keep mentioning that there are lives saved and there are length of days saved, and or else we present most of our presentation in dollar terms. We would like to use some of the tools so that we can speak in an Indian term. And health technology assessment is a good tool where evidence is assessed, cost benefit effective, and utility analysis is assessed, and ethics and the legality is assessed. So Joseph Juran, who is one of is a pioneer in health technology, health quality, he did mention that if we need to convert this, whatever we do as an operational efficiency in rupee terms, it makes a lot of sense, and that's how senior managers should be doing. And once you convert that in rupee term and mention that, it makes huge sense. So there was an article in Annals of Medicine which was published, and they did talk about high value, cost conscious care, and that is a fantastic model which got adopted, where they also classified value into as quality divided by cost, and it both are measurable. So what we generally don't do is measure what is not to be, what we generally don't have either the data to measure or we don't have an appetite to measure. So I'll quickly take few case studies. One is application of technology. Now, I've been saying this, that in healthcare, there is a hierarchy which exists. There are cardiovascular thoracic surgeons, there are neurosurgeons, then there is God, and then there are physicians, and then there are surgeons. So there are this group of people who play decibel-based management technique, and they shout that they need technology. Oncologist falls in that category, and there is a term called precision, and they want everything under the sun, every toy. So earlier there was cobalt, then moved into linear accelerator, and then there is a cyber knife. And when it is robotic in nature, you always feel it's a new technology, and it makes huge sense. And there is a systematic review which has been done, meta-analysis which also has been done, both for linear accelerator, which has IMRT, IGRT, SRS, and SPRT, versus cyber knife. Very interestingly, cyber knife, which has a robotic technology which moves with your respiration, and when it hits the tumor, the normal tissue damage is less. But if you do a systematic review, and if you look at just the word, I'm making it extremely simple since we don't have time. The local control is 70%, and the dose which you give is 36,700 rupees. When you look at linear accelerator, which looks old, but it's a workhorse, the local control is 90% and the dose is 11,000. But we still go ahead and choose newer technology, assuming that it would be because it's robotic in nature, new in nature, and then it will be extremely helpful. And we keep doing that. And I buy the point which Gautam was making, that we make those wrong choices. Some work in healthcare, we know hand hygiene is very important. We did that work, and we looked at, we are not talking about in dollar terms. So one surgical site infection or one ventilator associated pneumonia in my hospital is close to 61,000 rupees. It is because of my inappropriate, unwarranted care or lack of hand hygiene, where most of the faculty hand hygiene, doctors' hand hygiene is close to 34%, and we've become the contributor. The patient pays 61,000, that's bare minimum with a very average revenue per operating bed. So if you need to look at those economic terms and do an estimation before and after intervention on just hand hygiene, not looking at very high-end technology, silver impregnated catheters, just basic hand hygiene, reducing of surgical site infection is close to 21 lakhs. And that's the benefit you pass on. One, you bring in quality and you pass on to the patient, because it's most of it is out of pocket payment. Next slide. So you're definitely bringing down cost, but you're also bringing down healthcare associated infection. So $1 of investment, which is close just in training of hand hygiene, my return of investment is close to $236. And so going back to basics is extremely important. And when I communicated this in my organization close to 12 years back, I had only one infection control nurse. when you reach out and communicate this in a dollar or a rupee term, I have now 8 infection control nurses working, and it makes huge sense to save money and have a positive outcome. And there is also a cost of badwill and litigation with each, because when the patient's attendant, they stay in the waiting area, they talk about this infections being spread, and then there is a cost to that. Ultrasound guided in line insertion, systematic reviews, grade 1 analysis. This, my wife, professor in anesthesia, had a septic shock, got admitted in one of the local hospitals here in Delhi NCR when we shifted close to 3.5 years back. She was posted for a particular procedure, and another professor of anesthesia who said that he has done millions of blind subclavian insertion did that, and she landed into cardiac tamponade because he perforated a pulmonary artery. So ultrasound guided line insertion is a standard of care. We don't do it. The sonography machine is kept next to that professor of anesthesia, but he doesn't use it because he's so confident about his procedure. And it would be, and the total bill, the stay is 2 weeks, total bill is 6.8 lakhs. The sonography machine which you have, which you would use, which is standard of care, is equivalent to that amount for one particular patient. And that's the damage which we keep doing day in and day out. DVT prophylaxis, everybody knows, needs to be there. My mother, I was doing my post-graduation in Jaipur and brought my mother to the most prestigious hospital in Delhi for a CA stage 1 cancer surgery. And that was done 10 days after she was about to get discharged, where she immediately succumbed and we lost her. That was basically pulmonary embolism. And if you cost just a good standard of care, a good low molecular weight heparin, if it would have been given to her almost 2 decades back, which would have costed 1,114 rupees, I would have not lost her. And that is what we don't do on our practice, assuming that whatever we do is the care and is the best of the care. So my QALY saved is close to 3.84, which is very, very high. And that is the standard of care which we need to provide. So my low molecular weight heparin, enoxaparin or heparin cost would be 1914. And what we are saving for the patient is close to 50 to 44,000 of rupees. Similarly, we don't appoint people because we say that it's a cost to us. Medication management, if you just cost a medication error, which we do, and we say that, yes, people don't report adverse drug reactions, pharmacovigilance is extremely poor. In the research committee in NABH, we were collecting data of almost 600 hospitals. The medication error rate is close to 0.0001. Just because we don't know the definition and we don't collect. These are all 9 types of medication errors which we need to report. It's other than adverse drug reaction. And when you do it, one error is close to 22,000 rupees. You employ a clinical pharmacist who is so fantastically trained, who's a PharmD, 6 years of good clinical training, 40,000-50,000 rupees. She avoids 2 medication errors and you pay her the bill. So we need to cost. We need to understand there is a cost for poor quality. There is a standard of care which we don't understand, and we keep assuming that what we do is the right call. Similarly, antibiotic stewardship, we have Vishal did speak. AMR is going to be the next big pandemic. And if you just follow a good antibiotic stewardship mechanism, which putting a Donabedian's model of a structure, process, and an outcome, all what we do is in blue, all processes in green, and keep monitoring our outcome, which is on a regular basis, which is in red. And look at, we don't also do a good loading dose, which a nurse could be empowered. We still give 3 million unit colistin because we think colistin is a detergent and is going to kill the kidney. And we don't load appropriately with 9 million. And we do lots and lots of such mistakes. Dosings are improper, those which are time dependent, dose dependent. Many of the aminoglycosides are given as TDS, which needs to be given in OD. So we do lots of mistakes. Still, we give a lot of meropenem and metrogyl. Meropenem itself has an anaerobic coverage, but we want to give a metrogyl prasad to the patient because we have not revised, and we do that mistake. So if you do a good antibiotic stewardship, you save on mortality. which is very, very good, and it improves. You save on morbidity, the length of stays improve. This is an all-cause morbidity and mortality. And if your revenue per operating bed is close to 34 to 49,000 rupees, that's the huge earning on a good practice. And then there is there is definitely a good appropriateness of the care, which is important. So we did that for a particular unit, and our saving was close to 2 crore and 36,000 rupees. And this benefit, part of it would come to the hospital, but majority 90% goes to the patient. And it is important to cost all quality initiatives which we need to do, both direct and indirect, because it has an impact. Similarly, there was this is my last slide. I had a cardiovascular thoracic surgeon who always used to say that he always operates on a VIP patient, and he always deals with the high risk cases with an ejection fraction of 25 to 30% of cases. And he used to give, for a prophylaxis, meropenem, amikacin, linezolid, because he had this idea that he has to save all these patients by giving or pumping many antibiotics. We got another cardiovascular thoracic surgeon who wanted to just follow good practice. And he used to give only cefuroxime as a prophylaxis, not as a treatment. And his surgical site infections were always lower. And the saving is close to $4 lakh in just an year. And that's the damage which we create because we feel that we are doing justice in the care delivery on a road. So there are many examples. I'll leave this because we have to take few questions. Similarly for robot. So my point is that there are lots of quality initiatives. All quality initiative needs to be costed because there is a cost to poor quality. Unfortunately, patient pays. We also don't know the standard of care. The renewal of the exams for the faculty doesn't happen. Recently, I was doing a utilization review in my hospital, which is very recent, not for profit. I was reviewing a chart. A 2-day-old fever patient and an additional professor in medicine had advised CBC, ESR, KFT, LFT, dengue, lepto, malaria, blood culture, and urine routine. And when I asked him, he says that is how he has been doing. So why are we asking these questions? And he treated that as PO. And so the definition of PO is not known. And then the patient unfortunately pays for it. And that is where I think we need to create a movement and put a cost to what it is. And I firmly believe once there is a cost to poor quality, and there is where the buy-in also starts. Just saying that you save life or you save patient days doesn't have an impact because we don't see that. Thank you so much. So are there any other questions before we go into a fireside chat?
Sir, Yatish here. I think basically we all know actually what is the reality wise per bed day cost. But at the same time, we are not vocal about what they are paying in the government schemes are not able to. Basically, mainly wherever they cut corners, the cost of quality is not been quantified and projected to the world that how they are also equally contributing in delivering healthcare. I thought since this topic of cost of quality has come in, and both on one side an EBITDA, other side economic reforms are happening. Thing is, the cost of poor quality is much higher than what we are talking here, sir. Thank you.
I would really want Dr. Nandakumar Jairam, who had been the chairman for NABH and has been driving quality for so long, to comment.
I think you're spot on, Sanjeev. It has been a absolutely important aspect that has been neglected by the entire medical fraternity, if I may say so. Let's accept it. There has been very little control, for example, use of antibiotics. I can tell you that there are misconceptions and they continue to remain amongst physicians who practice, amongst administrators, even amongst the quality personnel. Poor understanding and poor recognition, poor control. This is what we suffer from. And the quicker we correct it, the better it is. Not only for the medical fraternity, but for the patient. And ultimately, that's what we work for. So I would completely endorse what you said.
Thank you so much, sir. Yes.
Good evening. Very well moderated and no surprise to see such a presentation from Dr. Sanjeev. It's very heartening to see that there is a price to quality. And we had been talking about having a repository of, all events so that we can have some data in our country to refer to. Because whenever I train people, I don't get any data from India to talk about what is our hospital acquired infection rate. So there is definitely a huge cost that we are paying unless we balance the outcomes, the clinical outcomes, and the money that we are spending in. More and more people need to be aware of quantifying the poor quality, just the way that you have been speaking about. So very well moderated, great learning in this session. Thanks to Dr. Gautam and Dr. Vishal and Dr. Sanjeev, very well moderated. And I really hope that such presentations can be shared more and more across the country. And whoever can initiate a repository of collecting this data for our country will do good. Otherwise, we will be having a losing battle when it comes to antibiotics. So I always tell them, imagine a day when there are no antibiotics available. What will we do then? Thank you.
True. We'll take a last.
You see, I want to stress one thing. We've been organizing multiple symposiums for God knows how many years. The most important symposium that we have to organize is for the medical professional on the use of antibiotics, you see. Many patients are being killed because of the overuse of antibiotic, resistance to antibiotic. And you can break your head with the consultant, they just won't listen to you. They just won't listen to you. So it is high time that we sensitize our medical professional to the antibiotic misuse and antibiotic unnecessary use of antibiotics. Like you talked about the surgeon, he gives 4 or 5 or 6. To give you an example, my own brother he died lately on 26th of September, UTI. And he was being loaded with antibiotics right, left, and center, knowing very well that he had a pseudomonas which he was resistant to. 5 months he was loaded with antibiotic. Counts kept on going up, cultures were positive. And then I said, enough is enough, as I took him home. Without any treatment, without any antibiotic, just supportive care and all that. The counts started coming down automatically. I don't know how, that was a magic or what it was. The culture was still positive. The pseudomonas was still there. But his quality of life started improving without antibiotic. So I think it is high time that we kind of start focusing on sensitizing our medical professionals about the use of antibiotic. And a nationwide, you see, symposium has to be organized on that.
Right. Thank you so much for those valuable comments. So we'll end this session. I would like to really thank Mr. Gautam and Dr. Madan Gopal for agreeing to be part of this session 3 of Resilient Economics. And if there are no more questions, we'll adjourn for this particular meeting.
Sad. सुनते नहीं है, फिर मैंने ना भगा के फिर ले नहीं दूंगी. Then his quality of life started improving, coming back home. 84. Investment file.
So we'll quickly go on to the last session. This was an experiment which we wanted to do this time, to have a fireside chat. And we definitely see lots of private equity investment in healthcare, and that has been steadily increasing in the recent years. The significant growth potential and increasing demand for quality and healthcare have also attracted some domestic and international PEs to invest in the country. And we have seen that recently, that many mergers and acquisitions have taken place. There is an increasing healthcare expenditure. There is increasing awareness of the present financial burden, but the resilience. There is tremendous growth in the private healthcare, an expectation from the patients with quality. And we thought that it would be appropriate to have a fireside chat where we bring in both the points. And we are very afraid of Dr. Rajiv Singhal, because if I any hospital and he is my closest neighbor, he is going to take it. So he's already taken 8. So we would like to invite Dr. Rajiv Singhal for this particular chat, and Dr. Nandu Kumar Jairam. Sir has been our mentor and chairman of NABH, and has been a very strong supporter and an advisor at Ficci. So with that, I would like to hand it over to Dr. Nandakumar Jairam to get started. We wanted a clinical point of view because that's extremely important. We wanted a P point of view that is extremely important because that is what is happening. And let's see who wins.
From the size, the age, and the way between Rajiv and myself, you know who will win.
You will.
But friends, it's a pleasure to be here. Let me start off by trying to place my side of the story first, and then hand it over to Rajiv to speak. And then we'll go at each other hammer and tongs, and finally decide who's the winner. Let me ask one basic question. What is the purpose of healthcare delivery? The purpose of healthcare delivery, as we've heard in the past sessions, is ultimately to create well-being, to ensure that appropriate care is given at all levels. Today, let's compare that with what makes a hospital healthy. Any general manager that I worked for, or worked for me rather, would say, sir, I made an EBITDA of 26%. That is what he looks at, full stop. There is a disparity and a complete diversion between these two statements. One of them is inconsistent. Because if you're looking only at the finances of a healthcare institution, you're not doing justice to the purpose for which you started. And that is my first and impactful statement that I stand by. Having said that, we all understand that without investment, there cannot be private healthcare. And private healthcare is certainly important. Therefore, the submission is that not only should you look at the bottom line of the balance sheet, but you should do a hardcore analysis of the quality of healthcare delivery, the clinical outcomes, the accountability, and as Sanjeev very appropriately said in the last session, the cost of quality. And these parameters has to be a part and parcel of your due diligence if you have to decide whether a hospital is appropriate or not. And now I raise the second question. How often does Rajiv or any other investor do this with the conviction to say, yes, we know that the quality is ABC. It's not just the problem with the investor. It's the problem that has crept into corporate healthcare and the manner in which we continue to live in this situation. So, in summary, and before I hand over to Rajiv, I would say, look at the cost, no doubt. Look at the finances, no doubt. But above all, keep quality as the foremost consideration in deciding the health of a healthcare institution. Over to you, Rajiv.
Thank you, sir. Before we started this conversation, in fact, it was Sanjeev who reached out and said he wants to have one con call because he wanted to set the expectations right and wanted to say how we definitely are going to be part of this conversation. So we both had a hearty laugh and we said, Sanjeev, the point is we are not going to keep any presentations. The data which is available today is available with everyone. We want to talk our hearts out and we would like to share our experience. That's far more important in a fireside chat rather than quoting certain data. That was important, and that's the reason I think we both are here. And Sanjeev also mentioned that after you guys open up, then he's going to open the boxing ring and he wants us to basically fight it out. He said, I'll ensure that you end up fighting. Okay, so we'll wait for the second round in the second bout. Having said that, just continuing on what Dr. Jairam sir said, I think if we are in healthcare, there are few non-negotiable things which we should take an account for, and quality being the most important part of it. And I'll give a brief background. When we started Marengo Asia, and incidentally, this is our third year of existence. It was in October 2020 when I got the company registered in an apartment where I stay in Gurgaon. We said, let's actually focus on few components which are there as far as the healthcare is concerned. Everybody speaks about those components, but can we create an organization which can deliver and can be measured? Today, sitting here, you can call me saying, it's too early for me to call out those, but I really want to be audacious in trying to say that, yes, what is our journey and what is our long-term goal? We said, let's create an organization which is focused on patient-first philosophy. Everybody talks about it. I'm 100% sure we can always organize a seminar. Everybody talks about how do we practice it? How do we bring this to measurability is the major focus area. 3 years from now, I'm happy to come back to the same stage and ask everyone to hold me accountable whether Marengo Asia has delivered that. I want to promise that, and that is where I think the differentiation is going to be, from the measurability of the patient-first concept on it. People spoke about the antibiotics, Sanjeev spoke about beautifully well on the infection control and other aspects. One of the foremost thing what we have done in our hospitals and organization, a continuous fight between the consultants and the manager is what medicines have to come into the ecosystem and what consumables, because everybody wants fancier stuff, because decisions are governed by who is going to Paris for a conference and who is going to Switzerland for a conference or Thailand for a vacation. Our objective was very simple. Are you going to use this particular medicine on your near and dears? If yes, they will be part of ecosystem. Otherwise, they will not be part of ecosystem. That is the mandate, and that's the simplest way we have defined the patient-first principle of getting the medicine and consumable in the system. The other aspect, what we said when we set up Marengo Asia, there are 3 A's on which people generally talk about is affordability, accessibility, and awareness of Indian healthcare. The most important component is accountability. We need to create accountable healthcare system. The time has come where we need to be held accountable by the patients, by the society, by the stakeholders, and even the investors. Then only we can change the healthcare ecosystem. On top of this, if we really are interested in the health of the ecosystem, health of the healthcare system, the only thing which is non-negotiable is delivering quality. I think that is the most important part. That is the only thing which will get us better investments, better results, and better outcomes over a period of time. Sanjeev, over to you. We are ready for the bout.
So those were very sweet talk. Let's come to our brass I was actually waiting for that.
There is an investment which an investor company has made.
Yes.
Now you need to either it could be a 1 year or a 2 year or a 3 year, whatever is your incubation period. And then there is a pressure which comes to the general managers and including to the clinicians. So those are Miss Universe statements which has already been made.
Absolutely right.
On the first round.
Absolutely right.
So how do we keep it patient first, and yet your investment has been made, but then you recover, but then there has to be a method to this all madness.
You want anyone up? Sir, I would always say you first and after that.
No, I agree with you, Sanjeev. The point really is, I think investors in healthcare have to be more realistic. And that is the first point that I would say. I don't believe that expectations of an investor should be as aggressive as they are today, because that is non-viable. If you take, for example, the valuations in today's world, are they realistic? Are they appropriate? Is that the right way in which we guide healthcare? Look, globally, there are so many examples of other nations where they are, of course, positive on the bottom line and the balance sheet, but they are more realistic in terms of A, the number of years it takes for them to recover their money, B, the percentages that they expect and hope for, and C, the manner in which healthcare is delivered. Now, why do I say the last point? I say the last point because time and again, the aspect of trust deficit has been brought up to us as a strong focus of Indian healthcare. And the reason for this could be very many, lack of accountability for sure, but it is also the lack of adherence to evidence-based protocols and practices. This is of paramount importance. And we, at the stage in which we are going to see so many more young doctors coming into the fray. And it's time we introduce not only quality, but the advantages of maintaining quality to this group of people. So I would say that the investors have to be more realistic, and the medical fraternity has to be in greater understanding of the need to put in evidence-based practice.
Sanjeev, in fact, Dr. Nankumar is absolutely right. Maybe there is a time when everybody goes for auto correction, whether the valuations have to go for auto correction when the time will come. More so, I would just like to spend some time on few basic points. We are talking about only one aspect of the healthcare system is setting the expectations, valuations, and other aspects of healthcare. But I think are we also responsible for setting the wrong expectations? Are we the ones, as you rightly mentioned in the beginning, whenever you see the hospital manager, the first thing before he says good morning to you is basically saying my EBITDA is 26%. Have we changed the language of healthcare system is far more important for us to understand. We do not discuss quality. We do not discuss patient experience. Have we moved away from those things? And are we only glued to one component saying, whenever you see me, just call me with the number EBITDA, and that will give me the smile on my face. So I think we also have to change the ecosystem in which we operate. We have to change our internal milieu. That's important part of it. How many times managers, and we all have lived that life, I think we spend time in trying to deep dive and understand the problems which are arising because of the patient experience or because of the infections or because of other things. Have we become reactionary? Are we not today process oriented? Are we forgetting just about delivering certain numbers, earning the bonus points and going away? So I think if I look at 360-degree of this entire thing, everyone has to live. It means somebody is setting a wrong expectation. Somebody is not giving a realistic picture to the investors saying, guys, this will require this much of time for maturation. You cannot have this before that. That's part one. Be audacious in trying to set the expectations right. And at same time, it is the responsibility of the people on the ground
to ensure that they do a deep dive. Today, majority of the issues today, what we are talking about is mainly because we are not holding people accountable on the ground. How the medical antibiotics are abused. Why not somebody who's supposed to be the medical head of operations is not taking care of it? Do we have the infection control process? What actions are we taking about? Are we scared of taking action on a doctor if he is literally pumping in antibiotics which are against the medical principles? So I think we all need to take those corrective actions, then rest of the things will fall in place.
So I think offense was the best way of defense. So for you, the offense was towards clinical team that they need to use antibiotic properly. But I'll still come back. Private equity players are changing the the dynamics. What if they invest right now? Possibly, my internal hypothesis would be that they are unable to invest anywhere else. They find healthcare possibly attractive in Indian setup. They're investing, and then after 2 to 3 years, they de-invest and go to some other location geographically or to other business. What happens to the Indian healthcare system now? Then, what is happening now, and what is going to happen then, sir?
That is unlikely to happen. And I can tell you that for sure. We all need many more institutions to deliver healthcare in this country. And the majority of them would be in the private sector. I'm sure everybody will accept that. There isn't any doubt that this is the way of the future. It is also fair to say that it is an important part of the economic growth of this country. If you take these two statements and the fact that money is going to be available in greater amounts within the country, investors in healthcare will stay. But I see a correction in the expectation of the investor happening, and hopefully at that, and returns of the kind that they expect today will not sustain. There is one other strong soldier, or maybe general, or maybe army that I can tell you is looking at us, and that is the insurance industry. Whether it is an Ayushman Bharat or private healthcare insurance, it is possible that the insurance industry wakes up and starts adhering to evidence-based protocols, practices, and insists on it for reimbursement. And that in turn will create a milieu interne, which is much better, which is much safer, and which is less expensive.
I think, Sanjeev, the investments will continue to happen. And I think the size of the country and the population and the people who are still to address. And there is a segment, there is a missing middle segment we continue to talk about is 40 crore people are into that missing middle segment. And there is a population which is definitely going to change their economic strata over a period of time. It means that there will be always captive set of people who will require private healthcare. These are the people today, they may be going to the government setup, they may be the beneficiary of Ayushman Bharat, but as time progresses, they may like to go to a different set of hospitals. So the investments will continue to attract. Our size and scale is something which is far more attractive to the investors because it means there is always a captive audience. And I keep saying one thing, that healthcare is a giant wheel of economy. It itself is a giant wheel economy. It is not only the doctors or the nurses, but if you look at the entire ecosystem, whether it's medicine, consumables, it is right up to the people who are in your neighborhood. You are driving a different segment of ecosystem, which is for a financial ecosystem. To collapse that, it's not possible. It's a good investment, to be very frank. And over a period of time, people have realized this is something which is there to stay. It's more of a recession-proof industry over a period of time. The returns may get subdued for a small period of time, but they will never evaporate. So the investments are definitely going to increase in this country.
Sir, we would like you to agree, disagree, or bombard with newer information. Yes. They may soon come to diagnostics also.
see, it seems that you're saying that it's a very attractive proposition for private equity or investors to invest in healthcare today in this country. What do you feel with Ayushman Bharat and with the fact that you talked about the missing middle, about 35 crore people? Actually, it's those people who pay you full when they come to the hospital. It's not Ayushman Bharat, it's not CGHS, ECHS, it's not even the nationalized insurance companies. All of them, I mean, would be below 50%. Maybe the insurance companies pay 55, 60. The private insurance companies pay about maybe 80, 85. But the poor chap who, you know, it's the poor chap or the missing middle is the one who's paying you 100 rupees when that's the bill. And maybe when he cries, comes to you, you may make it 95. Whereas you're doing for others at 40, 45. And it's this missing middle which is actually subsidizing those down the line. And when we say a PAT which is around 8%, 9%, he's the one responsible for it. Now, with the government very seriously wanting to bring these people into some kind of a health insurance scheme, which may be a co-pay scheme, you know, where the insured individual also pays something over and above. And maybe, you know, it comes into a CGHS kind of scheme or maybe something better than that. Then what happens? These people who are paying full are gone. Then how does your investment become attractive or stay attractive? What do you do then? Would you cut the salaries of the doctors and the nurses who are working in the hospital? Your other expenses are going to remain the same because government's not going to give you subsidy on electricity or land or building. So that's where personally I see we can talk about diagnostics also, but for the hospitals, I see a danger going forward. If this thing were to happen, still there may be 2% of the population who will still choose as to where they want to go, and and some percentage will remain in the private health insurance. But how do you think I'm just daydreaming or I'm an alarmist? Do you think this is possible? And if this is possible, why would anyone want to invest in healthcare? You know, also remember when the PMJ scheme was announced and Prime Minister Modi announced it, he said 2,000 new hospitals will be built. But what we are seeing currently is one large entity buying another and buying another, and really it's consolidation that's happening. Very few greenfield projects are on, and Sanjeev has done one, which is not for profit, and he's losing money hand over fist. So he can afford it because, you know, there's money lying which can still keep it going for another 5, 7 years. But what about a private investor?
I think very interesting point. And so there are multiple facets to your question, and I would like to actually, because there are, I would say, multi-layered questions which have come into this. One, what happens to the government scheme and then the investments and other aspects? Let me pick up one by one. The government schemes will continue to increase over a period of time because we all know all across the world, this is how health and education are two things which are there where people will continue to work on debate, whether it's you call it as a matter of politics or discussion, it will continue to happen. And this is not going to go away. This will increase, the percentage pie will increase. The other way to look at it, if I look at the announcement of Ayushman Bharat and other things, since the time that scheme has been launched, have the investors become scary about investing into India? Has the investments and the deal size have gone up? What is happening? There is one particular phenomena which is happening very, I would say, why? Because people have become conscious of the fact that the few hospitals on alone, in fact, Vishal spoke in the earlier session, where he said a lot of the hospital balance sheets are already, they are bleeding. The reason is whether it's a time of consolidation, like other consolidations have taken place in other businesses, I think that may be the way forward. Consolidation could be a very interesting phenomena which we may see, because that is where you will drive the cost efficiencies. Individual hospitals may find it difficult to stand alone over a period of time. They may not be able to deliver the required numbers which the investors they expect. Whether the consolidation may be the answer, that could be scenario. Other is how you use technology, harness the technology. So something, if the way we are running our hospitals today, we think after 3 years, 5 years, we continue to do this, I think we will never be able to make money out of it. Plain and simple. It means we have to change the way we are operating. The operating model has to get modified, changed, use of technology, use of efficiencies, integration, consolidation. All that has to basically be done if we really want to move to a level where we keep this particular segment attractive enough for the investments to basically pour in into this. Because there are things which are controllable, there are things which are uncontrollable. You can't control the government policies. You cannot control their pricing factor, when they will give money, when the receivables happen. So this is the problem this is the concern which you would have. The best is what can be controlled, work towards that, and then utilize what are my levers of controlling the business. I think I would actually take healthcare from that particular angle and say, keep it warm, keep it hot enough for the investments to happen. The internally change the milieu in which you are working, then only it becomes an attractive option.
I tend to agree with you, so no fight there. What I would say is that we are all coming into a system of high volume, low margin profits, and that is here to stay. It is also fair to say that I would imagine that with enough lobbying, the reimbursements from the government schemes will see an upward trend. This is inevitable. It has to happen. And we may reach, therefore, a level where it is a win and win with smaller margins. But I don't see definitely a lack of interest in investing in healthcare. That is not to be. And there I endorse what Rajiv said.
So, Dr. Lal, are you agreeing with their endorsement? They are becoming friends, which we are not happy.
I think any sector which sees investments coming in, would be very happy. But my point is slightly different. And my point is that as far as diagnostics are concerned, it is something like the Australian phenomenon. In Australia, if you were parked or passing over Australia in an international, space station, so what would you see? You would see lights all on the periphery, which means Perth, Adelaide, Canberra, Melbourne, Brisbane, etc. And you would see a very dark center. Now that's what precisely the problem with India is. That everybody wants to rush to the metro towns, the tier 1 or say tier 2 towns, and with different schemes. And in pathology, of course, you've all seen that since the entry barriers are minuscule, they are non-existent. So anybody, anytime, anywhere can open up a lab. And the people have been telling, right on our faces that we want to become like Dr. Lal. Now you spend 70 years in the damn profession and then you come up and then we'll talk. That's a very simple answer. But the get rich quick kind of a thing, that what you are seeing, and to get the investors always buzzing around you, and there are no profits, and they're losing money, and they are losing cash burns kind of a strategy, and yet the investors are coming in. Now this is a dangerous kind of a phenomenon, and this is what one has to guard against. You can say very coolly, how does it make a difference? Business will find its own water, etc. But they're ruining the business. Can you imagine that, like a Zomato or like something else, people have been advertising that we'll send the person within 10 minutes or 15 minutes, within 1 hour, we'll give you the report, etc. Now, has pathology been commoditized to such an extent? It's like selling, soap and shampoo, etc. So I don't know. But what I can see very clearly is that there has got to be a correction. That's part number 1. Point number 2 is that, yes, there are international and national investors who have got, money, and they would love to invest here rather than say anywhere else. Say now they're not interested in China that much. Otherwise, they were all running to China. So now they're coming to India, but the Indian system has to correct. There is overvaluation, and there is not, something of the, the bottom line is the EBITDA margins, etc., etc. So you've got to go through it in a calculated kind of a rational manner and not irrational manner just because you want to buy something. And then, who's going to pay for it? I gave you the example of the new guys who are coming into pathology. It's a cash burn strategy. To acquire a patient, God knows they're spending, hundreds of rupees. But the investors don't care. Now, this kind of, since I'm not an investor, so I don't know this phenomenon, but this is, kind of a sadomasochism. That this is a theek hai, abhi tak chalta hai. And the guys, so I hope that correction comes in. The second part is the government part. And the government is hell-bent on, twisting your arms in bringing the prices down. Now, what could be said? We were the first ones to be called by ICM at the time of RT-PCR for COVID. And we showed the cheat sheet to, Dr. Balram Bhargav. And he agreed with us. He says this test can cost 4,500 rupees and even more. And what has happened ultimately? 300 rupees. So from where you started and where you ended, yes, some kind of a correction, things were not available initially and etc., etc. Let's not go into all that. But the government and especially each state government is out to make a point that, see, Punjab did it for 500, Haryana has done it for 300. So, that kind of a thing. So that kind of a competition is going on also in the states. But thankfully, COVID is over. So now you talk about post-COVID. Everybody has made a lot of money, especially in testing, not to talk of the big hospitals, etc. That phase is over. We took some time to get back to the pre-COVID level, that crossed that. So hopefully our bad times are over. But the new kind of the testing which is coming in, we have absolutely no idea. Should we go to the interiors? Should we go to that 30 or 40 crore people who are on the upper middle class or the middle class who can afford to pay, etc. So that time will tell. Thank you.
How do you address the restlessness?
I rather than restlessness, first I think your attempt of trying to tell these two gentlemen to make us fight has not succeeded because they both are friends and Dr. Lal is my college senior, so you exactly are dummy. Okay, so that's part one of it. And Dr.
Always
Mahajan
helps.
Dr. Mahajan has been a great friend. Anyways, coming back to I think the restlessness part again, this is something, as we said, we are in the time where we are witnessing a change. There is a course correction which has to happen. I think there is no doubt in minds of everyone, and when we have our conversation with investors, everybody understands that, as initially Dr. Nankumar said, that the valuations today are sitting at a high which is unreasonable, difficult to sustain and maintain. It will put unnecessary pressure on the people who are working on the ground. The reality has to kick in. It's a matter of time, what time it kicks in. Most important is that whatever time it happens, but make your hospitals sustainable, profitable, and maintainable. I think that is the most important part. Gautam spoke about the healthy balance sheet. So I think the point is you do a good exercise, maintain a good nutrition, and you have a healthy balance sheet. Valuations and other things will fall in place. Because it's too early for any of us to say what will be that correction, whether the correction is going to be X percentage. But everyone, I think, in this room agrees their valuations are high, again, compared to the other kind of metrics, not sustainable. And over a period of time, the time has to come for auto correction, I think.
Right. I will actually take a point from what Dr. Lal said, and that is about Australia and the dark center. I think it is very appropriate to say that the growth of healthcare industry in India will be much more in the tier 2, tier 3 cities than in urban India. And that's very clear. It is also absolutely clear that investments and the cost of healthcare delivery in these has to be as low as possible. paying attention to appropriate infrastructure that is low cost and healthcare delivery that is low cost is imperative. And that is what will attract more investments into that segment. I would also stress that I see very strongly an opportunity for investments in new healthcare delivery models, which I think has been a study that KPMG has done. And while that is still in its incubatory phase, it is going to mature, and remote delivery of medicine, self-help, and the lot will go a long way in increasing the scope of healthcare delivery in rural India now than ever before.
And Sanjeev, if I may add, this model of low cost, low profit, but large volumes is untested in India. So, because you will be working on razor thin margins, exactly like what we've been doing for CGHS, ECHS, etc., etc. So, in many tests or many procedures, they were, in fact, we were losing a lot of money. So, this is a model, what Dr. Nand Kumar is saying, is possibly the future, but it is a dangerous future. So, let us see how it works out.
Mr. Gautam and Dr. Panigree, any comments?
I have a comment where I'm going to agree with Dr. Jairam first, saying that, the problem in the hospitals, what's happening is that private equity money is coming, but it is coming and it is becoming visible to the employees of the hospital. Ideally, there should be a wall, iron wall between the investor and the people and the clinicians who deliver patient care. They should not be worried about whether money is coming from private equity, stock market, charity. How does it matter to them? Problem is, if we tell them that this is private equity money, and I link their behavior to like a clinician or somebody to a stock option or share price, then that behavior, it will drive the behavior. The money drives the behavior, and then quality is left behind. So my suggestion is, I am agreeing with Dr. Jairam that patient care should be number one, and forget about everything else. Money will follow. Second thing is, I think the private equity, the challenge is, and I'm kind of not agreeing with you, Rajiv. So is that, you cannot exist with a private equity money in a smaller setup. It is like a treadmill. If you caught it, if you want to make it a good quality setup, you will have to invest in that. You're not going to get returns. So you invest in that, then you have to buy another one and another one and another one. So it's a journey. So you will get more returns as long as you keep growing and accumulating other assets. So ultimately, private equity is not, and I think one of the objectives of people like you is to tell them that if you want to earn 25 out of 100, forget 100. You want 25, you will get 25 out of 500. So that is something which is there. The problem, and I'm just going to re-emphasize that, maybe take your comment on that. What I mentioned about the payment model, the behavior inducing model, because if it is linked to price, returns, revenues, you will lose quality in a hospital. It doesn't matter. Word will get around that what Dr. Jairam said, that today this person has stopped 26%, tomorrow his junior and his junior and his junior, and then the security guard and the reception fellow will be saying, "Aap paisa kitna doge?" So I think you have to cut it at that level.
Can we have the last comment from Dr. Panik?
Yeah,
Sir, how's the behavior changed at the institute pre-investment and post-investment?
no, I'm just coming to the most important thing is that I think so. The bottom line is good medicine will get in good revenue. I think so. That's something very important. And Sanjeev, you mentioned about the quality part. See, yeah, good medicine will get in good revenue. That's the fundamental thing. And from taking back by what you were mentioning about quality, infection control, all that things. So I think the private healthcare needs to focus or keep a focus on that. EBITDA will follow. And now with the COVID pandemic that happened, the common man now knows about health. The government is also now sensitized. The engine has left the station now. as far as all these empanelments and subsidized healthcare is concerned. We can't, there's no going back. So we have to bear with that and see that what the sweet spot will be. How do we take care of the other segment, which is the cash and TPA? And for that, we have to keep a focus on good quality care. And as Rajiv was mentioning about seeing that our midline costs about the drugs, consumables, and all that, if you can keep that under control, the bottom line will be there. The other thing is that so if you want to go for high-end tertiary care and quaternary care, I think so scale is important. You can't sustain yourself with this empanel case business coming in with a high-end surgery of neurosurgery, oncosurgery, and all that, because you require high-end equipments there. But that scale is important. So if you have a scale there, as Dr. Jairam was mentioning, the volumes with low margins, that will take care of your running costs. And this is where your the tertiary and quaternary care which comes in, your transplants, oncology, neuro, cardiac, and all that, gastro. That is where you will get your sort of good GC things and get your EBITDA up. And the last part, which I want to just say because there's a lot of youngsters there, I think so we get too much caught on cardiac, neuro, and onco. For a secondary hospital, please focus on G3, P2, 1. G3 is gastro, general surgery, gynec. P2 is pulmonology and pediatrics. M is medicine. This will serve the community. I think so. We keep running around about EBITDA, this, that. This will serve the community. In your area, if you focus on these 6 that I'm talking about and focus on quality, your hospital will be the center for that community to come and attend.
Can I just add one? I wanted to say that this journey has happened in many sectors in India and abroad. But you see, the only people who have succeeded in the long term, investors have come and gone. The organizations which have existed are only people who have excellent quality, where the customer or the patient is first. So I think in this case, patient quality has to win. Investor, if they're unhappy, they will make a loss, that's all. But patient will win.
I think another sort of red signal is that we are getting too much caught in this EBITDA. And Rajiv, again, we give a rosy picture to this P investors. I think that between anything between 2025 is a very good EBITDA. People are talking about 28, 30, 35. I think that is because your fixed cost of your, when if you look at your personal cost, varies from 40, 45, sometimes it goes to nearly 50%. So how are you going to manage? So I think so this is rosy picture to the PE investors. I think so we are going into a sort of a slanging match with other competitors and saying that we can give 26, we can give 28, 30. So that is a trap that you're falling into.
I think the bottom line where we started, in fact, I would simply start from saying, I think let me just actually say what we agreed to and what was the story, and what I would also correct some misinterpretations, I guess, because I'm hearing certain points which I thought it's the right time to correct it. The first point is, I think quality, we said that is supreme. There is no compromise on it. This is non-negotiable without any doubt. Setting the expectations of the PE investor, the time has come where the investor expectations set. And I think the valuation corrections will has to take at particular time. And I think whether, so that you set the expectations right is very important. And it will follow its own course. And I think, as I said right in the beginning, and when I have this discussion with the investor, there is definitely some kind of, I think they are reaching to that particular level that these valuations are unexpected. That's part one. You can't make those margins which somebody would have made pre-COVID or that time, because there is definitely infiltration in a growing segment where the margins are thin. As Dr. Lalsa said, that you may be doing certain business where the margins may not be more. So I think these are the realities of healthcare today, most important. And I think important for us to operate the ecosystem is to take all the realities in this life, and say that these are the things which will be my driving force. The quality, patient first, without any doubt. I think that I would be very, this is something which is the mantra for us in our organization. Okay, so I just want to make sure and be there. The money and all this is an outcome if we have right process in place, supremely important. And that is the mantra which we continue to drive in our organization, that please focus on patient care. They are the biggest marketing tools for you. And if it happens, then everything will fall in place. Then the better EBITDAs, healthy investments, everything will fall in place. Time is for consolidation and the operational efficiencies. I think these are the few important points which we need to grow to make this organization and attract the investments in healthcare system. Over to you.
Thank you, Rajiv. No disagreement on those points. My statement would be, it is time that we create an environment to enhance clinical quality, ensure evidence-based practice, and appropriate care with accountability. This is something that we lack. And it is not something that we can just say is the responsibility of the NABH. It is the responsibility of each one of us. And I think there has to be a concerted collective action to achieve this if we have to see a good future for healthcare in this country.
Can I make a point, please? You see, all of us together, the government is attracting foreign investment day in and out. You see, the ads are there and the appeals are being made. The government is giving a lot of subsidy to these new startups. But when it comes to the purchase of the land for healthcare, I bought 3.5 acres of land 1990 for 65 lakhs. And I've purchased a plot of 1200 square meters for 12 crores. 12 crores. In Ayodhya, the new Ayodhya is coming, and the cost of land per acre right now, which I got the figures yesterday, is 21 crore per acre. That is the cost of the land, not only the cost of land. Then they are charging you the, what you call property tax. They are charging you the, what do you call it, lease money. Every year you have to pay the land. So the 3.5 acres of land, you have to pay 40 lakh rupees for the, what do you call it, the lease rent and the property tax. And the property tax is going with every passing day. Come to the electricity. We are being charged more than the commercials. The rates being charged to the healthcare are more than the restaurants and the hotels. Why? The minimum wages are going up and up and up and up. Everything is going up and up and up. If we have to give good quality and we have to be sustainable, not profitable, sustainable. Like I come from an NGO, you see, we run Dharamshila Cancer Hospital. So if we have to become sustainable, all of us together have to go to the government and say, ye land ki cost, ye bijli ki cost, ye what do you call it, property tax. Property tax is going like mad. It's going like mad. Double, triple, 4 times. The property tax is going up. So these are the major costs when a new investor has to come. Like we thought of making a hospital in Ayodhya. And when you hear the rates, you see, who is going to spend the money, that kind of money? So we have to go to the government and tell them to do this. And the second thing is that the government is losing money also, because I call the beneficiaries as the damads of the government. They are the damads of the God. उनको admission की जरूरत नहीं है, तो भी नहीं है, तो उनको चाहिए. उनको छुट्टी करेंगे, नहीं जाने को नहीं तैयार है. और कॉर्पोरेट हॉस्पिटल कहता पड़ा रहे, मेरा क्या जाता है, मेरा बेड खाली पड़ा है तो पड़ा रहे. So insurance companies and that, you see, those things have to be tightened. It's possible. It's very, very possible to become sustainable. I wouldn't call it profitable. Like we have sustained for 3 decades. We have sustained ourselves for 3 decades. But then now it looks like it is going to be difficult. The Ayodhya project, which I wanted to do, I don't think it's going to be sustainable. So we have to ask the government to give us the subsidies on the land, on the electricity, things, you see, main things that we have to.
Right. Point well taken. Yes.
Sir.
You will have to do half free.
वो आ गया जी, क्या कहते हैं, कल एडवर्टाइजमेंट आ गया कि लैंड की कॉस्ट क्या है. आई अप्लाइड फॉर 2 months ago. तो कॉस्ट आ गई है. आज मीटिंग हो रही है कि क्या उस योजना का नाम रखना है और उसके बाद क्या कितने साइज के प्लॉट काटने हैं, कितने के नहीं काटने, किसको देना है किसको नहीं. आज वो मीटिंग हो रही है. सो सस्ता वस्ता कुछ नहीं मिलने वाला.
So point
Sir,
well taken.
One point,
We
sir. Sir, sorry. See, basically, I was recently part of the GIC meeting and taking the cue from mid-40s. I think in the next 10-15 years of horizon, thing is we will be in a very bad phase. Looking at cash flows will be get affected. Margins will be like whatever the excitement of PE guys will go into thing. And definitely in next 10-15 years, it is not going to be very rosy thing because on one side, insurance is squeezing, other side, we were trying to accommodate. Our occupancies are not the same sustainable throughout the year. Thing is, it's going to be very, very difficult. It's not that rosy as investors thinks, and we are in the reality phase of testing phase is what I want to conclude. So basically, that's what.
Can I ask a question,
point take.
Dr. Sanjeev?
Yeah.
Yeah.
Where is it? Yeah. Last question.
Yeah, the question is specifically to Dr. Rajiv. He has got a new setup. Recently, two, three comments, because I'm from healthcare, so ordinary people ask me that, is this true? So there is a report that almost 40% of the CABGs are unnecessary and over 40 to 50% of the total knee replacements are unnecessary. This is from the Indian healthcare setting. So earlier in the day, there was a discussion about the trust factor. The trust factor affects me also because when I ask for any specific doctor to show one of my family, I use this word. Can you find someone who is not trigger hungry? Trigger hungry means ordering all kinds of tests before you can even tell what is your symptom and then immediately getting into an intervention. Is this because the investors are investing money and they're asking for returns? And Mr. Khanna mentioned about, revenue inducing behaviors. He was very polite in saying that because I've heard of doctors who left the corporate hospital because they could not meet the targets. I mean, these are the, some real and ugly truths that sometimes we need to discuss. It's very nice that Ficci is giving a forum for such a fireside chat. So I just wanted to hear Dr. Jairam said everything right and Dr. Raju started a new set of Maringo. So I would like to hear that whether he did something different to ensure some behaviors are, taken care of. Thank you.
I think report part, I don't want to comment because who are the authors? Yeah.
Thank you, Dr. Rajiv.
It's okay. Yeah. I said, I don't want to comment on the report, but I think coming back to what Gautam said and this thing, I think who has the responsibility of setting the culture of the organization, whether you want to drive your clinicians for the so-called target or that thing, somebody has to own up the responsibility. It's as simple as that. And I think the buck stops and somebody has to have that particular stuff saying that the buck stops at me. Now, today, when you set up an organization, and I'm just saying I don't want to tell into what other people are doing. I know my ecosystem, and that's the place where I can actually talk about it. So I would not comment on other people, what they are doing in life, the way how we want to drive this ecosystem. Do we have chats with our consultants on saying that the investors have put in money, I need more revenue? I think my operating team is sitting here. In fact, you can always ask them whether we have those conversations or not. It is completely no. There are no targets. Other day, I was recruiting a doctor for a hospital. He says, what are my targets? I said, there is only one target. Look after the patients who come into the system. That's the only target. Okay, this is the only line I have recruited more than 50 doctors in our hospitals over a period of time. They get surprised. Maybe there are views which people have, but this is the only thing. I have said this personally, and I have said this that nobody will talk to you about the target. So there is no question of this. And I think a lot of clinicians have joined us because they are thinking that, yes, this is something where the people are not going to chase them for the targets. And Sanjeev comes from Faridabad, a very close ally, so he's going to keep a close eye on me on recruiting people. So I understand Sanjeev organizing this session and planting this question through Thankam. Okay, so I understand that, but I thought when the war is declared, so I think all guns blazing, so perfectly fine. But this is how, Gautam, this is how we have done it. This is how we want to do it. This is how we want to practice. And that's the point when I made the opening statement. I said 3 years down the line, same podium, hold me accountable for that. What others are doing, I don't want to get into that. I cannot control. I divide my world into controllable and non-controllable. I cannot control what other people are doing, but I would like to control what Meringo Asia hospitals they will do. That is something which I would like to basically do that. That's the point.
Sanjeev, one final thing. I think one thing we missed out is MVT. That's a big support for most of the large corporate hospitals. And I see as more government-based insurance comes into this country, those high-end hospitals will increase the intake of patients coming from abroad. And that's how they will be sustainable and profitable.
Fantastic, sir. So very, very nice point, and I really enjoyed listening to both the point of views and both the stalwarts. Dr. Nand Kumar Jairam, it's always a pleasure to hear your point, and you're so passionate about clinical outcomes and the delivery system. And Dr. Rajiv, fantastic. You're doing so good, taking over so many hospitals. So exciting times or depressing times, we don't know. New age model or old age model success, we don't know. We will have to see whether Ayushman Bharat versus cash or other group of payers, we really don't know. We actually don't know how clinicians' behavior is going to change, or is it the new operational model which is going to bring in efficiency? We talk about more technology, we talk about more digital health, or we talk about what was mentioned about consolidation. So exciting times ahead. We will leave it at that. And thank you both for joining this and agreeing to participate. Thank you for fantastic questions. And thank you, Thankam, for the last penetrative, incisive question. And we invite you to participate and be part of that award ceremony, which would start at 7 o'clock. Thank you so much.
Thank you, sir. Thank you so much. Thank you, Dr. Singh, Dr. Jairam, and Dr. Singhal. Just some quick words. We start at 7 p.m. at the Meridian for the awards. Today, again, was extremely engaging sessions. Tomorrow morning, we begin at 9:30 with leveraging technology for transforming primary healthcare. On the MVT, I think I just need to suggest, Dr. Singhal, that Praveen here, sir, that you need to look at newer markets, because currently everybody is running to Bangladesh, which is pretty low rated. So we need to work on that strategy. But thank you so much and look forward to meeting you all in the evening at 7. Thank you.